For this session, I would like to invite Dr. Maheshwari, who is a professor and in the Department of Pediatrics at AIIMS Bhopal, and Dr. Sugandha Singh, who is an endocrinologist from Moradabad to dais.
Should be come.
The first presentation for the day.
So we have Professor Maheshwari, who is Professor of Pediatrics at AIIMS Bhopal and a very close friend for us for a long time. And we've got Dr. Sugandha Singh, an eminent pediatric endocrinologist from Moradabad. And over to the chairpersons, they will start the sessions from there.
Okay, so good afternoon to everyone. Thank you, Dr. Anurag, for giving this opportunity to start the section. And I think, as you told, this is a marathon session in the next 2 days. So we need to start with some interesting cases. In next 1 hour, we are going to start some interesting cases. First of all, I invite Dr. Vidhu to start her first case, infant with developmental delay. Just a guideline that we need to try to complete it within 8 minutes. So there will be some 2 minutes for discussion is available.
Thank you, sir. Okay, this one down, huh? Only this one. Okay. Good afternoon, everybody. Before starting, I would like to thank Anurag, sir, for the beautiful classes he's taking for us and the experience every time we come on site. So thank you, sir, and for this opportunity to present a case over here. My case is actually about an infant with developmental delay. This is for our endocrinologists, it's a common case you might be seeing, but in medical colleges and in pediatricians, a little awareness when we see children with developmental delay, an infant or a small child, sometimes we have to look into the matter and think a bit different also. I hope you will like you will understand and keep this in mind. Thank you. So going to the presentation. So this boy actually came to us when he was 1 year and around, he was going to be about 2. The informant is his mother and grandmother, and it's reliable. So they had actually saying that he has developmental delay, which they had noticed from his 7 years of age. From then on, they had been to doctors, and every time it was informed to them that the child will become better over time. So they had waited all this long, and then they actually came to my professor, Dr. Babu Francis, and I'm very thankful to him that he allowed me to work up in this case, and then I'm able to present this over here. So he came to sir, and when we are seeing the child, we have seen a child who has failure to thrive. So obviously this child is very small for his age, and his weight is also down. And at the age of around 2 years, he was unable to walk. But otherwise, he's able to sit, and then he speaks a few words. But obviously, he has GDD. And the history that is going to strike us when the mother and grandmother repeats on saying is, this child keeps on asking for water. We have the bottles, right? The top of that. He has a small thing on his hand, and he'll keep on asking for water every minute. You are standing near him. He keeps on asking for water. To the extent they are scared because he's always overflowing. His diapers are always overflowing. So they do not want to give him water, but he keeps on asking for water. This is the typical history that they have given from almost 1 year of age from the time they are reaching us. So by history, when we take, obviously, I said developmental delays there, and he's hypotonic, and he has the weakness. I already said that he's not unable to walk. We couldn't find any other neurological deficit. I meant the cranial nerves. And there is clear-cut history of polyuria, polydipsia. He has a relative constipation. He wasn't gaining weight. And they also say that he always tries to avoid salt and sugar. By nature, he's always trying to avoid that. And by past history, when we actually asked whether he was admitted for unexplained recurrent fevers, We wanted to see whether dehydration, he got admitted. They didn't give us a positive history like that, but they have been to doctors. That's it. Antenatally, we didn't get anything suggestive, nor in the family also. This is a family tree. There was nothing suggestive of a similar thing they haven't seen in their family. He was immunized, and then like not much of a positive thing got over there. So to summarize, this is a 2-year-old child who is firstborn of non-consanguineous marriage, and there was no significant antenatal history or postnatal history, with failure to thrive, polyuria, polydipsia, aversion to sugar and salt, with developmental delay, more on the gross motor area. Now coming to the examination part, you can see that he is a hypotonic child. So the posture, just to say about the posture, and these are the vitals, and developmental delay is there. I'm just rushing through just the important points I'm just mentioning. Okay, so his weight is 6.5 kg, height is around, length is around 73. With head to foot, we felt a slight high arch palate is there and round to faces is there, but like we cannot call him syndromic as such, but a few features we had felt at that time. Otherwise, overall, he looks normal. This is the chart depicting the same thing, that he has failure to thrive. CNS examination. The CNS examination about cranial nerves and things were normal. He has mild hypertonia is there. Other systems were also relatively normal. So now I'll go to the, so these were the differential diagnoses we were thinking about. And now coming to the investigations. So investigations, when we did the serum sodium, it was 159. And serum osmolality is 310. Urine osmolality is 164. Urine specific gravity is 1005. So with this, we wanted to do a water deprivation test, but we couldn't do it because overnight it was very difficult to him to maintain him. So we couldn't do it. And with this is just, with the sodium and all these levels, actually we could make out the case. And the ABG was also done, which was normal. Routine, he was anemic, and rest of the systems were almost normal. So now we are thinking about diabetes insipidus, and karyotyping was done for me, and that was normal. Ultrasound was done. Then actually for the first visit also, this was suspected and genetic test was sent. So we didn't have to, usually in our place, we will send and we have to wait for another 1 or 2 months for the report and then to treat. Maybe like we'll have to treat him earlier. But here within a 2-3 weeks gap, we actually got the result also. As you see the result, this is because he has, what I wanted to mention is, because he has this developmental delay and all these things, whenever he comes, the PGs take him for CNS case, right? So it was always getting missed. So only to highlight the fact that it was actually nephrogenic, even diabetes insipidus, it was nephrogenic diabetes insipidus with the result coming as X-linked recessive 1, V2 receptor defect it was. And hence we had started IMHOM. So for such a child, we should actually have a holistic approach. So we were actually counseling the parents, saying to them what actually has to be done for him. And we have to, because I said he's keeping on asking for water and it is always there in him. So slowly we had to optimize the fluid, and he was nutritionally deficient. So the calories, everything we had to raise a little, and we could do it very slowly. Now also we are trying our very best, very slowly. So ideally, we have to optimize the fluid intake, provide calories without much an osmotic burden. These are the things we should keep in mind. But as per the patient, it is slightly difficult. High calorie density feeds, we have to restrict the sodium. Low protein diet has to be governed. And whenever he's voiding, he has not started voiding on his own. So ideally, we should train them to frequent voiding, double voiding, all the stones. And the main thing is we have to maintain the euvolemia. We started him on a combination of hydrochlorothiazide and amiloride. So hydrochlorothiazide will actually help us to reduce the urine output, and the hypocalcemia and the other features can be controlled by the amiloride. The combination we are giving is Kespar 50 by 5. We are giving a half tablet in dilution 2 times a day. And after 2-3 weeks, when we repeated, the sodium had come down to almost 140. And over this 3-month period, clinically, he is improving. Right now, he's able to stand up and hold. And parents feel he's much better, and his values also. We are just trying to continue on that. It has just started the process. Thank you. Thank you for the patient listening.
Thank you so much, ma'am, for the amazing talk, please. Yeah.
Thank you, Dr. Vidhu, for that crisp presentation. It's a common scenario. We get that children with GDD, as you mentioned, are in medical colleges. They are taken to CNS examination. And I think from the case, it's well highlighted that there can be other CNS causes of developmental delay. Thank you so much for that presentation.
I would like to request Dr. Vibha to hand over momento to Dr. Vidhu, ma'am. Ma'am, please wait.
So if there are any questions also, we will be taking up. So anybody would like to give a query on this? And anybody online also can please, can please feel free to raise the questions. We'll be happy to answer that. Yeah. So the next. So this was a very interesting case. Now I'll hand back.
I think the message I wanted to give from this particular case, because this is actually not a global developmental delay, it's primarily the gross developmental delay in the gross motor fields. So that is secondary, and this is the reason he responded with the initial treatment. So that you need to take care. Don't label every child as a global developmental delay, and then just like every PG will take him to the case discussion. So the next case will be unusual hypercalcemia. I invite Dr. Arpita Bragwanshi to present her case.
So Dr. Arpita is working as a professor in pediatrics at KGMU, and she has been involved in pediatric endocrinology training for quite some time. Welcome, Dr. Arpita.
Thank you so much, sir, for this opportunity to present a case in this conference. So I will be presenting two cases of hypercalcemia. Very unusual. One is at infancy and one is at adolescence. So two extremes of age group presenting with hypercalcemia. So this 4-month-old baby came with the complaints of failure to thrive. There was often on episodes of fever, which the mother was complaining, which were measured and documented. There was also history of lethargy and feeding difficulty, which the child was complaining, and there was increase in the frequency of micturition and crying during those micturition episodes. On the antenatal and natal history, he was a full-term vaginal delivery. Birth weight was towards higher side, to a G3, P3 mother with no other history. There was history of perinatal asphyxia, for which the child needed an ICU admission for 4 days. However, he did not need any ventilatory support or any other major treatment on that part. There was no family history of hypercalcemia, renal calcification, and parathyroid surgery. There was no history of exogenous vitamin D or vitamin A, lithium, thiazide, and retinoic acid administration in this child. So with this kind of a picture, with these complaints, we had the possibilities of sepsis, UTI. Being in a medical college, we kept these possibilities before the investigations came in. And there was also a possibility of electrolyte abnormalities, hypercalcemia, neonatal diabetes, and rare possibility of immunodeficiency. So this was the patient. So there was generalized wasting, stunting. There was some syndromic phases in the form of triangular phases and retrognathia. However, there was no phenotypic picture of Williams syndrome. On the back examination, there were firm nodules on the back, which the mother did not notice, but on asking her, it had been present since day 4 of life, once he was discharged from the NICU. So there was wasting, stunting, microcephaly, and in the anthropometric examination. On further workup, the sepsis screen was normal, the blood glucose was normal, the CSF was normal, the serum calcium was very high, 15.07 total with the INA of 9.52. Serum phosphorus was towards higher side, which tells us that it was due to vitamin D related and not PTH related cause. ALP was normal for this age and kidney functions were normal. On further workup for hypercalcemia, the PTH was in the normal range. 25 hydroxy vitamin D was also normal, and 125 hydroxy vitamin D was towards higher side. The spot urinary calcium and creatinine ratio was higher, to the tune of 2 milligram per milligram. And USG KUB was done, which showed nephrocalcinosis in this child. So with this picture of high calcium with high phosphorus and normal PTH, we will be thinking on the lines of vitamin D related causes, which can be in the form of vitamin D excess, which may be due to exogenous or 24-hydroxylase deficiency, which presents as a idiopathic hypercalcemia of infancy, or syndromic, where Williams is a possibility. Another possibility will be 1-alpha hydroxylase excess due to fat necrosis, sarcoidosis, or tuberculosis. And the least possibility was hypophosphatasia, because ALP was normal in this child. So I'll quickly run through this algorithm of hypercalcemia. Because the PTH was low, we did the 25-hydroxy, which was normal. So we did the calcitriol, which was towards higher sides. So now our possibilities are fat necrosis, tuberculosis, sarcoidosis. So on general examination, there were no clinical pointers towards tuberculosis. Sarcoidosis does not have a presentation at this age. So we are left with fat necrosis. And if we go back, we have a positive perinatal asphyxia history, and general examination showed those firm nodules. So it is definitely a case of fat necrosis. So we treated the child with normal saline bolus, followed by double hydration, along with IV furosemide, and prednisolone was started at the dose of 2 milligram per kg per day, which was continued for 6 weeks. And gradually the serum calcium levels have come normal at 6 weeks, and we stopped the prednisolone at 6 weeks. And the child is doing well and is gaining weight. The developmental delay part is still persisting, probably due to the asphyxia component. So this was the first case. Now proceeding to the second case, that was a 14.5-year adolescent who came with the history of 5 years history of loss of appetite, and he was also presenting as failure to thrive. The father was saying whatever he eats, he does not gain weight, and there was short stature. There were chest deformities since 5 years of age, and localized swelling in the neck since 1.5 years, and genuvalgum since very recent 5 months onset. There was no history of fractures, polyuria, respiratory difficulty pointing towards no acidosis, no constipation, no encephalopathy, and there is no family history of hypercalcemia here too. So this is how the child looked, with severe chest deformities, and the genuvalgum is quite evident, and there was a localized thyroid swelling which was cystic on palpation. And there were no marfanoid features, no bumpy lips, which was seen in this child. So this was the anthropometric, where the child was having wasting with stunting, but the weight age was more affected, and the X-ray showed sarcopenia and erosions and scalloping-like features due to low phosphorus. So the clinical possibilities with any adolescents presenting with skeletal changes and failure to thrive here would be hypophosphatemic rickets, or distal RTA, or hyperparathyroidism, which may mimic rickets due to low phosphorus. So we worked on those lines. The counts were normal. There was mild anemia present. LFT was normal. Alkaline phosphatase was very high, and serum calcium was very high in this, to the tune of 19.5 milligram per deciliters, and ionic was also high. The serum phosphorus, as seen, is very low, pointing towards a PTH-related causes and not due to vitamin D. Kidney functions were normal. So for the further work for hypercalcemia, the serum PTH was very, very, very high. 25-hydroxy was towards higher side also. Probably this child would have received vitamin D in the periphery due to the skeletal changes. The spot urinary calcium creatinine was high, and USG KUB in this child did not show any nephrocalcinosis. The BMD was low, less than -2 standard deviation, and USG thyroid showed right thyroiditis with cystic nodule. FNAC showed Bethesda category 3A, atypia of unknown significance, and thyroid functions, prolactin levels were all normal in this child. So at present, he did not show any features of MEN1 and MEN2. So the clinical possibilities with hypercalcemia and hypophosphatemia with high PTH are only few. It is hyperparathyroidism or calcium sensing receptor defects, because calcium sensing receptor defect does not have skeletal changes, and if it is severe, presence in the neonatal age group, we were concentrating on the hyperparathyroidism part. And usually in the adolescents, it is like a multifocal disease. So he's still awaiting MIBI scan, but it is not a necessity in this child. So we treated the child with normal saline bolus, followed by double hydration. IV zoledronic acid was also needed, and we put the child on oral cinacalcet, and gradually the serum calcium levels were coming down, and it could come down only on day 7. Still, the child is awaiting for his surgery, and he is on oral double hydration and cinacalcet and is doing better. Thank you. We already know the approach to hypercalcemia. So this was high PTH and urinary calcium was high. So we are thinking about hyperparathyroidism. So the key message I would like to say with these two cases is that there should be a high index of suspicion of hypercalcemia in any neonate which presents with failure to thrive and non-specific complaints. Thorough clinical history examination and complete biochemical evaluation is essential. Subcutaneous fat necrosis should always be seen in the setting of perinatal asphyxia. Hyperparathyroidism can mimic rickets and should be kept as a possibility. So with that, I end this. Thank you.
Nice presentation, Dr. Arpita. Is there any questions? Yeah, please, Dr. Samina.
Very well presented, Dr. Arpita. Just wanted to ask that subcutaneous necrosis, often sometimes we see in a baby, but they're not often associated with hypercalcemia in all the cases. So is there a...
This was the first case I saw with subcutaneous fat necrosis with hypercalcemia. Yes.
So basically, subcutaneous necrosis, you will have more expression of 1-alpha hydroxylase. Now, how much is expressed? How much is the granulomatous tissue? So it's not that every subcutaneous necrosis will develop hypercalcemia. The more message, I think, very well put by Dr. Arpita was that phosphorus is the most important investigation in the setting of hypercalcemia. If your phosphorus level is high, that means it's basically a PTH independent / a vitamin D dependent cause. If the phosphorus is low, it's a PTH dependent cause. I think that will be there. So you need to worry about getting a calcium done in subcutaneous fat necrosis, but not all will develop hypercalcemia.
And how long will the nodules remain, sir?
Nodules may remain for some time because they're dead tissue. So they will remain for some time, but the active granulomatous tissue may go off in some time. So steroid therapy is somewhere around 2 to 8 weeks, depending upon the clinical scenario.
And the vitamin D supplementation has to be withheld during...
Absolutely. So because then all your vitamin D will be converted into calcitriol.
And then reintroduce calcium. Thank you.
I think the second important point was with regards to the hyperparathyroidism. Most children, and in fact, people who are below 18 and 30 years of age, they have a multifocal disease. So I think we were discussing that the scan was not done in this case. Scan is actually not going to help you out. Ultimately, it's a multifocal disease. You might have to remove nearly the whole of parathyroid. So we don't get much benefit of scan below 30 years of age. I think that will be an important thing to remember. And men association, again, will be very less likely in this case, but we have to be a bit aware about that scenario. It's usually in the second, third decade that you start having those scenarios.
Thank you.
What are the chances of recurrence of fat necrosis?
Of fat necrosis, usually they don't recur. It's just that you stop the treatment early, they may come back. But otherwise, the necrosis, they will gradually die down its own course. Thank you. So we'll move forward, Dr. Sugandha, the next scenario.
I would like to call upon Dr. Dhwani to present the next case, a case of unusual hypocalcemia.
Thank you so much, ma'am. So now that we've seen a case of hypercalcemia, we'll be seeing a very interesting case of hypocalcemia that we've encountered in our clinical setting. This child presented to us at 8 years of age with history of tetany, carpopedal spasm, and multiple episodes of seizures. These episodes had started at 2.5 years of age. The first episode was encountered following an acute febrile illness, during which the child developed episode of seizure. He was treated as a case of febrile seizure, received multiple antiepileptics, but remained refractory. The seizures remained refractory to management, following which a calcium level was done, which revealed hypocalcemia, and the child received IV calcium. Similar recurrent episodes were noticed during episodes of fever, according to the parents. And for these complaints, he received a long-term duration of oral calcium and vitamin D supplements. And yet, with febrile episodes, the child kept going into tetany, requiring IV calcium administration. The parents also gave a very classical history of recurrent oral candidiasis since about early infancy, about 8 to 10 months of age. The child was born at term with a weight of 3 kgs and had a smooth perinatal transition. Had initially mild motor delay to begin with, but had caught up with the milestones. He was immunized for age. Now, the interesting part of the history comes with the family one. The parents were married within the same caste, but not closely blood related. There was history of similar complaints of hypocalcemia in maternal uncle who passed away at about 3 to 4 years of age. This was the index child was first born to this couple, and there was history later on of similar complaints developing in the younger sibling. I will elaborate on the rest of the family history as I move on to the course. There was no history of failure to thrive, no suck cycle to begin with, no other infections other than the candidiasis that the child frequently had. No episodes of frequent colic pain, poor appetite or nausea, no bony deformities as such, and no opacity is noticed in the eyes. On examination, this child at 8 years of age had a fair height and weight. He had an SMR of TV2 CC bilaterally and pubic hair stage 1. Had oral candidiasis on examination and dystrophic nails suggestive of onychomycosis. He had a positive Chvostek and Trosto sign on examination. There was no cataract, no dental abnormalities, no lumps or bumps suggesting an ectopic calcification, no hyperpigmentation, and no evidence of dehydration was noticed. So if we summarize the case, the predominant features that are coming out are refractory hypocalcemia, or if I say recurrent hypocalcemia, oral candidiasis, and nail dystrophy. If you summarize this is Potter case, you will think of APES or APS1 here. Theoretic possibility of George may be considered in view of early onset hypocalcemia and fungal infection, which will suggest a T cell defect. However, these children often have much younger age of onset, will have classical syndromic features. So, I'm sorry. So if we, APS1 is an extremely rare disorder. Even in the high-risk groups, the prevalence is about 1 in 25,000. And the estimated prevalence in or incidence in USA is about 1 in 1 lakh. The age at manifestation varies from 0.2 to 18 years, with the mean age at diagnosis being 7.5 years, which is, I'd say really sad because the presentations start much early. It is inherited in an autosomal recessive manner or in a dominant negative fashion. And because of this kind of inheritance, there is no gender preponderance seen with this condition. The basic pathophysiology in APS1 is a loss of function mutation in the AIRE1 gene, which is responsible for central immune tolerance. As a result, autoreactive T cells spread out to the circulation and infiltrate all the other organs, and therefore cause autoimmune destruction of these rest of the organs. Now, these manifestations may be endocrine or non-endocrine. Common endocrine manifestations include involvement of the thyroid and parathyroid glands, adrenal glands, pancreas, and the gonads. Common involvement of the extra endocrine manifestations, if I may say, are dental enamel, nails and skin, intestines, the salivary glands, liver, lungs, and the kidneys. Whenever you have a T cell defect, you will also have a B cell defect resulting in autoantibodies. So the common endocrine autoantibodies that you may encounter in children with APS1 are antibodies to the calcium sensing receptor, anti-TPO antibodies, antibodies to 21-hydroxylase enzyme, the GAD65, IA2, and ICA antibodies, which may help predict the occurrence of type 1 diabetes in these children. The classic pathognomic or the, if I may say, diagnostic antibodies are the immunoglobulin G to interferon omega. So the workup in the index child revealed hypocalcemia, hyperphosphatemia with borderline low magnesium and a normal creatinine level. So if you go by the algorithm, hypocalcemia, high phosphorus, if your creatinine is normal, you look at the PTH levels. Now, PTH levels were low for the level of calcium here. So this points to hyperparathyroidism. As we were considering the possibility of APS1, we went ahead with screening for adrenal insufficiency, which was which we got normal electrolytes and cortisol levels, and thyroid function tests were normal. So now we have established that this was hyperparathyroidism. And the urine calcium creatinine ratio was slightly on the higher side, 0.14. With all these manifestations, we went ahead, and the positive family history, we went ahead with genetic workup in this child, which revealed an autosomal recessive AIRE1 gene mutation, which corresponded to the clinical picture of this child. Now we need to know what made the diagnostic delay in this particular child. So if you look at the guidelines for diagnosis of chronic mucocutaneous candidiasis, such children need to be screened for endocrine disorders based on clinical setting, especially for AIRE gene mutation when you have patient sibling affected with the same disorder. Also, the guidelines for management and diagnosis of hypoparathyroidism suggest that if you have an early onset hypoparathyroidism with a positive family history and the occurrence of recurrent candidiasis, do suspect APS1. Had the individual picture not been seen and the child seen as a whole with candidiasis and hypoparathyroidism, the diagnosis could have been made much earlier, maybe as early as the first episode of hypocalcemia that the child presented with. Now, understanding the management of APS1. So, the three classical manifestations are the hypoparathyroidism, mucocutaneous candidiasis, and adrenal insufficiency. For management of hypoparathyroidism, you give high doses of calcium and activated vitamin D to these patients. You monitor their calcium creatine ratio so that they don't go into hypercalciuria, developing nephrocalcinosis and CKD. And if the phosphorus levels are high, you need to give phosphate binders there. For mucocutaneous candidiasis, each episode must be aggressively treated with azoles, and if refractory, caspofungin needs to be given. If these episodes are frequent, more than 3 to 4 episodes per year, an antifungal prophylaxis in form of amphotericin B solution as a swish and swallow needs to be given. If not treated aggressively, these children develop an increased risk of digestive tract squamous cell carcinomas. Adrenal insufficiency needs to be, before management, you first need, because it is a later manifestation, you need to screen for adrenal insufficiency regularly in these children. The first manifestation of adrenal insufficiency will be a decreased requirement of calcium and calcitriol. Management will include hydrocortisone and fluorocortisone replacement, and one needs to monitor serum electrolytes in these children. So management of the index case for hypoparathyroidism, the child received calcium and calcitriol supplements slightly on the higher side. Even with these supplements, the child developed recurrent episodes of hypocalcemia requiring admission for IV calcium administration. Now, the target or the goals of treatment for hypoparathyroidism is that you prevent hypocalcemic crisis while balancing that the child does not have hypercalciuria and prevent the risk of CKD. So the calcium targets are usually on the low normal range. And on follow-up, we found that the calcium creatinine ratio had risen to 0.34. However, ultrasound had not shown nephrocalcinosis at serial follow-up. Challenges with managing hypoparathyroidism, although clinically and biochemically, hypoparathyroidism in APS is not very different from any other cause of hypoparathyroidism. Multiple case reports have been published which describe an increased requirement of calcium and calcitriol during acute illnesses. To quote one of those case reports, this is recalcitrant hypocalcemia in autoimmune enteropathy. So this was a 14-year-old patient. During episodes of diarrhea, it became difficult to maintain his ionized calcium despite high doses of calcitriol and calcium. Moreover, with increased calcitriol doses and ongoing hypocalcemia, the phosphate levels increased, which made the management more difficult. So what makes APS1 hypoparathyroidism different from the others is the involvement of so many other non-endocrine organs simultaneously. Chronic diarrhea and malabsorption occurring as a part of the APS1 syndrome predisposes to bacterial overgrowth, celiac disease, intestinal infections, and pancreatic exocrine insufficiency. Hypocalcemia, as we know, is an enzyme. It's a part of multiple enzymes as well. So hypocalcemia per se also causes malabsorption through reduction of cholecystokinin, decreased gallbladder emptying, and pancreatic insufficiency. Although adrenal insufficiency had not developed in our patient, but in those that have them, Glucocorticoids reduce intestinal and renal calcium absorption, especially when recurrent stress doses are needed. High dose of glucocorticoids are given, the calcium absorption further decreases. And this is what increases the calcium requirements during acute episodes in these children. So when you know the primary pathology is hypoparathyroidism, do you think PTH is a superior therapy to what we are providing in these children? The problems with conventional therapy is that it is basically a symptomatic management. If it's hypocalcemia, you give up, you end up giving calcium and calcitriol. When you develop hypophosphatemia, you end up giving phosphate binders. It will not reduce your risk of hypercalciuria. Ectopic calcifications may keep happening in calcium calcitriol therapy. So these problems remain. And that is why correcting the primary pathology was considered to be something that under research. However, one is also aware of the long-term negative role of PTH, especially on growing bones. So there were multiple studies, and the one with longest duration of follow-up was this one. It looked at 14 children, 5 with APS1 and 9 with calcium sensing receptor defect, and the role of PTH in them over a period of 1.5 to 10 years. What it found was with conventional therapy, most of these children had a low normal calcium, serum calcium range, but the urine calcium was significantly on the higher side. Whereas with the PTH therapy, while the serum calcium came down, the urine calcium also came down. So it was just a shift in the calcium range that we see here. Low serum calcium, low excretion of calcium in the urine. However, there was no mention of if switching to PTH therapy also increased the episodes of hypocalcemic manifestations in these children. It does establish safety over a duration of 10 years. So we do look forward to how PTH fares, and we will need more such trials to establish its safety. But yes, this remains a theoretical possibility of management for these children in future. Moving on to the index case, for chronic mucocutaneous candidiasis, the child had intermittent episodes which were treated with azoles and never required any more aggressive management. Growth was tracked serially and targeted well as per familial targets. The child fared well as per puberty as well. At the last visit, he was about 15 years, 8 months of age and had a testicular volume of 15 ml bilaterally with pH stage 5. We have been serially screening him for adrenal insufficiency and have found no evidence. His liver functions have been normal to date. Now, something interesting that happened in the last visit was that the parents told us that the younger sibling had developed recurrent episodes of cough and was on beta agonist. That is when we found out that even this child had had episodes of cough which were managed as hyperreactive airway disease, and the child had received beta agonists with inhaled corticosteroids. Now, why is this important? Because these children may have autoimmune pneumonitis, which mimics a hyperreactive airway disease. So there was one chest X-ray available which was normal, but then again, if the child has recurrent episodes, we need to get a CT done to rule out bronchiectasis. We had planned a CT, but the child has not come back so far. For the other manifestations, we've been screening him and they've been normal so far. Now, a brief description of the course in sibling. The sibling had similar episode of mucocutaneous candidiasis onset at 6 months. He developed hypocalcemic manifestations at 2.5 years of age, and that is when the parents came to us. The second child has developed similar complaints. Again, the genetic mutation was also done in the younger sibling and showed the same mutation. And it was the lung manifestation of this younger sibling that brought us the history of similar complaint in the elder sibling. Other functions have been tested in the younger sibling and have been normal so far. There is a maternal nephew, mother's nephew at 6 months of age developed chronic mucocutaneous candidiasis, and this child was finally picked up at the right time and found to have the same mutation. So the messages I would like to impart from this case are that if you have a child with chronic mucocutaneous candidiasis, this may be the earliest manifestation of APS1. Look at the family history, screen for endocrine disorders, and if positive family history is seen, do test these children early before they go into hypocalcemic crisis. Early genetic screening should also be offered to siblings and family when one case is already diagnosed. An aggressive treatment of mucocutaneous candidiasis will help prevention of squamous cell carcinoma later on. The most important thing that I want to highlight with this case is that these children, during acute episodes of infection or a flare, may need higher doses of calcium and calcitriol and do well with that. Regular screening is required for associated condition and manifestations. Thank you.
Yeah, so I think this was an interesting case, highlights how it's important to not just look at one particular disorder in terms of the endocrinopathy, we should look at other things as well. Is there any questions from the chairpersons or the audience? We'll move forward because we're running a bit behind time. So we'll start off with the next case then.
Moving on to the next case, I would like to invite Dr. Pradeep to present a case on neonatal diabetes.
So Dr. Pradeep is a well-known figure to all of you, the current audience. He is currently working as additional professor at AIIMS Patna, and he has been extensively involved with MedEClasses and different pediatric endocrine disorder aspects. And we look forward to a very interesting case from you, Dr. Pradeep, please.
Thank you, sir. Good afternoon, one and all present here. This case is important for me because while learning pediatric endocrinology, I came across this case as neonatal diabetes, and I managed this case not independently, but with the help of Anurag sir. So briefly, let's go with the case. So this case, term neonate born out of non-vaginal delivery, non-consanguineous marriage, cried immediately after birth, and the birth weight was 2.4 kg. The child was admitted for neonatal hyperbilirubinemia in an ICU for 3-4 days. And at day 20 of life, the child had fever and the child was worked up at periphery. And what they found a persistent hyperglycemia. So they started regular insulin. Okay, and initially the child was diagnosed as late onset neonatal sepsis and IV antibiotic was started. But since the hyperglycemia was persisting, the child was referred at 40 days to our center. And we admitted that child. And as per the guideline of neonatal diabetes, the random blood sugar was more than 200 milligram per deciliter for more than 3 days. So we made, and the blood ketone was lower side. It was not in DKA. So we made the diagnosis of neonatal diabetes, not in DKA. And we started basal insulin in form of injection glargine. We started with this 0.2 unit per kg per day. And gradually, we'll see in the subsequent slide, how do we escalate the treatment and how we shift to other modalities. Then SOS, the insulin Lispro was also started whenever the child needed the blood sugar spike went up to more than 250 milligram. The challenge with managing neonatal diabetes is that the child had frequent fits, initial days, 2 hourly or 1 hourly, and you cannot give bolus to every fit. And the quantity required in terms of insulin is very low for these children. So the guideline is to give bolus whenever the random blood sugar is more than 250 milligram per deciliter. And glycemic control, we were lucky enough that we managed to bring the blood sugar down to less than 250 milligram per deciliter. And the next step is naturally the confirmation of the diagnosis. So C-peptide in this case was towards lower side. Glycated hemoglobin was 5.8%. And for etiological workup, to rule out any renal problem, pancreatic agenesis, we did the CT abdomen, which was normal, and then we sent genetic test. So genetic test showed heterozygous mutation in ABCC8, and there was this novel mutation which was not there in the database. So to highlight this, the problem was with the potassium channel. And as we all know that whenever there is problem with potassium channel, we have to shift from insulin to sulfonylurea drugs. So we started with glibenclamide, 0.2 milligram per kg per day, and gradually we built it up. So the dose, adult dose is very low, 0.07 milligram per kg, and in neonate, it is rather high. So we went up to 0.8 milligram per kg per day, and gradually we tapered down the insulin, and we could taper it down. And since the child presented at 40 days, we tapered it down and we could stop insulin. And at 4 months of the child, what we have seen in follow-up that the requirement of glibenclamide was very low. Almost it was negligible. So I discussed with sir, and we had planned that why don't you stop it and see how the child behaves. So we stopped it. We stopped glibenclamide and we closely followed the child. We did all the milestones. We seen all the milestones, neurological, this assessment, growth, etc. And at 9 months of this age of the child, the C-peptide was still lower side. And then what we have seen that the blood sugar was fluctuating around 250 milligram per deciliter. Glycated hemoglobin was at that time towards normal. But during gradual follow-up, what we have seen that C-peptide was not rising up. And blood sugar was fluctuating between 230, 270, 280. And now this glycated hemoglobin was started rising up. So again, I discussed with sir, then we had a discussion that it is behaving like permanent form of neonatal diabetes. So we should start this glibenclamide again. So again, I started this glibenclamide 0.1 milligram per kg per day. And I revised the diagnosis as permanent neonatal diabetes mellitus. Since you remember the child presented at 20 days of life. So we see that those children who present early, they usually turn out to be transient form. So we thought that this is transient. But since the child behaved like this, ultimately we made the diagnosis of permanent neonatal diabetes. The growth parameters were normal, luckily. So differential diagnosis initially we kept like stress hyperglycemia, severe sepsis, congenital infection, etc. But that was ruled out, and ultimately it was neonatal diabetes mellitus. So what we see that this child neonatal diabetes, usually these children are low birth weight. So our child was also 2.4 kg, and mostly this potassium channel problems, they usually present this less than 1 month, more than around 30% of cases, but they can also present between 1 and 6 months, more of the 2/3 cases. And there was a large cohort of this where they found that most of the potassium channel are associated with neurodevelopmental disorder also. But luckily, here the Dent syndrome is associated. But what we see in our case, it was okay. It was not affected. The child was neurologically okay. Our mutation was this a heterozygous mutation, where at the position 262, the asparaginase was changed with tyrosine, but the report was this uncertain significance. With this case, what I want to highlight that many times you have to judge and you have to see clinically. Maybe the mutation is novel, which has not still been there in the database. So it can come as uncertain significance. Although it was showing that the ABCC mutation is associated with permanent or transient neonatal diabetes. So to go further in research, at many research centers, they do functional study to prove it, that this novel mutation is causing that clinical or phenotypic variation or not. So they do functional study, which we could not do. So neonatal diabetes, as I said, is if you have a child having persistent hypoglycemia, which is more than 200 milligram per deciliter for more than 3 days, usually when you doubt, it is better to admit the child and see the trend. So if it is if it is more than 200 for more than 3 days, you put it as neonatal diabetes, and the first thing is to send genetic test to prove, because if it is potassium channel defect, it responds to sulfonylurea. The incidence varies with the place to place. Western countries, in India, it is around 400,000, but the places where consanguineous marriages are more, like in Middle East countries, it is quite common. It is almost around 21,000 to 25,000. In pediatric diabetes, the prevalence of the neonatal diabetes is 1 in 400. The onset usually less than 6 months, 85% are usually monogenic. But if the onset is between 6 to 12 months, the monogenic forms are usually 55%. Okay, so what we see here, in Western countries, the proportion. So what we see, this transient form, which is more in Western countries, it is less in India, but permanent, it is more in India. And so this is just to highlight that mostly the transient neonatal diabetes 1 are mostly because of this 6q24 imprinting defect, while permanent forms are usually sulfonylurea responsive drugs, this neonatal diabetes like KCNJ11 mutation or ABCC8 mutation, and isolated other defects like this insulin gene defect, glucokinase defect, or HNF1 beta, or this GLUT2 defect. Type 2 are mostly this KCNJ11, ABCC8. Syndromic are mainly permanent, like IPEX syndrome, Volcker-Trellison, or Roger syndrome. Now, this is very, very much important. How do you, if you found that potassium channel defect is there, you have started insulin. Now, how you are going to shift it to sulfonylurea? This becomes very, very important, and it should always be protocolized. So always admit the patient. Don't treat these patients on OPD basis, because it will be very difficult to monitor glucose and build up glibenclamide. So after confirmation of mutation, you have to start oral hypoglycemic drugs. So use, as I said, you start with 0.1 milligram per kg and build it up. So usually the transition is done over 7 to 10 days, depending upon how the child is behaving. So you have to start oral hypoglycemic drug and taper the insulin. Here I beg your pardon that first the basal, not bolus, first basal one is stopped. So when you start glibenclamide, on day 1, you give the bolus basal, which was you were giving. On next day, you give it like 0.1 you have given today, 0.1 BD. Next day, you give 0.2 milligram per kg BD and stopped basal and give bolus as you were giving. So this depends on pre-meal blood sugar. If your pre-meal blood sugar is more than 200, you continue the same dose of this bolus insulin. But if it is less than 200 milligram blood sugar, reduce the dose of insulin by 50%. On next day, again, you increase the dose of glibenclamide, and same has to be followed. And ultimately, you have to stop bolus also and switch over. You have to switch over the child completely on glibenclamide. And meanwhile, you can also see the rise in C-peptide. But mind you, many times you have to have this glucagon injection at hand. But during glibenclamide switchover, it was seen that there was no reported cases of hypoglycemia on glibenclamide. Mostly the side effects are GI side effects, which are not worrisome. Diarrhea, vomiting, sometimes rashes has been reported, but those were not dangerous one. Okay, so thank you very much. My take-home message will be always do genetic test, always admit those children, prove the diagnosis first. Whenever you are switching it from insulin to glibenclamide, always do it inpatient, and Sometimes transient to permanent is confusing one. So thank you very much.
Thanks a lot, Dr. Pradeep, for this wonderful talk.
So, any questions from the audience? I am having one question that how frequently you can use the boluses in a day? And what is the dose you decided? Bolus insulin.
So bolus, as per, since there is no, you cannot calculate carbohydrate here. So it is said that 0.01 unit per kg you can give. And that has to be diluted in, the diluted preparation has to be given.
The newborn, usually you give many feeds. So at that time, how you decide about those bolus therapy?
So that I said, sir, you have to calculate, you have to take the pre-meal sugar. If it is more than 250, then you have to give. It is less than 250, you have to omit. You don't have to give bolus.
I think that's a very important message. And the other message is that everybody whom you're labeling transient has a risk of developing recurrence of diabetes, be it in the childhood or infancy or even in puberty, as we saw the similar genetic case presenting to us later on. Thank you, Dr. Pradeep. Our next.
Yeah. So the next case presentation is by Dr. Nitya from Kerala.
So Dr. Nitya is from Thrissur. And she has been part, I think, of every case presentation. Every time she has been presenting some very interesting cases. So please go ahead.
So very good afternoon, respected faculty and delegates. At the outset, let me thank Anurag sir for this wonderful opportunity. As sir told, it's probably the third consecutive case presentation for me. So I'm blessed and humbled to be a part of Case Conundrum as well as the APES every year. So my case presentation, actually, it's not a complicated one. It's pretty straightforward. Maybe like a couple of spotters, I can say. But maybe it should be it's very significant in our clinical practice and with a take-home message. So we'll be, in the next couple of minutes, next 5 minutes, we'll be seeing siblings in crisis. A 12-year-old boy who presented with history of multiple episodes of vomiting, generalized tonic-clonic seizures, with history of lethargy, weakness and easy fatigability. And at presentation, he had altered sensorium. He was in shock. Pulse volume was feeble and fluid bolus was given and resuscitated while he had a normal GRBS. No history of weight loss or salt craving, no history of chronic illness or drug intake, no history of trauma, exposure to irradiation or surgery, no history of visual complaints, deafness or focal neurological deficits, no history of absence of tears or dysphagia, and no oral ulcers or history of candidiasis. Past history, he had a history of febrile seizures at 11 months, was on intermittent prophylaxis for a while. Then at around 8 years of age, he developed hyperpigmentation of palms and soles, nails, limbs and gums. And there he was evaluated at an outside hospital, found to have high ACTH and low cortisol level, was started on hydrocortisone and fluorocortisone. So our diagnosis is pretty much clear from this. And the birth history is born as a first child of non-consanguineous parents, full-term normal delivery, 3 kg, no significant neonatal events, no NICU stay. Development was all normal and was fully immunized. Family history, there was something important. He had a younger sibling who had a similar history of hyperpigmentation and admissions for hypoglycemia. He was also diagnosed to have a similar disease. He was on similar medications. The younger sibling was diagnosed around 6 months past his first diagnosis and when he was 5 years of age. And that is the pedigree chart. So coming to general examination, child was active, alert, and his BP was at that time maintaining and had no pallor. And from the growth chart, we know he was like his height and weight was pretty short, less than 3 SDS. Then head-to-head examination, there was generalized hyperpigmentation with pigmented lips, jaw, nails, and palmar creases, sparse eyebrows and hair with alopecia, no dry eyes, and SMR staging, he was pre-pubertal with no focal neurological deficits. So this is the picture of the boy, which showed classical hyperpigmentation, nails and knuckles, and these are the siblings. So the first photos, like when they were it is pre to the diagnosis of the disease, and the present picture. CNS examination was pretty much normal. The stone was normal. Deep tendon reflexes were preserved. Bilateral plantar flexor. Sensory system gait was normal. No cerebellar signs, and hearing was badly normal. Another system examination also was pretty within normal limits. So, as we all know, it's very evident from the case. He's a child with primary adrenal insufficiency, and as mentioned, we have seen a couple of autoimmune conditions also discussed by Dhwani now. So, and we thought it was Addison's disease. But what's striking was, as you must have all thought, we know it's a male child, and he has a sibling with similar hyperpigmentation. And I'm sure that in the last 3 days we have been discussing quite a bit about this. So, coming to the flow chart, the etiological flow chart, we know that the hyperpigmentation as well as will show you that it is definitely a primary adrenal cause, and ACTH will definitely be high. So it's adrenal, and what next? What type of adrenal cause? So it's an acquired primary adrenal insufficiency. And since we considered the sibling also affected, we thought of adrenoleukodystrophy. And coming to the lab investigations, he had a little bit higher level of SGO-TPT, while sodium was 127 and 4.5. The ACTH was high, as we all expected, and it's evident from the clinical picture, and serum cortisol was low. And CT X-ray, chest X-ray was normal. CT brain as a CT adrenal was also normal. It didn't show any calcification as well. So we thought of adrenal insufficiency here, again, acquired cause, primary adrenal insufficiency since ACTH is sky high, and probably familial or an X-linked disease more than autoimmune. So we went ahead with an MRI. MRI showed, I think it's evident from the picture, that there is bilateral symmetric hyperintensities, which is predominant in the posterior, in the parotoccipital region, and like extending to corpus callosum, pons, and midbrain. And the typical sign, what we call as Garland sign, which is characteristically seen in adrenoleukodystrophy. So our diagnosis is pretty more closer to the metabolic thing, where it comes to ALD. And Waldman is out because we couldn't find any calcification, and the presentation is totally different. So so our diagnosis here, adrenoleukodystrophy, and as child was admitted, managed in PICU with IV fluids, injection hydrocortisone, stress dose, and then followed by fludrocortisone. And he was improved gradually, and then discharged on high zone as well as fludrocort. And with the advice of stress dose, he was given an ID card, and teachers were informed, and the parents were also taught about the stress dose. As Sir yesterday rightly mentioned, so which are the 4 S which will make us think of genetic disease? It's soon, severe, segregate, or syndromic. So here we also thought of a genetic study, and a genetic mutation, whole clinical exome was sent, which showed ABCD1 mutation positive. So it's also probably supported our diagnosis. Again, as Pradeep sir discussed, this also came as uncertain significance, but it was very well correlating with our clinical picture, and so it turned out to be ALD. So you all know, it's a brief recap about adrenoleukodystrophy. It's an X-linked disease. It's basically the accumulation of very long chain fatty acids in the peroxisomes, which causes a progressive dysfunction of adrenal cortex, nervous system, and again, one more organ involved is testicular Leydig cells. So most common peroxisomal disorder is defective like oxidative degradation of VLCFA happens, and it accumulates and causes demyelination. Another form of the disease is adrenomyeloneuropathy, which is actually a form which is seen in younger adults around 20 years. But classical X-linked ALD presents, as we all know, can present as primary immunodeficiency. Later on, CNS manifestations can come up. So ALD can present only with features of adrenocortical insufficiency, and adrenal insufficiency will be there in almost over 80% of ALD patients. So it should be considered in all males presenting with Addison's or adrenal insufficiency. And we'll see if very long fatty acid screening should be offered ideally to all risk relatives. But in our setting, for us, like a cost-benefit ratio, we directly progress to genetic mutation studies. And why diagnosis is important? As we all know, probably the only management is bone marrow transplant, early stem cell transplant, and that should be done pretty early for better outcomes. So the take home will be, we have a couple of siblings with adrenal insufficiency. So please look for pointers of ALD as well. Keep ALD in the mind, in the bottom of your mind when you search for the differentials. Genetic study is definitely indicated in such children because treatment options are there, if it is given early, it will work. So these children, we can say that they are getting prepared for stem cell transplant. Though they come from a poor background, they have some NGOs coming up and helping them out. So probably since the neurological events have not started, I think bone marrow transplant might help them out. So that's it. Thank you so much.
Yeah, I think, yeah, for the benefit of time, thanks for the wonderful presentation. I think we'll move to the last one.
Last one.
Yeah.
So I will invite Dr. Vibha Yadav, for presentation on gynecomastia.
Okay, so as no discussion endocrinology is complete without DSD, so we thought this DSD becomes important.
Thank you, sir. And good afternoon, everybody. So we have this 34-year-old male who presented with bilateral gynecomastia, and it was very distressing for him. And he noticed that there was a gradual development of chest since 18 years of age, and he developed secondary sexual characters at the age of 17 years. As compared to his peers, his facial hairs were sparse, and there was no gender dysphoria in him. But he was very much concerned about the non-progression of the phallic length. There was no history of any regression, stall puberty, mild virilization during puberty, or regression of the gynecomastia. He also had a history of erectile dysfunction. He had no history of any chronic illness or drug intake. In the past history, when we asked him, he told us that he has a bilateral mastectomy previously, but no surgery was done for the genitals. Orally, he had taken no medications, but he has taken 3 or 4 doses of injection testosterone. In the family history, he told us that his elder brother and maternal cousin brothers has similar complaints of gynecomastia and sparse facial and pubic hairs. In the anthropometry, what we found, he has a pretty good height of 180 centimeters, and his upper arm to lower arm span was ratio was 0.7:1, which means he has a longer legs and arm span of 186 centimeter, which is more than the 5 centimeter of his height. So definitely it's looking like a eukaryotic proportions. On the examination, what we found, he has a bilateral gynecomastia of 6 centimeter in diameter, firm and non-tender. The pubic hair stage was 4, but they were sparse. The testicular volume was 20 ml bilaterally, and the stretched penile length was 4 centimeter. There was no penoscrotal hypospadiasis. So, differential diagnosis, if we made just on the basis of clinical features, so he presented with delayed puberty, along with micropenis, gynecomastia, and erectile dysfunction, with a testicular volume of 20 ml and sparse facial and pubic hairs. So if we consider the micropenis, then differentials could be hypogonadism, XY gonadal dysgenesis, biosynthetic defects, 5-alpha reductase 2 defect, partial androgen insensitivity or minimal androgen sensitivity defect. And if we consider gynecomastia, then we'll have hypogonadism, stridogenic defect, hypogonadism, hyperprolactinemia could be the cause, drugs, PIS, MIS, and any feminizing tumor. But if we combine all the three, micropenis along with gynecomastia and erectile dysfunction with a testicular volume of 20 ml and sparse facial and pubic hairs, then we get a differential of partial androgen insensitivity syndrome or minimal or the 5-alpha reductase 2 defect. So when we get the investigation done, what we found that his testosterone level was high, it was 938, and his post-SCG testo and DST ratio was less than 10, which was supporting the diagnosis, but not diagnostic of any diagnosis. So we were in dilemma what to do. When we get the karyotype done, it was XY. At that time, he was not ready for the genetic testing. So we reviewed the literature, and what we found, the PIS, that is the partial androgen sensitivity syndrome, has a variable presentation. It could present with penoscrotal hypospadiasis or along with the micropenis also.
they could have like familial genitalia and the clitoris hypertrophy only. And during the puberty, the onset of puberty, in some would have 9.6 years, some would have male gender identity, and some could have female gender identity as well. In most of the cases, they develop gynecomastia during puberty. And as the second differential was 5-alpha reductase, so we compared the clinical features of 5-alpha reductase with the PIS, and what we found that the gynecomastia was absent in almost all the cases, and the testosterone to DST ratio was less than 10. And what we say, if the testo-DST ratio is less than 10, it is more suggestive of 5-alpha reductase deficiency. But as we can see in this study, it is not diagnostic for 5-alpha reductase deficiency. Then after a couple of years, he got convinced for the genetic testing. And what we found, he has this defect in the androgen receptor at the C2521 replacement of cysteine with the thionine. And it was hemizygous, X-linked recessive inheritance. So when we go through the literature, what we found that there is a lack of correlation between the genotype and the clinical phenotype of the patients. If there are two family members in the they are suffering from this defect, then one could present with the CIS, that is the complete androgen insensitivity defect, and other could present with the partial androgen insensitivity defect. And the most important and interesting thing is that in the patients with PIS phenotype cases, it is not necessary that you would found the AR mutation in all the cases. The study showed that in only 38% of cases had the AR mutations. Now the question is then why they are having what they have that is causing this clinical presentation of PIS. So they showed that androgen receptor is really essential for virilization, but there are other components of the androgen receptor complex and signaling network that are required for complete vascularization. These are the non-detected cases of androgen resistance, which might be secondary to the mutations in the 5-UTR region, that is the promoter region, and the other regulatory region. So if we talk about the management, we know that there is a variable presentation of the complete AIS, AIS. So the main thing is gender identity. As in the complete AIS patients, the gender identity is female as they have no androgen exposure during the antenatal period. While in the other, like PIS male and the minimal AIS, the gender of identity is male. We should always delay the genital reconstructive surgery till the puberty or till the patient become major. And according to his or her wish, we will plan the surgery. In the complete AIS, what is recommended that gonadectomy should be done after the puberty, and then we go for the hormone replacement and the urogenital tract surgery. In the PIS female, gonadectomy is done before the puberty, and the hormone replacement is done along with the urogenital tract surgery. In the PIS male, that is our patient, if there is an undescended testis, then definitely orchidopexy is done. And if the testis is not working, then orchidectomy should be done. And for the gynecomastia, we should try for tamoxifen. If the patient is not responsive for tamoxifen, then definitely mastectomy is the option. And for the micropenis, we should start with the higher dose of testosterone with the 500 to 1000 milligram 3 weekly. So if I summarize the case and go with the timeline of the patient presentation, he presented in October 2020 with the gynecomastia and micropenis, along with the facial hairs and pubic hairs with a testicular volume of 20 ml. He had a history of mastectomy. Then on an investigation, what we found, he had high testosterone level along with the high LH. He had already received the injection testosterone 250 milligram 3 weekly, but showed no response in terms of increase in the penile length and this decrease in the gynecomastia. So, and when we started the treatment with the higher doses of 500 mg testosterone, then his facial growth improved. They have increased, his penile length increased, and in the October 2020, he was finally convinced for the genetic testing. And it confirmed the diagnosis of PIS, and the semen analysis showed oligospermia. That means he has still the potential of fertility in him, and his erectile dysfunction will be resolved after this testosterone administration. But nowadays, he has stopped the testosterone by him, and still he's facing the problem of gynecomastia, which is not resolved. So the take-home message from this case is that if you have a clinical feature which are strongly suggesting that this is going towards the PIS, and this testosterone DST ratio doesn't support your evidence, and even the genital testing will not show that if all the patients should have this androgen receptor mutation. So if we have this phenotype, we should usually start with a high dose of testosterone, and then we should monitor him further. Thank you.
Thank you, Vibha.
Thank you, Dr. Vibha. I would like to invite any questions.
I think one important point which was there in this case, which was highlighted by Vibha, was that he had a large testis. So normally you have gynecomastia with small testes, that is Klinefelter. So large testes with gynecomastia clearly would be going more in favor of a pathological cause like androgen insensitivity. Again, your LH levels were on the higher side and testosterone was also high. So that's very, very important in that perspective. We have got some comments which are coming up. One is from Dr. Vijay Kumar from Calicut about less transient neonatal diabetes in India due to lack of detection. I think, agree with that because transient may not be picked up at all. So this is the reason that is there. And Dr. Chisholm is asking from Nigeria how high calorie feed be obtained with low protein. So basically what we do is that if you're giving milk, you dilute the milk with water and add oil so that you increase the calorie density while not increasing the solute load. So I'd like to thank the chairpersons for this session, Dr. Mahesh and Dr. Sugandha. Kindly thanks a lot. And I'll hand over to Dr. Dhwani to carry forward for the next session.
Thank you, sir. So we know that pediatric endocrinology is a rapidly evolving branch, especially in the last decade or so. With the upcoming new diagnostic and therapeutic interventions, the societies are coming up with new guidelines to stay up to date with these technology. So now we have a state-of-art session. For the first talk, I would like to invite Dr. Vibha to... Yes. Before we start, I would like to invite the chairpersons for the session. Dr. Vikas Mehrotra, sir, who is a pediatric endocrinologist and diabetologist from Aligarh. And I would like to invite Dr. Princey Joseph, ma'am, an additional professor in pediatrics from Kollam. Dr. Pradeep Kumar, sir, again, professor pediatrics from AIIMS Patna, to chair the session.
So I think this is a session which is going to focus largely in terms of management approach and how they are changing. So we have a quick 15 minutes talk so that we try to cover those scenarios from that perspective. So the chairpersons can...
the storming sessions on these cases. I would like to start on thyroid. And our first speaker is Dr. Vibha, who is a consultant pediatric endocrinologist at Regency. And over to Dr. Vibha, please. He'll be talking about the thyroid nodule, the clinical approach.
Thank you, sir. And good afternoon once again. So let's see. Coming to the question, what is thyroid nodule and how it is different from the goiter? Actually, thyroid nodule is a specific growth within the thyroid gland, which is ultrasonographically different from the thyroid parenchyma. So starting with the case, we had this 14-year-old girl presented with a thyroid swelling. The swelling was localized to the right lobe, and she has mild features of thyrotoxicosis. The FT4 was high and the TSH was 0.01. So in this case, USG and FNAC was planned. So here the question comes, should we really go for the USG and FNAC in this case, or there is another choice of investigation? So when the patient presented with a thyrotoxicosis and TSH is suppressed, definitely the choice of investigation here is a technetium 99 per thyroid scan, and we should go for the scan. Now coming to the what is the choice of investigation in different scenario based on the TSH level. So the ETA guidelines 2023 clearly says that if the patient comes to you with a thyroid swelling, always take the detailed history regarding the family history, exposure of any radiation, carefully examine the thyroid nodule. What is the consistency? What is the size? And what is the mobility? And the first investigation should be done is the TSH, because the further investigations are planned according to the TSH. So if the TSH is suppressed, like in the previous case, we should go for the free T4, trap antibody, and definitely the scan. And if the scan we found there is a hot nodule and a cold nodule, if we get the cold nodule, then definitely we should go for the USG for the stratification of the risk of malignancy. And on the basis of USG findings, then we go for the FNAC. If the TSH is normal, patient is euthyroid, then we can directly go for the USG and then for FNAC. But in the cases where there is a thyroid swelling nodule, the TSH is elevated, so we should go for here this free T4 level anti-TPO antibody, and again for the USG. So directly not going to the USG, we should go for the TSH level first. And again, the family history of medullary thyroid cancer is very important. And for this, the calcitonin level should be done in the patients of thyroid nodule. Now moving towards how should we evaluate further in the case of thyroid swelling. So we have this 13-year-old boy who presented with thyroid swelling localized to the right lobe. He was asymptomatic. He was euthyroid. And what does the USG shows? It shows irregular margins and the calcification, as you can see in the picture. So as these are the suspicious signs which point towards the malignancy, without doing any further investigation, he was directly planned for the lobectomy. So the question here is USG findings enough to make the final diagnosis? Definitely no. The ETA guidelines 2022 clearly says that USG alone cannot definitely distinguish the benign thyroid nodule from the thyroid cancer. And in suspected nodules, FNA is recommended. And when doing the USG, we should evaluate all the lymph nodes, cervical lymph nodes to check the metastasis. And we should cover the whole thyroid band along with the cervical chains, 3 to 4, second, third, fourth, and with the fifth level of cervical lymph nodes. Now, we know we just write the thyroid USG and we send the patient, but we should clearly write in the prescription that what we want the radiology to see in the thyroid, this USG. So the USG thyroid should contains and should explain these particular points, because these are very helpful in making the diagnosis of or in ruling out the this benign from the malignant lesions. And the report should clearly explain what is the echogenicity size of the thyroid lobe, how is the nodule, what is the size, what is the echogenicity, what is the composition, and is there any suspicious or non-suspicious signs present, or is there an extrathyroidal extension? And now coming to the question, which discrete lesion to be described? Any lesion which is more than 1 centimeter should be described. And if we have more than 3 nodules, then what to do? How many lesions should be described? The guidelines says that the largest one, and those with the suspicious signs, if the number is more than 3, and if the pathological lymph nodes is present, definitely the characteristics of the lymph node should be mentioned in the USG. Now coming to what are the suspicious USG findings that point towards the malignancy? There are irregular margins, microcalcification, and the hypoechogenicity. Coming to the ultrasound characteristics, I talked about the pointers towards the malignancy, that are the irregular margins, calcification, taller than wider, which is mostly applicable for the adult patient, hypoechoic, and the solid part. The study showed that the sensitivity of each and every USG characteristics have different sensitivity and specificity. And we can not just go with the calcification or the irregular margins. When we combine all these USG characteristics, our sensitivity and specificity is increased from 28.1 to 93.2 in the sensitivity. And while combining all these USG characteristics, we can increase the specificity from 41.4 to the 100%. So always combine these USG characteristics while making a diagnosis. And the same is done by the American College of Radiology, which is ACR TIRE scoring. It combines all the USG characteristics, composition, echogenicity, shape, margin, and the echogenic foci. And by each of them characteristics is given a point, and when combining all these points, it has been characterized into the various categories, and then this judgment or the guidance for the FNAC is done. But the studies have showed that the ACR thyroid scoring is better for the adults in diagnosing the benign from the malignant. And there is a Europeans has also prepared the thyroid scoring, but they have not involved extrathyroid extension in the composition of nodule in this. What about the pediatric nodule? Can we use the thyroid scoring in the pediatric thyroid nodules? The study showed that it is not very good for the pediatric thyroid nodules. And this study was done by the American College of Radiology, in which 340 patients younger than 19 years with 404 thyroid nodules were studied, which has a high percentage of malignant nodules, and among which 17 of 77 nodules would not be recommended for fine needle aspiration. It means they were missed and they were suspicious of malignancy, but they were not, the FNAC was not recommended in these cases. And what another, they have found that it reduced the biopsy rate of benign nodules in only 31% cases. So definitely those show that the ACR thyroid scoring, which we are using now, is not good for the pediatric patients. Some modification should be done in these patients in the thyroid scoring, like for the TR1 and the TR2. Regardless of the ultrasound characteristics, all the nodules larger than 4 centimeters should undergo FNA. And the other modification that they advise is that in the TR stage 3, the perform FNA in all the nodules which is 1.5 centimeter or larger. And in the TR4 risk level, we can see they have said to perform FNA in nodules 1 centimeter or larger, and in the follow-up nodules in which are 0.5 centimeter or the larger. What they found in some cases, which were proven cases of malignancy, but the USG has shown the this benign features. Like in the first picture, you can see there is a semicystic consistency, and the margins are smooth. In the second case, we can see that there is a regular margin with the solid cystic area. These were proven cases of malignancy, but according to the thyroid scoring, they were considered as benign. So now coming to the, after doing the thyroid, USG thyroid, then what should we do next? How should we proceed further? So again, this 15-year-old boy presented with a thyroid swelling, and it was localized to left lobe. He was asymptomatic, euthyroid, and the USG NAC showed regular margins, cystic, hyperechoic, and size was 0.5 centimeter. So FNAC was planned in this case. Now the question comes here, whether this patient require FNAC, what are the indications of FNAC? So this is the 88 nodule sonography patterns which show the risk of malignancy, and they have clearly showed that on the basis of USG characteristics, we go for the FNAC. Like in the high suspicion of cases which have microcalcifications, irregular margins, hypoechoic, and this taller than wider. The size which is more than 1 centimeter, definitely we should go for FNAC here. While at the low suspicion and the very low suspicion, the size is more than 1.5 centimeter, we should go for FNAC. But in the cases of benign nodules, FNAC is not required at all. And in our previous case, the FNAC was not required as the case, it was a benign nodule. But all the lesions, irrespective of the size, if there is an extrathyroidal extension, compression, abnormal lymph node, we should always go for the FNAC. Based on the FNAC, Bethesda system has been formed for reporting the thyroid cytology. And they have characterized the lesions in 6 classes: non-diagnostic, benign, ATP of undetermined significance, follicular neoplasm, suspicious for malignancy, and malignant. Here I want to highlight that there is a little bit difference in the nomenclature from the 2017 guideline and in the 2023 guideline. They have just replaced, they have just skipped the lesion. Initially, we used to say there is a atypical lesion of undetermined significance or the follicular lesions, but now they use the term of ATP of undetermined significance, and only the follicular neoplasm term is used in place of follicular neoplasm or suspicious for a follicular neoplasm. The user management is same in both the guidelines, like repeat FNA in the non-diagnostic lesions. In the benign, we have to follow up the case. AUS as it is a category of in dilemma whether to go for the molecular testing or diagnostic lobectomy. In the follicular neoplasm suspicious for malignancy and malignant lesion, definitely we should go for molecular testing first, then either lobectomy or the total thyroidectomy. So coming to the case, we have the same case who has this USG characteristics of benign lesions and size is 1.5 centimeter. And FNC showed the benign nodule. Then what to do next? Either we should follow up the case or we should go for the molecular testing or anything else. So here, the management for the thyroid nodule, especially in the benign cases, the ETA guideline says the FNC is repeated in the cases of first, if there is a non-diagnostic sample, and if the Bethesda class 3, that is the AUS type, and if there is discrepancy between the US ultrasound risk score and the cytological findings. In the Bethesda class 2, that was the previous case, if the lesion is benign on the FNAC, then what to do? Follow up the USG in 6 to 12 months, and FNAC is only required if the suspicion signs develop. And for the stable nodules, which do not show any suspicion signs, the USG should be done in 12 to 24 months till 5 years. And if during the meantime, the size increases by 20%, that is more than 2 mm, and the volume increases by 50%, definitely we should go for the FNAC. So coming to the similar case, now we found atypicia or undetermined significance in the FNAC. Then what should we do? Because this is a category where we are always in dilemma what to do. So the molecular testing has come up. Guidelines recommends that every lesion of category 3 should go for the molecular testing because it would help in it is important for prognostic information and it would guide in the extent of surgery. So there are several this thyroid genetic testing like Afirma, GC, Thyrosex V3, Thyronext, and the thyroid prints, and their type of test is different on all these. So based on the molecular testing, how do we go further? This is important. If we have this Bethesda 3 or 4 cytology, and we have done this molecular testing, and in the molecular testing we found there is no mutation, then definitely no intervention is required. We will observe the patient. But if there is a RAS-like, this is positive for RAS-like mutation, then definitely lobectomy is done. On the other hand, if the patient is positive for BRAF-like mutation, then total thyroidectomy or lobectomy is done. And if the patient is positive for multiple driver mutation, then definitely it is a high-risk cancer and total thyroidectomy is done. So thank you.
That's correct, Dr. Vibha. And I think very relevant points, particularly with the molecular testing, which is there with regards to that. So molecular testing becomes absolutely important. And this is part of the FNA sample where the molecular testing is done. Over to the chairperson.
Thank you very much, Dr. Vibha. Everything is fine with this thyroid nodule. May I have one question or later on we can have?
We can have the questions
later. Okay, fine. So next I invite Dr. Aisha. Dr. Aisha is like my younger sister. She is from Jawaharlal Nehru Medical College, an eminent professor and research fellow of SPE and SPAD and a learned pediatric endocrinologist. So we are proud of you, Dr. Aisha. We would like to hear you about the rickets, a very common condition we are encountering our day-to-day practice. So over to you, Dr. Aisha.
Okay, thank you very much, sir, for such a kind introduction. And thank you, Anurag sir and team, for doing this wonderful job of training so many pediatric endocrinologists. So without any further ado, I would rush to the topic. So talking about rickets treatment, vitamin D and beyond. So I would like to restrict myself to just the practical aspects. And if you have any query, just feel free to interrupt and ask the questions. So talking about rickets, so what we most frequently encounter is deficiency of calcium and vitamin D, which is the usual scenario. And what we do is we just give treatment and wait for the response to therapy. We give calcium, we give vitamin D therapy and wait for the response. So the problem occurs when the child does not respond to your treatment. So rickets can be classified as a simple deficiency of vitamin D and calcium, and refractory rickets, which usually does not respond to your first line of management. So this is when we start thinking about refractory rickets. So what comes under refractory rickets is actually calciopenic, which can be because of alteration in the calcium metabolism. So you think about vitamin D dependent rickets type 1 and 2. This could be because of renal failure or even in cases of malabsorption. So what are the clinical pointers or cues which make you suspect about calciopenic refractory rickets is it has very early onset, as early as in infancy. The children have very high hormone levels and the calcium levels is low. So another reason for refractory rickets is because of acidosis, which you can see in both proximal and distal type of RTA. And the clinical pointers in this situation will be the child will have polyuria. So these are the, you can say, the clinical cues which should, along with rickets, the clinical features of rickets, which should make you think about refractory rickets as the reason. There will be failure to thrive, which we very commonly see with the acidosis, RTAs, and the child may have nephrocalcinosis, as in distal RTA. So I'll come to that. Another aspect is where there is absorption problem in the phosphate levels. So there you can have phosphatemic rickets. So what comes under that is hypophosphatemic rickets, or even Fanconi's, or the hypophosphatemic rickets along with hypercalcemia. So the clinical pointers, they will have a late onset, comparatively late onset as compared to the calciopenic type. And the characteristic pointer here is that the children, they have more frequent involvement of the lower limbs. So which should make you think about refractory rickets. And another important clue or cue here is that their hormone and calcium levels might be normal. Okay, so the question that you should always ask in a child who presents with this limb deformities is whether that is rickets or something else. And if at all it's rickets, it's refractory or amenable to your first line of management. So I'll try to address these questions. So talking about the management aspect, so we had guidelines which came out in 2021, IAP guidelines. So this is very easily available, so you can find that. So what that recommends, the take-home message, an important point to remember here is that parental vitamin D, which is very, very frequently favored by practitioners all over, is not a very good form of management. Yeah, thank you. So it's only for whenever you suspect malabsorption. Otherwise, giving oral dose and daily therapy is definitely proven to be of more advantage and benefit as compared to your intermittent regimes or even your IM regimes. So once you start a child on treatment, so what are the clinical points? How does the child respond? So what happens? You start vitamin D as per the age appropriate dosage. It leads to calcium absorption, which is its function, and phosphate absorption. So what happens because of this? So what you need to remember here is there is influx of calcium into the bones. So the serum calcium levels might go down. So if you go for biochemical testing prior to the designated time, so you may have calcium levels in the low range, and which might have a manifestation of bone pain. So this does not mean the child is landing into failure, but this is a usual, you can say, response to therapy, which is physiological once you start a child on therapy. And because of this supplementations, there is increase in the osteoblastic activity. So that leads to increase in the level of serum alkaline phosphatase. So what we understand is ALP days means the child has rickets, but you have started the child on treatment, but still the levels are high. So this could be a physiological response, and you should not rush to conclusions and label it as refractory rickets. So there might be a transient rise in ALP, and in your X-ray, you'll find a line of healing. Radiological appearance of a healing rickets is very important, just to suggest that you are on right track. So these are the pictures you may have. As I said, in refractory rickets, there might be involvement of lower extremities more. So you may have all the abnormalities confined to the lower limbs. And you can have, depending upon the weight bearing on the joint, you may have further radiological evidence like the characteristic cupping, fraying, and splaying. So once you start the child on calcium and vitamin D source, but you wait for 4 to 6 weeks, but still there is no line of healing. So it's not always refractory. So there are certain misguiders. As I said, you may have high alkaline phosphatase levels. You may have normal low calcium levels, which is a part of your therapy. And the child may have bone pain along with that. So don't you may suspect, but don't jump to just this, that this is refractory rickets. So what can be the masqueraders of refractory rickets? Dysplasias, skeletal dysplasias, hypophosphatasias, and fluorosis. So they may have manifestation which might mimic refractory or any kind of rickets. So you should always, this calls for a detailed clinical history and examination. Okay, so you may have other conditions which may have clinical features suggestive of rickets. So, so red herring signs, again, the repetition of what I said earlier, polyuria in a child who has multiple fractures, unexplained fractures, and who has failure to thrive, this should make you think about rickets as the etiology. So talking about management, so that depends upon the condition. As I said, it could be because of calcium, because of phosphate, or even the involvement of, in cases of renal जो है acidosis. So depends upon the condition. Definitely for RTS, like the treatment is bicarbonate and phosphate supplementation. For vitamin D dependent rickets, that depends upon whatever the problem is, whether it's at the receptor level or problem or abnormality in the enzyme. So that calls for high dose calcitriol, that is vitamin D analogs along with calcium. So coming to one very unusual and unaddressed form of rickets, that is hypophosphatemic rickets. So how do you treat that? Once you label a child as a case of hypophosphatemic rickets, in which it could be autosomal dominant, I'm not going into details of that, or it could be because of X-linked hypophosphatemic rickets. So you have to give phosphate supplementation in a dose of 40 milligram per kg per day. That has to be titrated, and you have to monitor. So how do you have to adjust the dose? So giving like, it's not just calcium and phosphate. Now you're thinking beyond that. So you give phosphate and you keep titrating the dose. Similarly for calcitriol and calcidiol. Now alpha calcidiol, it's used mostly in cases of like renal involvement, renal failure, because it gets converted into activated calcium, vitamin D in liver. So it does not require renal involvement for its activation. So that is helpful in those situations. But the doses are very important. And another important aspect is monitoring. Why? Because you are giving activated form. So you have to, you don't have to overtreat. So you always have to monitor that you do not overdo the treatment. Okay, so what are the different phosphate and phosphorus preparations available? So you have oral preparations available, tablet form, you have in sachet form, and also I'm sure all of you must be aware of the Julie solution, which is available, which provides about 50 milligram of phosphate per ml of solution. And you have injectable preparation also. Depending upon the case, you have to start the child on treatment. So how do you monitor? So these are the parameters that should always be addressed in a child who is started on phosphate supplementation. So you have to monitor growth, very reliable clinical parameter. And if it's not increasing, then definitely the dose has to be titrated. You have to monitor biochemically phosphate levels every 3 monthly, and likewise as given in the chart. And accordingly, the dose has to be adjusted. Always remember to monitor, like in simple rickets, you never monitor urine routinely. But in this case, you have to monitor urine for calcium creatinine ratio, for the reason being, again, you don't overdo, because giving increased doses might lead to increased phosphate levels. Calcium might lead to calciuria, and it might lead to nephrocalcinosis. So keep monitoring and keep titrating the dose accordingly. So what can be the complications? So complication, very sinister complication could be hyperparathyroidism, because you are perhaps overtreating, and the child has, because of overstimulation, has landed up into hyperparathyroidism, which could be because of high phosphate levels if you didn't monitor, or because of low calcitriol. So these can be reasons where the child can land up into hyperparathyroidism, and which could be counterproductive in this case. So what you have to do, you have to reduce phosphate levels, obviously, and you have to, and at times, if it doesn't respond to the just reduction of dose, so take care of the the parathormone levels, you might need to give cinacalcet also. So nephrocalcinosis is another complication which we are always wary of. So you have to keep monitoring urine calcium creatinine ratio, so the child does not have something iatrogenic. It could be because of high calcium and phosphate levels. So you have to just monitor it through annual ultrasound, or if the child has abdominal complaints and that needs to be addressed, and that can be by talking about drugs, so that can be corrected by giving thiazide diuretic. So child with rickets and being giving thiazide. So this is always another important take-home message. Another complication that you might encounter is the child may have growth failure if not properly managed. So you have, it could be because of delayed diagnosis, very common in our scenario, in our setup. So you have to, most of the children, they are often brought late. So you have to keep that thing also account while counseling the parents before embarking on treatment, that growth failure is a part, and because they are already late, so it might compromise the adult height. It could be because of poor control, though the drugs are available, but at times follow-up becomes an issue. And here follow-up is very important because you have to keep titrating the dose. And renal dysfunction is another reason for that. So how do you rectify those? So you have to aim for a better control, better monitoring. So talking about growth hormone, like children, because of refractory rickets, because of the deformity per se, they may have a short stature, which could be disproportionate short stature. So growth hormone, because it's being used in so many indications. So talking about renal rickets and refractory rickets and growth hormones, so we have mixed studies. So the robust evidence that says that it doesn't help much. So it might be used, but it's not like you have both kinds of evidence available. Few are favoring while other refuting, but the evidence says it doesn't help much in this situation. So again, about hypophosphatemic rickets. So here I talk about a case. So we have a child who is a diagnosed case, who has been started on phosphorus with the baseline dose that I talked about, who is on calcitriol 30 nanogram, and talking about phosphate levels are normal, low, and parathormone levels on the higher side. So what is the plan? Anybody from the audience? So he's already on treatment, parathormone levels you monitor still high. Okay, so go back to the chart so go back the thing that I was talking about. So it could be because of hyperparathyroidism. So improper giving a too high a dose, high phosphate might lead to parathormone stimulation, might lead to hyperparathyroidism. So again, the remedial measures would be to reduce the phosphate dose. So that has to be titrated. So that is the importance of titration. And you have to increase the dose of calcitriol. Okay, so this is how you monitor. So the same child was followed up after 2 years. Phosphate was reduced from 40 to 30, calcitriol again 25, 30 to 25. The child now complains of polyuria and abdominal pain. So what next? What could that be? Pardon? Okay, very good. So that's okay. So you go for urine calcium creatinine ratio, that's 0.6, and the scan shows renal calcification. So obviously the diagnosis becomes obvious that the child has developed nephrocalcinosis. So perhaps you were high on the dose. And for that, what do you add? You add thiazide to take care of this hypercalciuria. Okay, so that was added to the child, and the dose of the calcitriol has to be reduced further. So again, the child was followed up after 1 year. Phosphate, again, 30 milligram per kg, calcitriol 25. Height. So the earlier height is not given, but I would say poor growth velocity. His testicular volume is 4 ml. So what's the plan now? Poor growth velocity. So the third scenario, the third situation, poor compliance. Okay, the child is landing up into growth failure. So again, maybe he was not following up properly. Maybe he was not taking the drugs properly. So again, the third scenario, the third complication that we talked about, that the child may have growth failure. So you have to talk about better control. So that has to be monitored. You have to ensure compliance of the drugs. You have to counsel the family. And growth hormone, as I said, that remains plus minus. That remains a gray area towards a no indication. So what is recent? So we have now a new drug, you can say new, it was approved in 2018 for X-linked hypophosphatemic rickets, burosumab, that is a monoclonal antibodies, because now we are living in a generation of immune therapies and these drugs. So this is available. So if you recall that for all kinds of hypophosphatemic rickets, the problem is at FG3, the phosphatonase FG3 levels. So what they do, the levels of these increase because of many reasons, because of mutations. So this has phosphaturic effect. So that's why the child lands up into phosphaturia. So what is this burosumab? So this is an antibody which works again, which takes care of this increased FGF23 levels. So that takes care of the phosphaturia. Okay, so the levels gradually become normal. So whatever the phosphate levels which was being secreted in the urine because of burosumab, it gets reduced because that's its line of action. So that takes care of the nephrocalcinosis, and also it has a stimulatory effect on the calcitriol. Okay, so that will take care of the hyperparathyroidism, which could be the complication of the drug. Okay, so the indication, but it's not very, though it's available, but it's not a very like simple drug that you can give in any child with hypophosphatemic rickets, because there are few indication and also contraindication like in any other drug. So for newly diagnosed and even X-linked hypophosphatemic rickets, and also for malignancy induced tumor induced phosphatemia, so you may give burosumab, but the catch here is always look for serum phosphorus levels. So the levels should always be low before you start this treatment. And another important recommendation and precaution here is that you do not have to give calcitriol and phosphate along with that, because it might lead to dangerously high levels of phosphate. So once you diagnose a child as X-linked hypophosphatemic or tumor-induced osteomalacia, you can give this drug, but the serum phosphate level should be low. And if the child has been on treatment, then these two things have to be stopped at least for a week prior to starting this treatment. Okay, and the contraindication would be a renal involvement. So if the child has renal failure, so definitely this drug is contraindicated, because again in renal failure, you may have hyperphosphatemia. So this might increase it further and cause the problems. And you can give normal doses of vitamin D along with burosumab. Monitoring has again to be with growth, because but if the cases are very extreme, like in cases of delayed diagnosis, you may have that bony deformity that might persist for a long period, and that might require orthopedic correction. But you have to just monitor how the child is responding. If obviously the epiphyses have not closed, and you have to monitor biochemically also. And you have to try to maintain in the lower normal, the phosphate levels have to be maintained the lower normal level, so that you do not overtreat. So there might be high risk of dental abscess. That's it. So talking about another reasons for refractory rickets. So vitamin D dependent rickets. So that depends upon this is, I'm sure everybody knows, vitamin D gets converted into 25 hydroxy and
Rasha,
22. Okay, I'm running short.
request you to just wrap it up. Thank you.
Okay, so I'll just come to the treatment part. So you have to give calcium in vitamin D dependent, depending upon the case, and the activated form of calcitriol, which might be like in type where you have resistance at the vitamin D receptor levels. So dose has to be high. So that is what has to be given. And talking about the same thing like vitamin D resistant rickets type 2, where there is problem at the receptor level. So doses has to be high. You have to give calcitriol, and the dose are higher as compared to in a normal situation where you give. And this might require initiation with IV calcium also, but subsequently the child can be switched to oral calcium supplementation. So vitamin D preparation, all of you are aware what are available. So the take home message is just oral is always better, and the daily dose is always better than the intermittent. Greater rise, because we have different types of, you have ergocalciferol, you have cholecalciferol. So response is always better. So greater rise with cholecalciferol, no advantage of parenteral vitamin D, except in special situations like malabsorption. And this is the same thing. I think I can skip. Okay, so monitoring. Okay, so I'll talk about, this is the same thing, repetition of the same thing. You have to give calcitriol high dosage along with calcium, and you have to keep monitoring. Monitoring has to be, and just remember, apart from calcium phosphate, alkaline phosphatase, you have to monitor urine for calcium creatinine ratio. That is very important. That should be a routine part of your monitoring, because you should not overtreat. X-ray has to be repeated at least for after 4 to 6 weeks to look for line of healing. And if it doesn't appear, revisit your diagnosis and recheck whether the child is taking proper dosage or not. So this is again The same thing, type 2. So you have to give calcitriol in high dosage, IV calcium, subsequently switch to oral calcium. So this is the same thing. Monitoring again, calcium phosphate, alkaline phosphatase, the same biochemical parameters, but how to play around with them is very important. How to titrate doses is very important. So you have to look for age appropriate normal levels. And so we have 3.5 years old with refractory rickets. So, okay, so what is your take here? Calcium, the low side, phosphate, low, alkaline phosphatase on the high. No response to parenteral therapy. Go back to the same flow chart. Okay, 25, hydroxy is low, definitely on the lower side. So that could be 10-5 hydroxylate deficiency. So, okay, I think this is the same thing. So I want to go to the RTA part. The last part is about, so what happens in the proximal as well as in distal RTA. The proximal, you know, it's because of the increase in the secretion of phosphate level, bicarb levels. And in the distal RTA, you may have problems at the secretion of this proton pump, hydrogen ions, which might lead to RTA. So this is amenable to treatment. So once you have a child who presents with polyuria, who presents with failure to thrive, and who has this feature lower limb involvement and disfiguration of the lower limb. So you have to, and the clinical, as far as biochemical parameters, electrolytes, you have hypocalcemia as the manifestation. So you have to think about RTA, and the treatment has to be with alkali preparation, soda bicarb, that depends upon proximal or distal. You have to give bicarb preparation. So you have sodium, potassium, polycitra, which is a powder form tablet, easily available, potassium citrate. So again, that has to be given and the dose has to be titrated. Okay, so your target would be a bicarbonate, which should be in the near normal level, 22 to 24 millimoles per liter, and the dose has to be initiated again for distal RTA. You might require a bit smaller dose. It has to be initiated at 4 to 10 nanomoles per kg per day, and the dose has to be titrated depending upon the response. Preparation, as I said, it's sodium potassium citrate is available, soda bicarb for hypercalciuria, which might again lead to nephrocalcinosis, especially in distal RTA. So you have to go for low salt diet along with thiazide diuretics to take care of that. So urine calcium creatinine ratio is the monitoring for every form of refractory rickets. Annual ultrasound, again, to look for nephrocalcinosis is very important. And renal functions. These are in addition to your normal biochemical parameters. And for proximal RTA, because this is because of the defect in the child passes like amino acids and glycosuria and bicarbonaturia, everything is there. So you have to give treatment for that. Again, the treatment is bicarb. So this is along with the vitamin D preparation that has to be given. It is because of the faulty secretion of the hydrogen ions. It is characterized by, again, hypokalemia, but the nephrocalcinosis and hypercalciuria is not so frequently seen as in distal RTA. So dose, again, has to be 10 to 15. It is a bit higher. You have to give nanomoles per kg per day. And to take care of hypercalciuria, thiazide diuretics have to be given. Potassium, the usual requirement, 2 to 4 milliequivalents per kg per day. And the phosphate, roughly 40 to 50 milligram per kg per day. And you have to keep monitoring. There are chances because the condition predisposes for hypokalemia. So you have to keep monitoring for that. You have to give analogs of vitamin D as in any case. And the child subsequently improves upon time. So monitoring, the same thing. I think this is all I have to say. Okay. So any questions about refractory? I think I was rushing.
Thank you so much, ma'am. Before you leave, I would like to request Dr. Vibha to hand over momentum to Aisha, ma'am. I would like to request the chairpersons to invite the next speaker, please.
Okay, so the next speaker is Dr. Sajili, and she will talk about low bone mass. Dr. Sajili, she was fellow here and she's very well to know. Thank you. Please go ahead.
Yeah, so it's a pleasure to welcome Dr. Sajili, who is currently working as a pediatric endocrinologist at Pune. She was with us as a fellow, and it's really good to see her doing so well in that region. Thank you.
Thank you, sir, for your kind words. And thank you, panel. So without wasting time, I'll start my presentation today on low bone mass. So basically, I'll be talking more about what is the definition and how do we approach a child with low bone mass in pediatrics. So what is basically low osteoporosis in pediatrics? Is it based on DEXA? No. The DEXA Z score of less than -2 doesn't say that the child is osteoporotic, okay? The basic diagnosis depends on clinical presentation. If the child has any single vertebral fracture or has 2 long bone fractures in less than 10 years and more than 3 or more long bone fractures in a child who is less than 18 years with a BMD-Z score of -2 standard deviations is considered to be osteoporosis as per the International Society of Clinical Densitometry official statement in 2013. So what do we do when we diagnose a child to have osteoporosis, or how we go how we approach a child who has a bone fracture? Okay, so this is an approach. This has been recently published in 2024. It's a bit complicated approach. We'll go step by step and understand how to approach a child who comes with fracture. So first step, whenever a child comes with fracture, one needs to identify whether this is fracture because of some basic metabolic causes like rickets. So any child who comes with fracture, one should do calcium profile, vitamin D, rule out rickets or vitamin D dependent rickets. Then also one has to look for non-accidental injury. Okay, in that cases, one needs to rule this out first before labeling the child osteoporotic. The second step will involve evaluating the skeletal phenotype of the child. One knows that the child may be at risk of primary osteoporosis, like in cases of osteogenesis imperfecta, which is the most common cause of osteoporosis in children, and secondary causes, which can be because of acute and chronic conditions like a long-term steroid use or a patient who is having cerebral palsy. They are at risk of secondary osteoporosis. So how do we evaluate the child for skeletal phenotype? So one can look at the clinical features. We all know that osteogenesis imperfecta will present with blue sclera, early onset fractures, recurrent fractures. But there are some other conditions also which can present with primary osteoporosis in pediatrics, which includes some skeletal dysplasias. One can look at skin laxity for some conditions like Ehlers-Danlos, which can have primary osteoporosis, vascular calcifications, spinomuscular atrophy, or some syndromes where the kids can have primary osteoporosis. If these features are present in a child with significant fracture, one may consider this as primary osteoporosis. Secondary causes, as I discussed previously, are some critical organ dysfunctions, inflammatory conditions where we use long-term steroids, some endocrinopathies which have been long-standing, and some medications like glucocorticoids or some lifestyle conditions which add to all these conditions resulting in secondary osteoporosis. So if you find any clinical features of this in a child with a significant fracture, then the child needs evaluation for osteoporosis. So the step 3 will be labeling the fractures, whether the fractures are major fractures or they are minor fractures. So major fractures are the fractures of the long bones and vertebrae. Also, flat bone fractures are considered to be major fractures. In these cases, even in absence of, or in these cases, less supporting evidence is required to confirm the diagnosis of osteoporosis. But when you have fractures of tibia, fibula, radius, or ulna, you need major supporting factors because these bones are very commonly fractured in pediatrics. Okay, so in that cases, you need stronger evidence to say that the child is having osteoporosis. So once you confirm that the child is either having features of primary or secondary osteoporosis with significant fracture, either fracture of the vertebrae or the long bone, you can go ahead and manage these kids. In case when you don't find any features, you can use the criteria of ISDC's 2013 statement, which says 2 fractures before less than 10 years and 3 fractures before 18 years of age. In that cases, you can also manage the child as osteoporosis. So how do you evaluate which kids will require treatment? So see, one needs to understand whether the child is likely to recover on its own or not. So in conditions where you know that the child is having spinomuscular problems or he is a case of osteogenesis imperfecta, the chances that the child's bone density will improve on its own is less likely. And in these cases, you might treat the child. But in conditions where the child is treated for transient conditions like leukemia or he has temporary immobilization, in that cases, you can wait and watch, monitor the child over 1 year, and see how the child is having further risk of fractures or not. If the child is recovering on his own, you don't need to treat these conditions, just monitor. Okay, so let's talk about the treatment. Since we know normal bone remodeling and abnormal remodeling, so anything that affects the bone remodeling will cause bone loss. So the treatment options are basically targeted towards this. So the treatment targets for low bone mass will be targeted towards decreasing the osteoclast, increasing the number of osteoblasts or osteocytes. So the treatment options that are available in pediatrics, or the treatments that are available, are anti-resorptive, which includes bisphosphonates, denosumab, SERMs, and calcitonin, which are anti-resorptive. Bone forming are recombinant PTH. And the dual-acting newer drug is romosumab or sclerostin inhibitor, which is still in pipe. Hello. Yeah. So the guidelines, what does the guidelines recommend? That in pediatrics, only calcium and vitamin D treatment has been recommended officially by the 2020 guideline, which was published in the Rheumatology Journal. But because of our long-term use of bisphosphonates in pediatrics, it has been seen that bisphosphonates are helpful in improving pediatric osteoporosis, mostly in conditions like primary osteogenesis imperfecta. And we have a huge experience of using bisphosphonates in these conditions. So what are bisphosphonates? Basically, bisphosphonates are anti-resorptive agents. They act on the osteocyte and cause apoptosis of osteocyte. Also, they modulate the signals to the osteoblast and osteocyte, resulting in new bone formation. That's how they improve the bone mineral density or the bone mass. So the bisphosphonates that are available are either oral versus IV. So oral bisphosphonates that are available are alendronate, or IV that are used are pamidronate or zolendronate. So which are better in pediatrics? Anyone? IV, okay. So yes, so this was a recent study that has been published in 2023, which is a meta-analysis which studied the efficacy and safety of bisphosphonates on childhood osteoporosis. So what they showed that both the IV as well as oral bisphosphonates are well tolerated, and also they have equal efficacy. But yes, there are some studies we say that the oral bisphosphonates does not have any role on the cortical width or increasing the cortical thickness. So hence, because of the huge data that we have, we prefer IV bisphosphonates in pediatrics. So the two common bisphosphonates that are used are either pamidronate or zolendronate. But with availability of zolendronate, more and more people are switching towards zolendronate. So these are the basic doses that are used. These are the initiation doses. And the side effects we know are flu-like reactions at the beginning of the dose, hypocalcemia if the child is not well treated or prepared before giving bisphosphonates, and the very rare side effect that has been seen is osteonecrosis of jaw, which has been less seen in pediatrics. The only contraindication for bisphosphonates is acute renal failure. So how long should we treat a child with bisphosphonates? So if you see the child, you have to monitor the child and ensure the child has stabilization of osteoporosis. That means there are no new vertebral fractures, vertebral bone reshaping has been achieved, there is no back pain, there are no new long bone fractures, and the BMD-Z scores are improving or normalized. In these conditions, and if the child has primary osteoporosis, you may switch the child on maintenance doses. So what a maintenance doses basically mean is you decrease the dose by 50%, what you are giving at the start, or even lesser than that, just to maintain the bone mass. And in primary osteoporosis patients, like in OI, some guidelines do say 2 years, 5 years, but this latest guideline says until the epiphyseal fusion, we can give bisphosphonates in patients with primary osteoporosis. And in secondary osteoporosis, we can give as long as the risk factors persist. If there is no improvement, one can continue the initiation dose till the stabilization is achieved. And once it is achieved, you can switch to maintenance dose. So the another drug that we discussed was denosumab. Denosumab is a rank ligand inhibitor, which again decreases the osteoclast activity and decreases bone resorption. It is available for subcutaneous injection, which can be given every 6 monthly. The major side effect that has been seen is hypercalcemia and rebound bone resorption. So what about the safety of denosumab? So this was a recent study that was published in 2024, where denosumab was tried in osteogenesis imperfecta patients. So here they did had 84 patients, and they were equally divided in denosumab group and zoledronate group. What was observed here, if you can see, that the denosumab group had major discontinuations. The dropout rate was around 7 at the end of the study of over 1 year. And the main reason was hypercalcemic crisis. So what does this study, in this graph, you can see that the hypercalcemia was very significant with denosumab compared to zoledronate. So the study concluded that hypercalcemia is very severe and common side effect in pediatrics, and hence it cannot be used as a first-line drug. Bisphosphonates still hold true, and they are more first-line drugs for pediatric osteoporosis. In addition, there are some anabolic agents which are in trial and they are not used in pediatrics. Parathyroid is not used in pediatrics, though it is used in adults because of the risk of osteocarcinoma in children. And that's all, I think. So my take-home message will be osteoporosis is more a clinical diagnosis. Adequate calcium and vitamin D supplementation is essential. Bisphosphonates are the mainstay of treatment in pediatric osteoporosis. You can refer to these guidelines for further evaluation.
I think thanks a lot, Dr. Sajali, for the wonderful talk. I think the one important message about bisphosphonates versus denosumab debate is that denosumab basically do not have a long-term impact as far as osteoclast is concerned. And when you're using denosumab, as soon as you stop it, the osteoclast which was suppressed suddenly go into an overdrive, and that causes hypercalcemia. So when you're using denosumab, there is no end date. If you stop denosumab, you will have rebound hypercalcemia. So some people in adults say you use denosumab and then switch to bisphosphonate. So in OI, you have to treat for a long time, and maybe sometimes you have to stop. This is not going to be a very good option on that perspective. Dr. Princey, your comments? Any questions? So if there are no questions, I'll now request Dr. Dhwani to kindly facilitate
Thank you, sir.
Sajali for this wonderful talk.
Okay, let me invite next speaker, Dr. Manoj Agarwal. He himself a fellow of CDER. He will be speaking on genetic obesity for the next 10-15 minutes. Over to you, sir.
Thanks, Dr. Stransi. And Dr. Manoj, again, is one of our fellows, and he's been doing really well in Ahmedabad, and he has been doing a lot of work in terms of type 1 diabetes, obesity, and it's really good to see so many people spreading across the country. And welcome, Manoj, again. Yeah.
Thank you very much, sir, for such a nice introduction and having me in the conference. And it is always love to be in Kanpur with all of my colleagues, seniors, and friends. So today I'm going to talk about monogenic obesity and genetic obesity. So this is the case of a 7-year-old girl who has a severe obesity. BMI was more than 3 standard deviation, had a pre-diabetes, and developmental history and all thing was normal. Genetic testing has been sent by a pediatrician, and that came as negative. And this is the patient. So does it require genetic reports? No. So in this case, it was overdiagnosed as the genetic obesity. So what I'm going to talk about next 10-15 minutes, that when to think about genetic obesity and when not to think. So mainly obesity we can divide into mainly 2 categories. One is the physiological, where growth and development and vision is normal. And second is the pathological, where you will find one gene is defected, which is a monogenic obesity. They do have a entire spectrum of disorder, which is a syndromic obesity, where you find the hyperplasia, vision, and the puberty issue. And another type where you find the hypothalamic damage, and because of that obesity occur, it is a hypothalamic obesity. Third is the endocrine, where you are very well experienced that growth is mainly affected. So when we need to suspect about the genetic obesity, so this is the guideline, endocrine society guideline. We suggest genetic obesity if it is present at very early age, before 5 years of age, there is a severe obesity, and if there is a hyperplasia is there. So 3 points we have to take into the consideration. That is the most common case presentation that we have to think about genetic obesity. Yeah. So as sir has told, that when we need to think about genetic obesity, is mother is coming to your OPD and mother is complaining that my child is severely obese and age is less than 5 years of age. This kind of presentation you can see, you find depressed child and worrisome parents. Mother is complaining, my child is always hungry, they have to lock the fridge, the child is eating from garbage, the child is eating ice. That kind of complaint if you are seeing, and a mother is especially complaining that I have lost control over my child because I constantly child is eating and eating from garbage, and a mother is asking for meditation to stop her hyperphagia. In this case, you have to think about genetic obesity. Yeah. So as Dr. Nitya has said, when we think about something which is associated with genetics, if it is severe, okay, how much severe? If below 5 years of age, then we have to think about genetic obesity, but the prevalence is always very, very low. Among the less than 5 years of age, you will find 5% case as a genetic obesity. If they have hyperphagia, then you have to if they have severity, severe obesity, severe BMI included, then you have to think about, are they taking excessive junk food? That in that case you don't have to think about. If they have, you have to rule out the endocrine causes as well as. Yes, if family is affected, if parents is affected, in this case, you have to think about genetic obesity, and the syndromic features is there. You have to think about genetic obesity. So why obesity occur? So it is always balanced between the intake and the energy expenditure. We eat for the survival pleasure. Here, suppose if we have gulab jamu, then we can eat more. So we eat for the pleasure, and we have different centers for working for that. No, there is a interplay between the ghrelin and the leptin. What is the ghrelin? Ghrelin is a hunger hormone, and the leptin is a satiety hormones. So if there is a mismatch between two hormones, then it can cause the obesity. Mainly the genetic obesity can cause due to the leptin defect. And it is mainly due to the satiety issue. This is a very complex slide. So we do have a two hormone from the GI tract and the stomach, which tells to our brain that I'm hungry, I need to eat. So this is the hunger signaling. And second one is that we do have, if we have enough eaten, then we from our adipocyte there is a leptin secretion which goes to our brain and which tell to our brain that now I'm enough, I have eaten well, so I have to stop eating. So this is the mainly there is a regulation of hunger and satiety center. And this is the simplified approach. From the fat cell, there is a secretion of the leptin, which goes to your brain, which work on the POMC. POMC, they go to the MC4 receptor, and for there, you will have a signal of satiation. And so if I divide genetic obesity, then if one gene is affected, then we can call as a genetic monogenic obesity. If whole entire spectrum of disease is there, then we can call as a syndromic obesity. In the genetic obesity, you find developmentally normal child. In there is a leptin deficiency, could be the leptin resistance, POMC, MC4 receptor defect. If development is affected, then post MC4 receptor defect you can find. In the cases of the syndromic obesity, you are very well aware about the Prader-Willi syndrome, Prader-Willi syndrome, Alstrom syndrome. So I'm going to talk about the monogenic obesity right now. So are you seeing the mouse? This mice. Yeah. So same age mice is there, and this child has a double weight than the two previous mice. So and then the scientist has found that this has a obesity because there is a absence of leptin called gene in this mice, and this is how the leptin deficiency has been found. So this is the case of the leptin deficiency. You will find mutation in the leptin receptor. Here, if you do the leptin, then leptin level is very, very low. So if leptin is low, then it is a more specific for the leptin deficiency rather than the high leptin. So here you will find low leptin, and prevalence is extremely rare. So by this discovery, scientists were very happy that if we give leptin to everyone, then everyone will be treated. But no. So there was only few rare cases is there which have a leptin deficiency. And by the diagnostic test, you have to do a leptin and the genetic treatment. And the treatment is a metylleptin available, which is available in injection form, subcutaneous. So this is the children who are at the 3 year of age, weight was 40 kg, and after the leptin treatment at the 29 kg of weight at the 6 year. And you can appreciate this the weight at the 8 year. The child had a weight of 86 kg. And this is the mouse of the leptin receptor deficiency. So leptin was there, but it was not working. So they do have a similar kind of presentation. They begin with the very normal weight, and as they age progress, they turn into severe obesity. And this is the child at the 2 year of age. You can find the 38.7 kilogram per meter square of weight. So how severe obesity you can see in this defect. So how does it occur? So it is due to the mutation of the leptin receptor defect, and it is very rare. And phenotype you will find similar to the leptin deficiency, like you will have a severe obesity with the problem in the pubertal development, because leptin is a toll maker for the puberty and the growth. And the diagnostic test here, you will find, if the leptin you do, then you will find a high leptin, and confirmatory result will be the genetic testing. And what are the treatment available? Now MC4 receptor agonist is working well with this kind of the obesity, which is setmelanotide. Yeah. So this is the POMC mutation. I think you all are aware. This is a 2-year-old boy who has a severe obesity, presented with the neonatal hypoglycemia, and he had a frequent respiratory infection and found to have a adrenal insufficiency with the thyroid deficiency. So generally in the adrenal insufficiency, you found children with a low weight, but here there was a obesity with the adrenal insufficiency. Though this was the defect of the POMC defect. And what is the treatment? Treatment option is a hydrocortisone. You have to replace, and you can try with the MC4 receptor agonist in some case study. So this is the POMC mutation. By giving the MC4 receptor, how dramatically weight reduction is there. Another is a pro-hormone convertase deficiency, where you will have a defect of the insulin metabolism. So you will have a diabetes, you have a diabetes insipidus because of the AVP is not secreting, and you have GnRH deficiency along with the severe obesity. And here treatment is a hormone replacement. And again, MC4 receptor mutation. In this case, treatment is very nicely available, that where MC4 receptor is not working. Here you will find very tall child because of the insulin resistance, and there will be a severe insulin resistance will be there. And how you will diagnose? It is by the genetic testing, and let me tell you that it is very it is very common in the monogenic obesity. So among the 3 to 5% of the case you will find of MC4 receptor. And treatment is very nice. MC4 receptor, which has been launched, which is approved after November 2020 by the FDA. And the setmelanotide has a promising result, not only for the MC4 receptor, but also for the POMC defect, for the PCSK1 defect, leptin receptor deficiency, and also for the broader Biddle syndrome. So I am going to talk about the syndromic obesity. So when you have to suspect about the syndromic obesity, if it is severe obesity, mental retardation, you will find organ related some developmental abnormality. And if you find the family is included. So I think this child is not looking obese, but what I want to convey that this child has a hypotonia, and the feeding tube is inside her mouth. So that means he has a feeding difficulty with the hypotonia. So this could be the presentation of the Prader-Willi syndrome during the infancy. And as the age progress, they start developing obesity due to the hyperplasia. And this is the child that we have managed in the Kanpur with the sir. And he was admitted for the respiratory failure, almond-shaped eye, acromicra, micropenis, all symptoms was there of the Prader-Willi syndrome. And why does it occur? It is occur due to the different pathology. It is mainly imprinting defect, where mainly in this majority of case you will find the paternal deletion. In some case you will find maternal duplication and imprinting defect. And what is the treatment option is available? Here you can give the growth hormone after ENT workup, and GLP-1 analogs has been tried, liraglutide, but it decreased the hyperphagia score rather than the decreasing the obesity. And here the behavior therapy and dietary restriction is the mainstay of the treatment. So, and the carbetocin, the oxytocin has been tried for this patient, and it has it gave some result that the carbetocin 3.2 milligram has been a very good response in decreasing the hyperplasia in the Prader-Willi syndrome. So this is the case of the Prader-Willi syndrome, that you will have a difficulty in the vision mainly, and you will find polydactyly, and also cilia is also affected. So there are the features that if you have a primary criteria and the secondary criteria. So if you have 4 primary criteria, then you can label as a Prader-Willi syndrome. And if you have 3 primary plus 2 secondary, then you can label as a Prader-Willi syndrome. And diet restriction, metformin was a previous available treatment. Now, since 2020, you can give a trial of the setmelanotide here. And this is the case that I have managed, that you can appreciate in the picture that the child has a very short stature, obesity with the brachydactyly, and there was a hypocalcemia at the onset. So this is the case of PHP, pseudo hypoparathyroidism. And it occurred due to the inactivating mutation of the GNS1. And if you find the normal parameter, biochemical parameter, then it can be coming from the father. So it is a pseudo hypoparathyroidism. If mother is it is coming from the mother, then you will have a AHO phenotype plus biochemical parameter. So syndromic causes of the obesity, in that case Prader-Willi syndrome is most common. There you have a treatment of the growth hormone, GnRH, GLP analogs you can try if diabetes develop. And in the pseudo hypoparathyroidism, we can give trial of MC4 receptor agonist, but it is not well established. Another Prader-Willi with the metformin, you can give a setmelanotide, and for the Alstrom, and another syndrome, you have to give a lifestyle modification. So if I summarize my slide, then if growth, puberty, and everything is normal, then you can label as a exogenous obesity. You have to work up for the obesity complication rather than the diagnosis. If it is all thing is affected, if slow growth is there, then it is endocrine obesity. If the early onset, you find the developmental delay, if you find the dysmorphism, then you have to think about the syndromic obesity. You do karyotype, you do methylation, you do FISH. And if it is you find abnormal, then it is Prader-Willi syndrome. If it is everything is normal and you will find the defect in the vision, then it could be the Prader-Willi syndrome or Cohen syndrome. Everything is normal, development is affected, then it is a BDNF1 type. And another reason, if developmental delay is not there, then you can see for them genetic kind of obesity. If you do leptin, if leptin is low, then you can label as the leptin deficiency. If it is normal, then you can label as a post-leptin receptor deficiency, like MC4 leptin receptor deficiency or the POMC deficiency. So thank you very much for such.
Thanks a lot, Manoj, for this wonderful talk and for summarizing this session. I'll just have a look at any questions which are there from the audience outside. The chairpersons, can you please have the inputs?
Very nice presentation, Dr. Manoj. Any comment on growth hormone therapy in a patient of Prader-Willi syndrome who is having obstructive sleep apnea?
So first, if we are giving in the growth hormone in the Prader-Willi syndrome, then we have to do a workup for the ENT. If it is there, then it is not. We don't give, because it can cause a further obstruction in the sleep apnea.
So you have to correct it using either the surgery or the other measures, and then only go ahead with surgery. We have a question from Dr. Edeli from Cameroon, What is the difference between osteomalacia and osteoporosis? So I think that is related to the vitamin D causes, and osteoporosis is more of the overall the component as far as the matrix component is concerned. So if you have a predominant problem of calcification, we tend to call it more like osteomalacia, while osteoporosis will be overall matrix. But however, from a bone strength perspective, vitamin D deficiency can also cause a similar picture. Thank you, Dr. Manoj. Thanks a lot. We'll request Dr. Vibha to give a hand over a memento to Dr. Manoj. Yeah, carry on.
Moving on to our next topic, congenital adrenal hyperplasia. For this, we have an excellent speaker, Dr. Sugandha S. Over to you, ma'am.
Yeah. So Sugandha has done her training under Dr. Raghupati, and she is currently working as a pediatric endocrinologist at Moradabad, and she has been closely involved with us in past sessions as well. Thank you.
It's my privilege to be here for the second time, and I thank Anurag sir for giving me this opportunity. So without any further ado, I've been told that the steroidogenesis pathway, its pathophysiology and classification has been covered well in advance in the previous sessions. So here we'll be focusing more on the diagnosis and the management part. So as we all know that during childhood, cortisol is the predominant hormone that is produced from the adrenals, and it is produced at the rate of 6 to 8 milligrams per meter square per day, while aldosterone is much less, being secreted at 0.1 milligrams per day. So what happens in 21 hydroxylase deficiency is that there is a deficiency of mineralocorticoids, deficiency of cortisol, and the excess of adrenal androgens. This condition is relatively common, being found in 1 in 14,000 to 18,000 newborns on the newborn screen, and it is an autosomal recessive condition. And what happens with the excess androgens is that the increased levels of 17-OHP, they enter the backdoor pathway and get converted directly to a more potent form of androgen, which is dihydrotestosterone via the alpha ketoreductase. And this DHT is the main cause of virilization in female fetuses. So depending upon the residual enzymatic activity, their CH has been classified into severe salt wasting, in which we have less than 1% of residual enzymatic activity. So the children present with severe salt wasting, severe cortisol deficiency, and because of the excess androgens, there is DSD in girls. And sometimes the male children escape presentation and land up in crisis. So here we know that the treatment is by hydrocortisone and fluorocortisone replacement. But what happens with the simple virilizing form is that the residual enzymatic activity is around 1 to 5%. So there is no overt but covert aldosterone deficiency, and children present a little later with atypical genitalia in girls, precocity in boys. And because of the covert aldosterone deficiency, here we see that the dose requirement of glucocorticoids is high. So it is worthwhile to add fluorocortisone to the treatment. And in the third form, which is the simple, which is a non-classic form, you see that there is no the enzymatic activity is up to 20%. So there is no salt wasting, and these are classically known as late onset CAH because these children present with features of hyperandrogenism. So boys present with acne issues, while girls present with hirsutism, oligomenorrhea, and subnormal fertility. So the Endocrine Society routinely recommends against the use of glucocorticoids in these children, while if you add hydrocortisone, they will cause suppression of adrenal androgens. But because of its long-term effects, we can alternatively treat them with estrogen-progesterone combinations, where the progesterone will be such that it has some mild anti-androgenic effects, something like desogestrel along with ethinyl estradiol.
So coming on to the diagnosis, we know that 17-OHP is the test of choice. But there are a few catches here. Like at what time should we collect the sample? So it should be collected as a fasting 8 a.m. sample. And in postmenarchal girls, it should be collected on day 2 to day 10 of the menstrual cycle. Because we've seen that there is a post-ovulatory rise of 17-OHP. And if a child is amenorrheic for a longer period, it is better to do serum progesterone levels along with 17-OHP. So as to be sure that progesterone levels are low, that means we have collected the sample in the proliferative phase and not in the post-ovulatory phase. Another precaution to be taken is during newborn period, there are higher levels of circulating sulfated compounds. So if we do 17-OHP, we have to ask for extracted levels. Otherwise, we'll get false positive results here. So false positive scenarios are prematurity, infection, stress, post-ovulatory rise, and some adrenocortical tumors. Now we should be able to interpret the 17-OHP levels. So what we can see is if the levels are really low, something like 300 nanograms per deciliter or 3 nanograms per ml, then CAH is unlikely. But if the levels are very high, above 35 nanograms per ml, then consider 21-hydroxylase as a potential differential. And if the levels are in between, somewhere between 3 to 12 nanograms per ml, always consider causes of some variants like 11-hydroxylase deficiency, 3-beta-HSD, and POR deficiency. And if the levels fall between 12 to 35 nanograms per ml, it is always followed up with the ACTH stimulation test. If the stimulated levels are less than 10, that means CAH is unlikely. But for levels above 10, then consider 21-hydroxylase as a possible diagnosis. So newborn screening, this condition is, it meets the newborn screening criteria. Why? Because this is relatively common and it presents as a lag phase and it's life-threatening. And with a robust test like 17-OHP, there are high chances of picking up children with 21-hydroxylase deficiency. So when should we collect the sample? It is done on day 3 of life to avoid the early CRH surge. And it should be done on a filter paper dry by heel prick samples. And when the levels are done in the newborn screening, they are done by immunoassays. So immunoassays have high sensitivity and low specificity, meaning if you will pick up all the true positives, but you will also pick up some false positives. So if on newborn screen, beyond a certain level of cutoff, all these children should be recalled for a second level of testing. So second tier testing is done when the 17-OHP levels on a newborn screen are above 12 nanograms per ml. And here, when we do the second tier testing, we should always ask for extracted levels of 17-OHP by tandem mass spectrometry. Also worthwhile to do sodium potassium levels here. And if clinical suspicion is high, then we can actually consider doing a genetic test also. If the levels are less than 3 nanograms per ml, CAH is unlikely. And again, if the levels are in between 3 to 12, always consider the possibility of variance. False positives can be seen with prematurity, infections, antenatal steroids. So here, antenatal steroids given to mother will actually cause false negative in the on 17-OHP estimation. The levels will be falsely low because it will cross the placenta, and because of that, the levels will be low. So prenatal diagnosis can be done by amniocentesis, in which we take the amniotic fluid and send it for androstenedione ion estimation. But the preferred mode is by doing chorionic villus sampling. You can obtain the fetal DNA for genetic analysis, and this can be done at 10 to 11 weeks of gestation. Now, coming to the management part, the Endocrine Society has laid down some clinical practice guidelines. So I'll be moving on to that. So first, we should know the acute management of adrenal crisis. Adrenal crisis can be precipitated by infections in children who are on glucocorticoids, but they fail to receive the stress doses. So here, the child will be dehydrated, will have hypoglycemia, and will require higher levels of glucocorticoid replacement. So first, maintain the ABCs. Start with fluids, give 20 ml per kg of bolus with an isotonic saline,
and repeat up to 3 times if required, and send for some send electrolyte levels here. Glucocorticoid replacement should be started by a bolus. Give 100 milligram followed by maintenance dose of 200 milligrams, which can be given as a continuous IV infusion, or it can be given as a divided dose. Then once the child is stable, then consider tapering the level of glucocorticoids over the next 24 hours. And if the likely cause here is infection, then consider adding antibiotics. Hypoglycemia can be managed by giving boluses of dextrose 10% for a child who's less than 12 years. Give 5 to 10 ml per kg of D10. And if the child is more than 12 years, then you can consider giving dextrose 25%. So sometimes what happens is that we see newborns in salt wasting crisis, especially male children who have avoided early identification, and they directly land up in salt wasting crisis. Here also the management remains more or less the same, that we have to maintain the ABCs first, start giving IV fluid bolus, and put these children on double maintenance of IV fluid. Here we should give half normal saline with 5% dextrose, correct the hyperkalemia, correct hypoglycemia, and once and then start giving glucocorticoid replacement. Initially given as a bolus of 50 milligram per meter square per day and a maintenance of 100 milligram per meter square per day. And once the child stabilizes over the next 2 to 3 days, then typically bring down the doses. And once the dose reaches 50 milligram per meter square per day, consider adding fludrocortisone at this point. So hormonal treatment in CH, actually we face some challenges with that, because first is that it fails to mimic the circadian rhythm. Second is that the adaptation to stress is also not seen, and there's also a constant juggle between over treatment and under treatment. So let's go age wise. That during neonatal period and early infancy, we know that glucocorticoid replacement is done by hydrocortisone. That is the drug of choice, because it has least effects on growth suppression. A supraphysiological dose of 10 to 15 milligram per meter square has been found to adequately suppress the androgens, and that is the dose that is to be used. But because of its shorter half-life, it needs to be given 3 to 4 times a day, and that makes it difficult to stick to the adherence. It can be mixed with food and given. Fludrocortisone replacement should be started in all newborns even before who've been picked up on newborn screening and they have not yet developed hyponatremia. And we know that because of relative mineralocorticoid resistance and because of the anti-mineralocorticoid effects of 17-OHP, the dose requirement for fludrocortisone is usually higher in the early infancy period. So the dose can be up to from 100 to 200 microgram per day given as OD or BD doses. Additionally, these children may require supplementation of sodium chloride because of the relatively low sodium content in the diet. So that can be given as 1 to 2 grams per day in divided doses, given in form of common salt or crushed sodium chloride tablets. During childhood, basically, if we can bring down the dose of fludrocortisone, that should be considered, and weight adequate doses of glucocorticoid should be given. The target here will be the monitoring part. Basically, you have to monitor this child for adequate growth and also monitor their 17-OHP levels. So target 17-OHP levels here will be between 4 to 2 nanograms per ml, and also you can do androstenedione levels for monitoring purpose. We do not aim to normalize 17-OHP, because doing so, we can actually give more glucocorticoid replacement and push the child into iatrogenic Cushing syndrome. This we have already covered. Here, just one mention I would like to make in the adult section, that there is one plenadrin, which is a modified release hydrocortisone. Basically, it is just a long-acting hydrocortisone, but this has been in use in adults with adrenal insufficiency. As of now, its role in CH is not yet established. So this table just compares the different glucocorticoid preparations. Hydrocortisone is the drug of choice in all ages. And the side effect profile of prednisolone is somewhere between hydrocortisone and dexamethasone. It can only be used in children who have completed growth and are requiring, usually pubertal children, they are requiring higher dose of hydrocortisone. Then maybe they can be put on prednisolone for a while, or they are facing menstrual irregularities or for fertility induction. Dexamethasone is only to be used in children who have developed testicular adrenal rest tumors. So this picture clearly depicts about the treatment effects in CAH. So if the dose of hydrocortisone, what happens is that the hydrocortisone has local effects on the growth plate. And if a supraphysiological dose is being used or a higher dose is being used, then these children will have growth failure. And if the dose is administered is less, then what will happen? That there will be advancement with there will be advancement with growth and the testosterone, higher levels of testosterone because of inadequate suppression, and that will lead to testicular adrenal rest tumors. So deficiency will present as increased bone age, early puberty, and testicular adrenal rest tumors. While the effects of fludrocortisone can be monitored by potassium and blood pressure, so if the dose is higher, the child, if the dose is in excess, the child will have hypertension and hypokalemia. But if the fludrocortisone dose is insufficient, then what happens is that triggers hypovolemia, because of which AVP secretion will happen, and AVP will cause excess ACTH stimulation. And if the ACTH is high, then the ultimate glucocorticoid requirement also increases. So if the aldosterone dose is low, then you will have hyperkalemia along with a higher need for hydrocortisone. So in a child who's following up with you, who's diagnosed as CAH, you need to do clinical monitoring with growth, pubertal signs, blood pressure, ask about the pigmentation, and look at the testicular size. That will give you a fair idea about are we really over-treating or under-treating. Lab monitoring can be done with androgen level estimation in form of androstenedione and testosterone. That the aim here should be normal values for sex and age. 17 UHP, as previously discussed, that aim should not be to normalize it. It should be targeted between 4 to 12 nanograms per ml, and potassium should be in the lab ranges. You can also do salivary levels of 17 UHP, and the target here would be three times the upper limit of normal. And bone age will give you a fair idea. If the bone age is retarded, that means we are over treating, and if it is advanced, that means we are under treating. So stress dose, as we all know, that all caretakers should be informed that they have to give stress dosing in cases of infection and major stress. It can be the dose of hydrocortisone needs to be increased, and it should be given 2 to 3 times the usual dose. And they should also keep in injectable form of hydrocortisone available with them, so as to if in case the child is vomiting, is not able to tolerate orally, or if the child is going through a major stress, then parenteral use of hydrocortisone can also be done. The dose of fludrocortisone does not require, you need not increase the dose of fludrocortisone. So common scenarios where we need to give stress dosing, like if the child is having fever, high grade fever, so triple the dose of oral hydrocortisone and maintain hydration. Give simple and complex carbohydrate to ensure euglycemia. In cases of gastroenteritis, if the oral dose is not tolerated, then you can consider giving parenteral form of hydrocortisone, or consider admission in this case if the child is not able to, if there is oral replacement of fluids are also not possible and the child appears dehydrated. In cases of major surgery, before any scheduled surgery, you have to give hydrocortisone bolus in the dose of 50 to 100 milligram per meter square, followed by continuous IV infusion throughout the surgery. And once the child is stable, has been shifted to the ward, or has shifted to oral diets have been allowed, then you can consider giving oral hydrocortisone. For some simple procedures like dental surgery, need not give, just give a morning double dose of hydrocortisone, and depending upon the recovery, you can see whether stress dosing is required or not. So my last slide would be about some novel strategies. in the future management of CH. The modified release preparations we've already talked about. So one study, they did a study on where they were using hydrocortisone along with combination of testolactone and flutamide, and here they found that the growth potential and even the bone age was normal for these children, and they were studied for over almost up to 2 years. And but the final outcome of this study is yet to be seen. And another mention I would like to make is about abiraterone, which is a potent CYP17A1 inhibitor, and it is currently being used in cases of prostatic cancer. But when abiraterone was used along with hydrocortisone, it was found that it remarkably reduced the levels of androstenedione and testosterone, and that is why this holds potential use in severe cases of CAH in prepubertal children. And last is the category of CRHR1 antagonist. They were found to reduce the ACTH mediated androgen drive, and single use of this drug, they found that the levels of ACTH and 17-OHP were normal. So these group of drugs have now entered into the preclinical trials, and we still need to look forward to these drugs in the future management of CAH. That's all. Thank you so much.
Thanks a lot, Dr. Sugandha, and for a wonderful session. This was a very good session in which we focused on varied disorders like low bone mass, rickets, in terms of CAH, monogenic obesity, and the thyroid nodule. So it was a comprehensive session. We'll see if there are any questions from our audience here or from the chairpersons.
Any comment? First of all, very nice presentation, madam. Any comment on the feasibility of this renin, this plasma renin activity during the monitoring of CH patients?
So renin levels also can be used for monitoring, but in younger children, I think it's more difficult because it has to be corroborated with their standing height, and they need not, along with crying also the renin levels get increase. So I think more feasible would be 17-OHP and androstenedione levels.
Yeah, I think renin would be relevant if you're thinking of problems like persistently high requirement of hydrocortisone despite a good dose. That would be because of this covert hypovolemia that you was talking about. If your sodium potassium are normal and yet your blood pressure is on the lower side, so those sort of scenarios, it will be better on that. So I think I'll thank all of you for the patient hearing. I request Dr. Sumanna to kindly come up and felicitate Dr. Sugandha, please. And I'll thank the chairpersons, Dr. Princey Joseph, Dr. Vikas Mehrotra, and Dr. Pradeep for this wonderful session. And I think we'll move on to the next session, Dhwani.
For the next session, I would like to request Pradeep sir to stay back to chair the next
Or maybe
session.
Dr. Arpita can come in because, yeah. Yeah, Dr. Arpita can come. Yeah.
So for the next session, I would like to invite Dr. Sumana ma'am and Dr. Arpita ma'am to chair this session. Sumana ma'am is an additional professor in pediatrics at R&D Institute of Medical Science, Kolkata. And Arpita ma'am is again an additional professor in pediatrics at KGMU, Lucknow. Our next session is on endocrine diagnostics. Now we know that most of our patients depend on lab diagnostics to prove or confirm a diagnosis, and to understand the finer intricacies of these diagnostic processes, and to understand the finer errors that can occur in the ordering of these tests and how these tests are conducted can significantly affect the diagnostic establishment of the diagnosis and management in these children.
Yeah, over to the chairpersons.
Hello, good afternoon, everyone. Thank you, Dr. Vajpayee, for this honor. It's a very important session, and I know, although it's the middle part of the day, but it is so very important as endocrinologists to know about not only what to send, but how to send. So, because all will depend on that. So, I think the first session is on hormone assays. Over to Dr. Alappan and Anurag, sir. Thank you.
Okay, so basically endocrinology is all about investigations, and we want to do tests in the right way, the right time, interpret it correctly. Because if our interpretation of the testing is wrong, then there'll be no point doing everything, and we'll be doing a mismanagement in that perspective. So this is going to be a dialogue. The next 3 sessions are going like that. So we'll have a dialogue. So we have Alapan here, then we will have Dhwani, and Vibha will talk about the unique thing subsequently. So this is like a dialogue as to what case scenarios we see and how those case scenarios can help us learn about pediatric endocrinology. So hormone assays, as I said, are vital in pediatric endocrinology. They are often a game changer, but they are often complicated. There are so many things happening in terms of how to send the sample, when to send the sample, which sample to choose, which technique to choose, and how to interpret, which causes so much confusion. So we need to be very clear about assays which should be precise, accurate, and interpret it very well. Now, endocrinology is a challenging condition because we are dealing with large molecules. We are dealing with a wide range. Now, if you look at sodium, you're talking about a range of around 130 to 150. For TSH, you're talking about a range of minimum of 0.4 to 5. So it's like 1,000% changes in terms of the interval. So this is something which is very important. Things are changing during puberty. Levels will go up and down. There will be a lot of other diurnal variations as well. So this needs a lot of understanding, and I think this talk is important. So why do we do an endocrine test? One is just to do screening, like we want to rule a particular condition out. There you want to have a test which has got a higher sensitivity. Then to establish a diagnosis, you want a test which has got a higher specificity. Then to monitor, of course, we talked about 17-OHP, androstenedione, things like that. But the key message is do a test only if it changes your decision. Do not do the test unnecessarily. Only if you have a high pretest probability. I'll talk a bit about that. And if it changes your treatment effect. So we'll have the first case coming on to Dr. Alapan.
Good afternoon, everyone. So we have this 10-year-old boy presented with growth failure. The height was short, 127 centimeter with standard deviation score of minus 2.4. Weight was 14 kg, which was a bit less, minus 4.8 standard deviation score. The screening normal workup was normal initially, and someone did a IGF-1 level, and it seems to be low. So, Dr. Anurag sir, I would like to know whether this test is necessary at this particular point of time, and what is the importance of IGF-1 in this setting?
So what we're seeing clearly, this child is short. So definitely in short stature, we talk about screening for various causes. But the first thing is a clinical assessment. So what you can see clearly here, what is more affected? It is height or weight?
This is the weight more affected.
So this is more likely to be a nutritional cause. So this low IGF-1, I would say, first of all, it should not have been done. IGF-1 is not a good test in a malnourished individual. And this basically will give you a false diagnosis. And that's why the growth hormone stimulation test was normal. So when you are doing endocrine assessment, there are a lot of errors which can happen from when you're prescribing a test and when you are interpreting a test. You can have issues in terms of the test, the timing, as I said, the sample, how you processed, which technique, and all these errors can be there. So errors can be pre-analytical, in which before you have writing, analytical, or post-analytical. So what do you think is the most common form of errors in endocrinology? Is it pre-analytical or post-analytical?
It's a pre-analytical.
So it's actually more than 50% errors are happening at our level. So it's first of all we to blame before we start blaming, and 50% there and 20% in terms of post-analytical. So 70% errors are at the level of the treating physician and 30% may be at the lab level. So you need to be very cautious in that regards. So the type of test you send, sample, labeling, processing, then 30% errors may happen, which we'll talk about, whether there's the issue of precision in terms of quality, interference, and other things. And then very important, if you're not interpreting the levels properly, the range is given wrongly, the reporting is wrong in that regards. So if I go back to this case, as I said, this is a wrong test. It should not have been done in a malnourished child. So malnourished and a liver disease, why do IGF-1? This is not really required. So generally, we tend to do a direct hormone assay for large hormones which are stable, like FT4, cortisol, and testosterone, which are not changing a lot. We tend to look at co-secretors. So where do you do co-secretors, Alapan?
Like in case of C-peptide level.
So when your primary molecule has a
less stability in terms of
short half-life. So classical example is insulin and C-peptide and copeptin and the AVP. So other thing you do is, of course, to look at the effect of the particular hormone. And the classical example is ketone. So the most sensitive marker of hyperinsulinism is hypoketotic hypoglycemia. So look at the effect. If your phosphorus is low, your PTH should be high. If your phosphorus is high, your PTH effect is not there. So always look at those parameters first before you go ahead otherwise. And of course, you can look at metabolites like cortisol in that regards.
So this second case, a 15-year-old boy presented with obesity. He has all the features of Cushing syndrome like hypertension, striae, blood pressure was elevated, but the overnight dexamethasone suppression test was suppressed. It's 40 nanomole per liter. Sir, in spite of having all the syndromes of Cushing syndrome, do you think this test is reliable on this regard?
So I think a lot of things have to be looked at. Most important thing would be what sort of sample you're using. So we know that we have the whole blood. The whole blood has got a lot of enzymes. So whole blood is only good for point of care tests, like doing ketones, like if you want to do blood sugar. So only labile rapid changes you can do. Then if you remove blood cells on, then you get the plasma, which again has got multiple factors. So plasma again is not something which is very, very good test. It's a labile one, they're dynamic changes. So it's good for things like ACTH. There you want to do plasma. For all other scenarios, you use serum, which is much more stable, where you have removed the clotting protein, and the serum would be quite good and stable for peptides and other steroids. So whether you're using the whole blood, plasma, or serum will make a difference, because matrix does have an impact in terms of hormonal assessment. You can sometimes use urinary, as we were discussing, for especially for steroids, and we talked about salivary, Dr. Sugandha talked about, in terms of cortisol or 17-OHP also. You can do that for these small molecules. So now in this case, the ACTH level, which was done on serum, was found to be elevated, but MRI was normal. So serum ACTH is not good. We should have gone with
plasma ACTH.
We should have gone with plasma. So selecting the type of sample you are sending also is very, very important in that regards.
So in the next case, 11-year-old boy presented with growth failure. He had a significant growth failure of height standard deviation score less than -5.4, has an immature facies, and all the screening initial investigations were normal. So someone did a basal growth hormone level and it came to be low, and he was diagnosed as growth hormone deficiency. But sir, I would like to know whether this basal growth hormone level is any role in this child.
So compared to the previous case, the pre-test probability of growth hormone deficiency is much more higher in this case. This is very short and has immature phases. But basal growth hormone, as we know, growth hormone has a pulsatile secretion. So this basal growth hormone is of limited role at all. So if you have a pulsatile secretion like growth hormone, cortisol, prolactin, and testosterone, you have to be very, very careful in that scenario. You can also have diurnal variation. The classic example is that of cortisol, which is highest in the day, lowest at the night. So you have to choose when do you want to that particular sample. If you're looking for excess, you will do in the
night time.
In the night time, if you want to do for deficiency, you will do in the morning. So that becomes important. Then there are some hormones, particularly the reproductive hormones, the LH, FSH, progesterone, 17-OHP, which we discussed, testosterone, who have a marked menstrual variation. So there you have to decide what day of period, proliferative or secretory, where you want to do it in that regards. And then you have seasonal variation in thyroid, in the setting of vitamin D, in the setting of estradiol. So here, of course, you have a problem of pulsatility. So what you could have done is you can do a pooled sample like LHFSH. So how do you pool the sample? You take 3 samples, do the value and average it. So you take sample 3 times 0, 15, 30 and take all the values and average it. So you mix all the 3 samples and then do the single value. There's no need to doing three values there. Then timing, cortisol, as I said, morning for deficiency, night time for excess. Co-secretion like C-peptide may be a good idea, and you can do a growth hormone dynamic. So coming back to this case, what do you think would have been the best strategy?
Best would be, we would rather want to go for the growth hormone stimulation test in this child, because we are not suspecting any growth hormone insensitivity in this case. So
GHST will be important. So only indication Alapan has said is if you have a very strong possibility of growth hormone insensitivity, cost is an issue, get a basal growth hormone. If it's more than 5 in a short child, that could be growth hormone insensitivity.
Now the 13-year-old boy presented with weakness and pigmentation. Sodium level is normal, potassium is 4.6. Cortisol done was in the lower range.
So pigmentation is a common finding. We can see pigmentation in various conditions, B12 deficiency, some infections, some other conditions. So it does not mean alone that if you have pigmentation, you will have cortisol deficiency. So the key question here is this cortisol significant or not? So isolated cortisol deficiency, even if it at 8 a.m., I would not consider it significant unless there is hyponatremia, unless there is hypoglycemia, unless there is stress, or if you have a ACTH, which is more than 3 times the upper limit. But what is the time of this cortisol, Alapan?
It was done in the evening. So probably
So this cortisol, again, we remember that there is a distinct peak, which is happening in the morning, and the levels are low at evening. So if you do the cortisol at evening, your levels will be low. So clearly the error here, once we did on 8 a.m. was corrected. So what is your key message here?
We should see the diurnal patterns, which hormone we are doing.
Yeah.
And we have to go according to the.
So only do the sample when is the right time in that regards. So this was a wrong timing which is there.
Okay. Now the next case with a 15-year-old girl with hirsutism, menstrual irregularities were there. Hirsutism was in a moderate level with FGS score of 12, and someone did LH and FSH level. LH was raised, also the FSH one.
So what does a high LH mean? Let's forget about this sample. What does high LH mean? Is it diagnostic of PCOS?
No, sir. It could be a variation of normal variation also. We have to see when the LH has been done and also the FSH has been done.
And the other thing is that LH is not driving your PCOS. This high LH may actually be the effect of PCOS rather than the cause of PCOS. So don't give too much importance to these LH, FSH values. What's more important is your Ferriman-Galway score. What's more important is your testosterone level. So that becomes critical from that perspective. Now, my question is, what was the time of this LH? Because we know that you can have severe peak of LHs, which is happening in between. And if you do at this time, your entire value will be compromised. So this was done at a intermediate time of period.
Yes.
So day 2 period, now the levels are normal. So what does it mean?
That means this is just because due to the ovulation and this level was high, but we've done the day 2 level, it was normal in this child.
So it was a wrong timing.
So now the 6-month-old girl presented with seizure. Calcium level was low, with phosphorus level was also low. PTA is done, was on the lower side. Also the vitamin D level was on the lower side.
So now your question is it PTH deficiency or vitamin D deficiency? So as I said, one marker is the effect of the hormone. What is the effect of PTH deficiency?
The phosphorus should be in the
high. And what about vitamin D deficiency? It should be low. So if you go just by your biochemical parameters, this picture is vitamin 2, a vitamin D deficiency rather than a PTH deficiency. So before doing anything, I'll say this PTH I am very, very doubtful of. So that becomes important as how have you transported. Now, many of these peptides like ACTH, PTH, insulin, they would be very sensitive to temperature changes. So you can't just say, okay, go to the collection center, give your sample, and by the time it goes, it's already destroyed. You also have to think of other samples where you don't freeze like ADH or IGF-1, or those who are not affected by temperature. You can put it there, growth hormone, cortisol, TSH. But remember these 4, they are of absolute importance in which you want to avoid that. So now what has happened then?
Then again, the PTH is done in repeatedly, and this time the sample was sent in on the eyes and immediately after collection. So the repeat PTH is shown a high level 250.
So very important is just to ensure that your sample is taken properly.
Now this 7-year-old girl presented with early puberty, breast age of 3 and pubic hair of 2. Bone age is 10 years, a bit progressed. LH FSH is raised in consideration of a 7-year-old girl, but estradiol level is less than 5.
So what do you think? This is a progressive puberty or this is a slowly progressive puberty?
I think this is a considering the bone age and the breast stage in this child at this 7 years of age. I think this is a progressive.
So there is a non-estrogen cause of early puberty and a non-estrogen cause of advanced bone age, do you think?
No, I think the estradiol values has been done in another methods like.
So this is a very, very common report we see. We see LH is high, FSH is high, estradiol is 0. And then the patient will tell you how is estrogen 0 and you still have a precocious puberty. So till now, I all talked about pre-analytical issue. So this is again an analytical issue. But you can say also, you could have said that don't do with this technique, do via a different technique. So techniques are very, very important. We know that there are two types of techniques: the immunoassay, which is most commonly used by most counters and rapidly techniques. They are good for large molecule, large volume peptides, but they are not very good for steroids, particularly for estrogen, testosterone, and for rarer situations, cortisol in the newborn. Immunoassays are not very good. There you will like to go ahead with something like mass spectroscopy, which separates the various hormones based upon their mass and charge ratio. And that's how you distinguish between the two. They're good for smaller molecules. You need only small volume. So if you're looking at estrogen in males, testosterone in females, estrogen in prepubertal girls, if you're looking at cortisol in infants, think of a possibility of mass spectroscopy. That will be a better way to go forward in terms of that technique. So this is the wrong technique which was used.
Now this next case, 12-year-old boy with 21 hydroxylase deficiency, hydrocortisone, he was on hydrocortisone 15 milligram per meter square per day. Now the 17 OHP level is 4 nanogram per ml. As you all know that we have always in a target cutoff of 3, the 17 OHP level was a bit raised from that. Again, the next value, it was done from the another lab that was showing that it was 2.4. Sir, why this discrepancy is there?
I think already very nicely Dr. Sugandha has mentioned that we should not target at the lower limit. We want to keep it at 3 times the upper limit. That is also because of the sensitivity issues. So when we talk about the comparison of a particular assay, we compare this to a gold standard. And we also talk about precision and accuracy. So what is the difference between precision and accuracy?
Accurate means how many times the level is giving the right diagnosis, and the precision is how many times the report is giving the similar kind of values.
Yeah, so if you repeat the same sample multiple times, your value is going up and down, or is it going on one particular side? So if you can see, you have this form of this thing which is accurate and precise, while here you have a systematic error and you can go up and down. That will be a random error. So every test will have variability, and this variability would be very significant. At least 20% variability is allowed. So when you talk about the variation, 20% coefficient of variation is allowed. So this 2.4 and 4 to me is the same. It doesn't make any difference because it's 20% up and 20% down. So don't worry about these minor changes in these scenarios.
Okay, the next case, 10-year-old girl with hypothyroidism on thyroxine supplementation of 100 microgram. Her TSH was 54. Asking about the compliance, it was a good compliance, and the child is euthyroid. So we repeated the sample and TSH was 2.5.
So again, good that you repeat the TSH. So if you have a clinical biochemical discordance, then you should do a resample. Now, why this TSH is high there can be many explanations, but one of the most logical explanation often happens is what is known as a carryover effect. So maybe you had a patient whose TSH was more than 1000. It was there, and some amount of that sample, if the washing was not good enough, remained in that container, and the next sample, the level goes up. So the lab should have a mechanism by which they should really look at that if there is a possibility of carryover, they should repeat it. So again, saying if you have one erroneous report which is not fitting into the clinical picture, don't. So you are the final judge, not the report. So this is something which is important.
Now this next case, 16-year-old girl presented with galactorrhea, the high possibility of hyperprolactinemia. Now his prolactin level came low, 16 picogram per ml, but she has headache, vomiting, and an MRI showing a large adenoma. So in spite of having all the symptoms and galactorrhea, why is this prolactin level is not high?
So generally speaking, if you have galactorrhea, your prolactin should be more than 100. Now, theoretically, you can have a non-functional adenoma in which prolactin may not be very high in this scenario, but because of galactorrhea, I would be thinking this is a functional adenoma. So there is an analytical issue which is coming, and the most common analytical issue for hormones who go many times their basal level is what is known as a hook effect. So if you look at scenarios like HCG, prolactin, TSH or calcitonin, these are pretty much like tumor markers. Their numbers can go 100 times, 1000 times. Normal prolactin is 40, but you can have prolactin up to 4000, 8000. So in this scenario, after a level, you have a falsely low level, and this is what is known as a hook effect. So how do you correct for hook effect?
So as we know that hook effect is due to the excess of antibodies in the serum, so we can dilute the serum so that antibody concentration will be a bit less.
Not the antibody, the ligand. The ligand is too high. So if you dilute the ligand, you will get that. So you should do it with a diluted sample. You will get the better result in that regards.
So now the next case, a 17-year-old girl presented with follow-up of a papillary carcinoma of thyroid. She has undergone the surgery and radioiodine ablation. Now the thyroglobulin level was undetectable for follow-up, but the radioactive iodine scan is showing a lesion present in the neck. Sir, do you think that this radioactive lesion is already present, but why this thyroglobulin is undetectable?
Yes, so thyroglobulin is supposed to be a very sensitive marker of any thyroid tissue. Now your radioactive iodine shows that there is a thyroid tissue, but you have no biochemical marker. So it doesn't mean that you don't have any thyroid tissue. So what I would like to go ahead is to look at some other possible causes. And one very important thing is antibody. See, ultimately, when you're doing an immunoassay, you need an antigen to bind to the antibody, and then you have the second antibody. But suppose there is already an antibody to thyroglobulin, it will take off this antigen. And that's why you will have a falsely negative test as far as this is concerned. And this is particularly common for thyroglobulin. And this is very, very important. You will have a falsely low. You should then go ahead with a non-competitive assay like GCMS, which will give you a correct diagnosis. Or if you measure anti-thyroglobulin antibody, that will be a good thing. So a big message is that if you are really thinking of a follow-up of thyroid carcinoma, always do a thyroglobulin antibody as well, because that may be positive in that regards.
Okay. Now this 11-year-old boy presented with lethargy. T4 level was low with a TSH 3.4, a normal in the normal range. There was no goiter. TPO was negative, and test of total T4 and T3 level was normal.
So again, this is a scenario which could be a central hypothyroidism. So do you think this could be central hypothyroidism?
Before labeling something as central hypothyroidism, I would like to consider a repeat test in this.
So what is important to understand that if you have a low T3 or T4, TSH should be sky high. If the TSH is below 20, you should think of central hypothyroidism. But yes, before you label that, because then you will have to do an MRI, you have to do a cortisol, you have to do a prolactin, so many things, you better do something else. So what could be going wrong is heterophile antibody. So what is a heterophile antibody?
Heterophile antibodies are the antibodies that is present in human beings, but that is actually against the some animal species, cross species. And
so there is a cross reactivity of these antibodies, and we know all these assays are essentially based upon some like horseradish peroxidase. There are other ones which are originating from the animal species. So these antibodies can inhibit the activity of these enzymes, and therefore you may have a falsely low or a falsely high level. So heterophile antibody again can explain you discrepancy which is noted. So do it on a different platform. What do you mean by a different platform in this setting?
That means we can do it from a different lab also?
Not on a different lab. Suppose they have various ways. Some do via the Roche, some do via Alexis, some do using Beckman with Coulter. So if you do only with Roche and the other lab is using the same machine, they will give the same report. But if you do through a different machine, and you ask a lab whether you're doing with a different machine, then you will get the right result. So this is what the platform would be.
We have
so
to
different.
Ask whether
what is
serum they are using?
No, which machine they are using? Because each machine will use different serum and other parameters. Yeah.
So
yeah,
14-year-old boy presented with gynecomastia. Breast is 2, testicular volume is 12, and pubic hair stage of 3. His LH FSH level was 1.8 and 2.4 respectively, and testosterone level was 120. And prolactin done, it was 120 picogram per ml.
So a lot of people with gynecomastia, they get a prolactin done. But does this hyperprolactinemia cause this gynecomastia? Do you think?
I don't think so, because the prolactin, how it causes gynecomastia is due to the hypogonadism.
So if your prolactin is causing gynecomastia, your testo should have been low. So if you have a normal testo with a high prolactin, I would doubt whether this prolactin is right or not. Now we talked about hook effect, where you had clinical features but the levels were low. Here you don't have a clinical features but the level are high. So this is the opposite of hook effect, and this is what is known as a macroprolactin. So macroprolactin means because of the antibodies, a lot of prolactin molecules which are non-functional fuse with together and you will get a very, very high level. So this is clearly a case of macroprolactin in this scenario.
So now this 14-year-old boy presented with delayed puberty, testicular volume of 4 ml with pubic hair stage of 1. Testosterone level is undetectable. And the repeat testosterone done was just in the puberty level of 24 nanogram per ml.
So if your final diagnosis depends only on testosterone levels, you will always get confused. You have to look at the clinical picture. What testicular volume is 4 ml. It means what? He has already entered into puberty or he is just entering into puberty. So in this scenario, I would be more cautious in that regards. Now, when you say undetectable, the lower limit may be 20 for that lab. So anything which is 16 or 17, it will say undetectable. So you need to remember that there is always a coefficient of variation. And if the coefficient of variation becomes more than 20% on both sides, the lab will say, this is my range. I am allowed to report only if the coefficient of variation is less than 20%. And closer you go to the extreme, the more variation will happen. Like in blood glucose, when you use glucometers, they are good for high or they are good for low sugars.
They are good for the high blood glucose.
But their coefficient of variation is more for the low sugars. Similarly, for estrogen, they have been developed for reproductive endocrinology. For females whose estrogen is 100, they are not been developed for estrogen levels of 8 or 10. So same thing is about testosterone. They are for adult males. At lower levels, the coefficient of variation will go very, very high. And that's why you need to be cautious about that. So this you need to do using a different technique. Or I would say forget about it. Just follow up the child. He's already has a testicular volume of 4 ml at 14. He will progress.
So this 8-year-old girl with short stature, height was 128 centimeter, not very short, and having a normal screening test. Growth hormone stimulation test was done, which was showing, according to the guidelines, it was a partial growth hormone deficiency. I would like to know, sir, whether this growth hormone stimulation test is required considering the pretest probability in this child.
I think the most important thing is that the test is only going to change the probability of the diagnosis. If your pretest probability is very, very low, even if the test is positive, your post-test probability is not going to be very, very high. That becomes very, very important. I'll give you an example. You have got a very good test which has got 90% sensitivity and 90% specificity. The prevalence here is reasonably okay. And here you are finding good positive predictive value because you have got a high prevalence in this regards. Now, in second scenario, if the prevalence is only 10%, now what is happening with the same sensitivity and specificity, your positive predictive value has come down. So if you do not think that this is GHD, please do not do a growth hormone stimulation test. Only do if you have a high index of suspicion, then only these results will make the difference. Remember, none of these tests are perfect. You will have variations and you will unnecessarily label somebody as GHD or you will exclude them as non-GHD in that regard. So as the prevalence increases, the positive predictive value goes up, the negative predictive value goes down. So always look in terms of prevalence. So here you should not have done the test.
Okay, now the next case, 12-year-old boy presented with delayed puberty concern with testicular volume of 2 ml and pubic hair of stage 1. Bone age is around 10 years and the hormonal investigation has been done, which was showing that undetectable LH, FSH and testosterone level. Sir, I would like to know whether this child actually required this kind of investigations considering the
so this child, if you go by biochemical reports, is hypogonadotropic hypogonadism. But every prepubertal child is hypogonadotropic hypogonadism. So why do you need to even do the test? So unless you reach the criteria, which is 14 years and TV less than 4, you should not even do the test. This is so common in girls and boys where we get these tests and it causes more confusion. Nothing to be done. They will say, do an MRI head and then things will go on. Similarly, if you have no breast, they will do an ultrasound which shows no uterus and then MRI, karyotype, and everything is going to be done. So in endocrinology, often it is good to not do things rather than overdo. So this is definitely not required. You know that during this phase, from around 1 year till around 13, 14 years, you will have zero hormones. So everybody from 1 to 14 is the same. Don't do the endocrine test in this regards, and that becomes important from that perspective. You wait for 2 years, what's the harm? This is not the criteria because around 15% boys of his age may still be too. Yeah, so we should have been followed up. Yeah. So we have to counsel them. So it's our task. So because otherwise you will get these sort of reports. So the criteria is 14 years. We should follow this. Yeah, there's no worries. Yeah.
So the next case, 12-year-old boy presented with lethargy. Free T4 level is low with TSH in the TSH level was 12. Cortisol done was low. The ACTH of 5.6 picogram per ml. And there was undetectable gonadotropins level as well as testosterone.
So I think this is very, very important test. So if you look at FT4, the TSH is 12. Now, do you think this TSH about 10 is primary or central? Forget about FT4.
Above 10,
if you had not done FT4, TSH was 11, 12, what would you have thought?
We have thought about the primary hypothyroidism.
So very importantly, always do a FT4 when you're doing TSH. Do not just do a TSH number 1. Now, if your FT4 is low, do you think this is still primary?
No, we have to see in the contextual assessment of FT4 and TSH. If FT4 is low, the TSH should be sky high, more than at least 12.
So there is a log linear relationship between FT4 and TSH. If your FT4 is low, your TSH should be very high. If your TSH is detectable with a high FT4, you are basically dealing with hydrotoxicosis or TSH adenoma. While if your TSH is up to 20 and you have a low FT4, this is central hypothyroidism. So again, this contextual assessment is very, very important. And this is relevant for other conditions as well.
So the similar case, a 7-year-old girl with tetany presented with hypocalcemia and hyperphosphatemia. Creatinine level was normal. PTH is in the normal range as reported by the laboratories. So
here the PTH is normal. Do you think you'll have to work up for other causes?
Sir, if you consider for the calcium level, in the low setting of the low calcium level, the PTH should be more than at least 70.
So PTH should be sky high. It should be 200, 300, at least more than 70. So this PTH, which is quote unquote normal, is not normal for hypocalcemia. And you already see a high phosphorus, which basically means that PTH is not working here clearly. So this is clearly a case of hypoparathyroidism. So the same level of PTH may be low in hypocalcemia, normal in eucalcemia, and high in hypercalcemia. So if your PTH is 24 with hypocalcemia, that's low. 24 with normal calcium is normal. 24 with high calcium is high. So you have to always see, when you say PTH, I will say what is the calcium. When you say TSH, I'll say what is the FT4. You say what's the ketone, you will say what's the insulin and glucose. That becomes important. So you have to have a systematic association. So this again is inappropriately low level of PTH. This is actually hypoparathyroidism. So to summarize, there is always an overlap of physiology and pathology. It impact of age, puberty, and disease. You have to correlate it clinically, and testing should be done only if it is necessary. So over to the chairperson before we start with the second part.
Thank you so much, sir, for such a interesting and lucid dialogue, delving into the practical aspects of hormonal assays and clarifying about the pre and analytical and post-analytical errors which may occur. I would like the audience, if they have any questions.
Sorry, I have just one thing to say, sir. You have pretty much covered all the possible mistakes that we commit probably, but just then as clinicians, we should take history of the drugs they are taking already for before sending prolactin, whether they are taking domperidone and all, before sending cortisol, whether they're taking
Absolutely. Very,
OCTs.
very, very, very important. Thanks, Halapan, for this wonderful dialogue. Now, I'll be joined via Dhwani for the second aspect of what is now becoming very common. Dr. Deepak is sitting here. He was saying that all the patients that we had in the on-site course had a genetic report. So now genetics has become very, very important, that many of our patients require genetics. But again, which test to do, when to do or not do, how to interpret is also very important. So now I think endocrine genetics is coming as a big way in that regards. So when do we order a genetic test? For screening, establishing a diagnosis, saying a prognosis, and do again, as I said, only if you are going to change your management based upon that and do a clinical correlation in that perspective. Now, remember that all diseases do not have a genetic etiology. Manoj was talking about that child with constitutional obesity. If you do an unnecessary genetic workup there, it is not going to help out. So what we need to remember is that depending upon the penetrance and prevalence, you will have three basic group of disorders. Mendelian disorders who are highly penetrant, and they have got very less prevalence. While you have got the complex traits like obesity, short stature, you may also have things like diabetes, in which you have got high prevalence, but the effect of a single gene is less. This is a polygenic inheritance. So what we are mainly going to focus are about these Mendelian group of disorders and not these complex traits where doing a genetics is absolutely useless from that perspective. And we talk about various type of inheritances. We'll mainly be focusing about monogenic inheritance, largely Mendelian, and the exception that are there in terms of non-Mendelian inheritance. And we've got some very interesting cases to come up with.
So the first case of a 3-year-old boy who presented with achondroplasia and the family was unaffected. So, sir, we know that it is inherited in autosomal dominant fashion. Do you think the family can be unaffected in such patients?
Yes, this could be theoretically a novel mutation. So that's why the family is unaffected and the child had a mutation. Now the question is, he is asking whether the next child will be affected or not. So what would you counsel?
If this is a novel mutation, maybe perhaps not. The chance of recurrence will be as much as the baseline population.
So like some new mutation will be like a very, very rare chance that the second child will also have a mutation. But what happened here? So this is the classical autosomal dominant in which you will expect to be parents should have been involved. Since the parents is not involved, we are saying this is a novel mutation.
So what happened was the index child was affected and the family was not affected. So the possibility of a novel mutation was considered. The family was reassured that there is no chance of or the baseline chance of recurrence in subsequent sibling. But the next child also developed achondroplasia. Now, how do we explain that, sir?
So this is a very, very unfortunate scenario in which they were counseled that nothing will happen, but unfortunately they developed it. So we need to understand that there are multiple factors which affect the Mendelian inheritance, and one of them is mosaicism. So mosaicism means that all the cells do not carry the same genotype. Different cells will have different genotype. So here what may have happened is the gonads of one of the parents had that mutation of achondroplasia, while the somatic mutation was not there. So that's why it passed on to the next generation. So therefore, whenever you have this sort of a scenario, you should always be wary that there could be a germline mosaicism. So always in these sort of conditions, you have to be careful before you say, okay, everything is normal. Maybe getting a genetic testing in the intrauterine period may have been a good option in that regards.
So the second case is a 2-year-old girl with vaginal bleeding, had recent onset breast development with no pubic hair. On examination, she had irregular cafe au lait spots with ovarian cysts. Now, this made the diagnosis of McCune-Albright very classical presentation of McCune-Albright, and the lab parameters collaborated in form of low LH-FSH levels. However, GNS1 testing was found to be negative sent from the blood sample. Now, how do we explain that, sir?
So again, this comes out back to the mosaicism part here again, because what we're looking here is that McCune-Albright is a somatic mosaicism. So some cells will be affected, some cells will not be affected. So blood sample may be negative. How many of them will have blood positive usually?
How many?
So it's like 50% around may have a positive in the blood. But if you are negative in blood, this does not exclude McCune-Albright. Then you take the sample either from the fibroblast, cafe au lait area. You can take from the cyst aspiration, you will get the right report. Same is true for Turner syndrome, because Turner syndrome, if you have a mosaic Turner and you don't do enough number of karyotypes, you will be missing out in terms of this Turner syndrome. So this is very, very important. So this is a somatic mutation, and we should look for the site where it is affected. So cafe au lait is the best area to do a skin scraping at a fibroblast. You will get the diagnosis.
Next is a 5-year-old girl presenting with hypocalcemic seizures. The lab evaluation showed hypocalcemia with hyperphosphatemia, normal creatinine. PTH level was inadvertently low for the level of calcium. Now, someone went ahead with she also had complaints of growth failure. Now, the treating physician went ahead with genetic testing, which showed a RET1 mutation, and there was no family history of suggestive of medullary thyroid carcinoma.
So we are all scared with the RET1 mutation. But what we need to understand is that RET1 mutation in a family who has got 10 people with thyroid carcinoma will have different implications as considered to the RET1 mutation in an incidental diagnosis. Now, we know that you can have pituitary incidentalomas. But if you have features of Cushing syndrome and you have a 6 mm lesion, you say this is significant. If you have no feature, your 6 mm lesion becomes significant. So again, this is an incidental finding. If we do The NGS of all of us who are sitting here, we will find 15 to 20 pathogenic mutations which are there in us, but they are not manifesting because there's something else is countering it. So maybe somebody is producing more cortisol, but the receptor is down. So things will balance out. So we don't know in this case whether the risk is the same. And this brings us to an important issue of penetrance. And this clearly is a penetrance which is there. So when you talk about two terms, penetrance and expressivity, what are the difference, Dhwani?
Penetrance is
how many of the children will have the disease, and expressivity means how severely they are affected. So you can have variable penetrance in that only 6 of 10 have a disease. You may have variable expressivity in that they may have mild, some may have severe, that sort of a thing, or you can have a combination of the two. So that is important for autosomal dominant disorders.
Next, we have a 10-year-old boy with obesity. He was normal till age of 3 years and had rapid weight progression ever since. There was history of hyperphagia and a small phallic size. The syndrome classically fit into the clinical picture, fit into Prader-Willi syndrome. So the clinician went ahead with fish analysis, which was found to be normal. So do we exclude Prader-Willi in this child, or do we go for some other tests here?
So we need to understand the genetics as to what is causing Prader-Willi syndrome. This is an imprinting disorder. So when you talk about imprinting disorder, it means that
there is something that is silencing or modifying the expression of the gene.
And the expression of the disease will depend upon whether you are getting it from the father or from the mother. So imprinting disorder, suppose you have a deletion, 60%, okay, you will be able to pick up on fish. But there are problems in the methylation center, there are problems in the epi-regulatory center, and they will not be picked up on that. So you should know what diagnosis you are talking about. So there you have multiple diseases are imprinting. We talked about Prader-Willi, Engelmann, Beckwith-Wheatman. And in all these disorders, you need to remember that you can have manifestation depending upon which parent is giving you that particular gene. So what you need to do here is to go ahead with a methylation study, which is a much better technique, and you combine with MLPA, which will give you the diagnosis. So the recommended test for Prader-Willi is methylation study plus MLPA. Fish is not the good test.
Next, we have a 21-days-old boy with irritability, has mild dehydration, very high calcium levels, and high PTH for the level of calcium levels. So this looks like hyperparathyroidism. The urine calcium creatinine ratio is low, again favoring the diagnosis of hyperparathyroidism. Now, is there something that we can inquire clinically about the family, which will help us pinpoint the diagnosis in the next child?
So you have a very high level of calcium in the child, but the urinary calcium is not high. Relatively not high. So what it means is that you have got high levels in the blood, low levels in the urine, which means that the body has a problem in sensing calcium. It is telling my calcium is low, so PTH is working overboard. It's also conserving in the urine. So this is what is known as neonatal severe hyperparathyroidism. And this is often because of a homozygous mutation. Both parents will have a familial hypocalciuric hypercalcemia. So you should basically evaluate. So best would be to look at calcium, phosphorus, PTH in the mother and father. So what did you find there?
What we found that only the father was affected. He had high hypercalcemia, and the mother had normal serum calcium levels.
So that's a very interesting scenario. So normally for neonatal severe hyperparathyroidism, we say surgery. There's no other way, you have to treat the surgery. But this is a unique situation that only the father is affected. So what is happening is that this child has a mutation in the calcium sensing receptor, which is hetero or homozygous?
Heterozygous.
But he is sensing mother's calcium is low because he wants calcium to be 11. Mother's calcium of 9 is low, so he'll develop hyperparathyroidism. But what will happen after some time, once he is out of the placenta, he will then have normalization of level and behave now like a calcium sensing receptor defect. So before you label somebody as neonatal severe hyperparathyroidism and you say go ahead with surgery, you should always exclude this very, very important entity of neonatal hyperparathyroidism, in which only one gene is affected, and that is coming from the father. Mother's gene is normal. So do you think this is an imprinting defect? This is a pseudo imprinting, because imprinting means that this is not an imprinted gene, but this is behaving differently based upon the parental expression. So this is
Had the mother been symptomatic, would the child have, had the mother had hypercalciuria and the father been normal, will the child present
normal? But the child will have a familial benign hypercalcemia, but he will not have severe hypercalcemia. Another example is GCK deficiency, where you have a problem in glucose sensing. Father is affected, mother is not affected, you will develop
hypoglycemia.
You will develop hyperglycemia. Basically, because you will try to build up more. Mother is affected, child is not affected, you will develop infant of diabetic mother-like picture. So I think this is beyond that, but a similar scenario.
So next we have a 7-year-old boy with growth failure, height severely compromised, and similarly the weight was appropriate for height but compromised for age. Classically had doll faces and a peak growth hormone level on stimulation test of 2.1. So this fit into a growth hormone deficiency. On examination, he had a firm hepatomegaly with very high SGPT levels. And on an overnight fast, the blood sugar in the morning was 32 with a ketotic hypoglycemia.
So this was the case whom Sajali had presented in one of our conferences. A child who was labeled as growth hormone deficiency, but actually is GSD. Because if you look at it, he has a plump facies, hepatomegaly. And now we know that GSD, this could be GSD3, this could be GSD6, GSD9. So what we were doing earlier, send one single mutation. Look for GSD3. Now what we are seeing here is that mutation clearly is negative. So what could have been done better in this scenario? So this is what is known as locus heterogeneity. When we say locus heterogeneity, it means that you can have multiple genes which are controlling the same thing. If you have XY DSD, you can have 25 genes which can cause XY DSD. If you have hypophosphatemic rickets, for example, it can be because of a FGF receptor problem. It could be because of phosphatonin or so many other genes. So getting one gene at a time is not going to work. So what should we do? We should go for
the complete panel.
Targeted panel. So in these sort of scenarios, it's always better to go for a targeted panel.
Next, we have a 12-year-old boy with obesity with weight SDS at plus 2.2, height is again advanced at plus 1.2, has a normal facies and a normal development. Should we go for, do we consider a genetic obesity here? Is genetic diagnosis warranted in this patient or not?
Yes. So we always talk about this, that all 4S. If you have 4S, then think of a genetic cause. So those 4S are?
Soon, syndromic, segregating, and severe.
So if it is very early onset, not in this case. Syndromic features, no. Family history, no. Severity, no. If you do genetic testing in this child, you will be doing in crores of individuals. So this is not required clearly in this regards. So what about this girl?
In contrast to the previous child, now we have a child with 2-year-old girl with severe obesity, rapidly progressive, had history of hyperphagia. Now in this child, should we go for a genetic
What do you
test?
think?
Yes, this is again a soon appearing soon, very severe obesity. This child definitely needs genetic
and syndromic features. So hyperphagia is there. So this requires clear evaluation. So it's early, severe, unusual, and then you will find some defect. So you will get the leptin receptor defect. So if you have severe, soon, syndromic, segregatory, this is the genetic test. Otherwise, you will unnecessarily waste the genetic test there in that regards.
Next, we have a day 3 child with atypical genitalia. Has no palpable gonads, Prader stage 4. Ultrasound shows presence of Mullerian structures and the karyotype was 46XX. So this is a 46XX DSD with mildly elevated 17 OHP levels. The baby was labeled as CAH and started on hydrocortisone, fludrocortisone. However, on serial follow-up, the 17 OHP levels remained significantly suppressed, so the doses were tapered and completely stopped. Even after stopping hydrocortisone, the 17 OHP levels remained normal. And what was classical on history was that the Prader staging also remained pretty much static in this child. As a result, the child was counseled, and further on, this child presented at puberty with complaints of delayed puberty. So
again, this test gives a very important message that just biochemical parameters may not be your final clue for diagnosis. We say, okay, XXDSD is there. This girl has slightly elevated 17 OHP. It's easy, CH, lifelong treatment. But look at the 17 OHP. It's not very high. What Dr. Sugandha was talking about, we have to have levels which are much higher. So here you should think of other possibilities as well. And when we thought this should have been a genetic testing should have been done, and then we decide which test to do. This is a very important thing. So if you're looking, your options are either sequencing, you look at the whole gene, you read each and every part of the gene. You can do a comparative analysis. You do a cytogenetic or a fish or karyotype. Sequencing could be Sanger sequencing versus next generation. So Sanger sequencing is like you are reading each and every word of the book yourself. NGS is like that you have wanting to read the whole 100 books. You have 1,000 people who are reading this page, this page, this page. So they are not very good. They are not as good as you for the editor, but at least they are covering it multiple times. Then you say same page is done by many people. So you will get, okay, you will get some good idea. The depth of coverage will be more. Comparative is array and MLPA. Here you are comparing so many normal phenomena versus diseased phenomena. So you know it's normal or abnormal. And then, of course, cytogenetics, we know fish, which will localize your gene, and karyotype, we all know that. So Sanger sequencing, as I said, is like a very meticulous process, but you can't do it for all the genes. You will do it for one particular gene. It will take days for this result to come in. NGS is a rapid technique, but again, rapid means you may miss. So they may make some errors. So that's why it's not that good. However, latest NGS techniques are coming as good as Sanger. So hopefully in the next few years, this will become the gold standard in that regard. So what we do with NGS is that if we want to look at a defect, we go through the entire railroad and see what the problem is. While if you're looking basically for particular sites, you will be looking at NGS. So if you have a single gene, only one mutation is there, you will go with hotspot testing. If you have single gene with multiple mutations, you say, okay, Sanger sequencing. You know 90% of CAH21 hydroxylase is because of this defect. I will only look at that part of the gene. But if there are 100 defects, then you will do the whole gene. Third is that you don't know whether it is 11, this is 17, this is 21. Do a targeted panel in that regards. Then you don't know at all. In that scenario, you will like to do a whole exome and a whole genome sequencing. What is the difference between whole exome and whole genome sequencing?
So as we know that DNA has two parts, the exon and the intron. The exon part is translated into, transcribed into RNA and translated into proteins, whereas the intron part is not transcribed. This part, even though it is not transcribed, has some regulatory effects on the coding part, and therefore whole genome will give you the information of both introns as well as exons, and whole exome will give you information of only the coding region of
and
the
what
DNA.
Vibha just mentioned in the setting of AIS was that in androgen insensitivity, you may have a problem not only in the coded region, you may have a problem in the promoter, the regulator. So if you do the gene analysis, it will be normal. And then you will say, okay, this is not AIS, but you should do the whole genome sequencing rather than an exome sequencing. So you should know which test to do. This is the most important slide here. And then copy number variations. Copy number variations means deletion, duplications, chromosomal abnormalities. NGS is not very good for copy number variations. You should do MLPA, and that is why for Prader-Willi, you go with MLPA or FISH. So this is how you will decide. And if you want to do thousands of genes simultaneously, you will do an array that will tell you whether your gene is normal or abnormal. So knowing this becomes very, very important. So now if you have a likely monogenic defect, if it's not there, don't test. 90% of your cases do not require genetic evaluation. But yes, and you know the candidate genes are only 1 or 2, you said I will do a sequencing. If they are up to 10 to 20, do a targeted panel. If it's normal or if it's unclear, then you go ahead with the exome sequencing. And if it's abnormal, you can do a functional study. Often they report as variants of unknown significance. But if you know that this is androgen insensitivity syndrome, the mutation is there in the androgen receptor, forget about it. Just because they haven't reported that mutation, they have said VUS, it is not VUS, it is pathogenic. That's where clinical judgment comes. Functional study is not required for everybody. If you know this is VDDI type 2 and the report is the same, don't waste money in doing a functional study. However, if exome is also normal, you have an option of whole genome sequencing. So I think these two slides will give you the real clue about that. So now what we found in this case was that you had this report.
Yeah. So in this child who was not actually a 21 hydroxylase, there was a history of maternal virilization, and we went ahead with targeted panel. The genetic report showed aromatase deficiency, likely pathogenic here. Moreover, sir, I would also like you to explain to us what in silico predictions.
Okay, yeah, these parameters are important. So we'll discuss about how will you decide that when you get a variation, is that significant or not? Now, there's a difference between variation and mutation. Now we don't use the term mutation because mutation means that this is a abnormal or disease causing thing. So we need to really know whether this is significant or not. We'll go for this case first and then we'll discuss about that.
We have a day 14 child with atypical genitalia. Bilateral gonads were palpable and there was no uterus on ultrasound. So this was a 46XY DSD with reasonable testosterone levels and salt wasting. With marginally elevated 17 OHP levels. So the clinical picture and the lab picture does go in favor of 3 beta HSP.
So this is a XY individual who has salt wasting. With DSD, it's clearly a 3 beta will be the most common thing. Now, this is the report. Now, how do we decide whether a particular mutation is pathogenic or not? So you look at multiple things. One is familial segregation. Do you have multiple family members who are affected and they have the same mutation? And of course, it is pathogenic. Don't worry about that. If the gene frequency is more than 0.1%, I'll go the other way around. If the gene is more than 1 in 1,000, then you will say, okay, this is likely to be a normal variation. You can't have so many diseased individuals. So less than 0.1% will become significant. Then how long this gene has been conserved? They will tell you that this is conserved for 3 million years. Or much longer, which means it's a very, very important gene. If this gene has been conserved and this child is not conserved, means there is some abnormality is there in that regards. Then you can look at clinical correlation, whether it's fitting into your clinical diagnosis or not. And then you can do a functional study or an in silico model. When you say in silico, which you specifically asked for, this basically means that you will try to develop a model in the computer, and the computer will try to tell you the functionality. So where is the mutation, which point is the mutation, what change happens in amino acids, then you will say, okay, this is likely to be effective or not in that perspective. So now if you look at this, what they are saying is that there is previously been reported in patients. That would basically mean that this is very, very significant. It has not been reported in 1,000 genome project. That means it's a rare phenomena, and in silico production is damaging. So all three would mean that this is pathogenic. But just because they are not there does not exclude the diagnosis if you have a good clinical picture.
Moving on, we have a day 3 child with atypical genitalia, Prader stage 4, no palpable gonads, and ultrasound shows a Müllerian structure. So this is definitely a 46XX DSD. The lab evaluation showed hyponatremia with hyperkalemia and very significantly elevated 17 OHP levels.
So this is clearly going like a 21 hydroxylase deficiency, but somebody did a NGS and the NGS was normal. So what do you think is happening here?
NGS is not a good test to diagnose 21 hydroxylase deficiency. Going for a hotspot testing or a Sanger sequencing could have helped.
Why?
Because there is presence of pseudogene which may alter the results of
so when you have, why is it the most common form of CAH? Is because there is a pseudogene and there is an exchange between the true gene and the pseudogene. So when you have a pseudogene, your NGS will pick up that pseudogene also, and that may cause more confusion. So NGS is not a good test for 21 hydroxylase deficiency, which clearly Dhwani has mentioned. You should go with other scenario like Sanger sequencing in that regards.
Next, we have a 15-year-old girl with primary amenorrhea. On examination, she has breast stage 4 with sparse pubic hair. And what we found interestingly was presence of bilateral inguinal gonads in this child. Ultrasound showed no Müllerian structure. So this was an XY DSD picked up at a much later stage. Next, what we found was elevated FSH levels. The karyotype confirmed a 46XY karyotype. And the testosterone levels were significantly high here.
So what are the diagnosis in a XY individual? Primary amenorrhea, good breast development, no pubic hair development, high testosterone, androgen insensitivity syndrome. Yes.
So, however, the whole exome sequencing done to confirm the diagnosis was found to be normal. So what went wrong here?
So this is what Vibha was highlighting, that we need to understand that the androgen receptor, the problem could be in the coded area, or it could also be in the promoter or the regulator area. When you're doing a whole exome, you're only looking at the areas which have been coded. You're not looking at the areas which are proximal to the coding region, and therefore you may have an error. So if you want to really look at androgen insensitivity, you need to go for a whole genome sequencing rather than a whole exome sequencing in that scenario. And WGS would have been a better scenario.
Next, we have an 8-year-old boy with short stature, height of 92, which was at minus 6.2 standard deviation. He was small for gestational age. And as per the new guidelines, we know that pretty much for everybody, a genetic test has been advised. So we went ahead with an NGS and found out the workup to be normal. However, he was found to have 10 variants of unknown significance.
So I think this is a common thing. When you do a MRI in everybody, you will find incidentaloma in 10%. When you do CT abdomen, you will find adrenal incidentaloma in 5 to 10%. Similarly, if you do, as I said, sequencing in all of us, we will find 15, 20 variants, which are now confusing. They may cause a disease, but they may not cause a disease. So there are now guidelines in which otherwise they will cause confusion. If suppose you release the report and you say that this patient may have a risk of medullary carcinoma thyroid, you can understand what will happen to the child. He's come for the short stature, but you have given, okay, likely to be medullary carcinoma thyroid when you don't only know whether he is at risk or not. So now there are specific guidelines that there is only a few conditions in which that they will release the report. They will not release the report in every condition, but few conditions are like in endocrinology. I think there are a bit of these hyperlipidemia syndromes and all those which you can easily identify. So this is a guideline. Otherwise, there will be a lot of confusion for the doctor as well as for the patient.
Next, we have a 29-year-old lady who presented with medullary thyroid carcinoma and pheochromocytoma. She was diagnosed with MEN2B. Her sister's son is about 3 months old, and now she's concerned for her nephew's sake and goes ahead with
what you want to testing from that.
Yeah. Should we go
so this is important. We always talk about what is known as a cascade testing. If you have somebody with medullary carcinoma, you have to look at first degree relatives. You have to screen them. Now, what do we do here? Luckily, we have got very good genetic testing, and there is a very good genotype phenotype correlation in this setting. So what you will know is that based upon what gene is affected, you will know the risk of development. The worst gene is 918, which basically is a bad scenario. So what you need to look at here, the 918, if it is affected, then you have to go ahead with a prophylactic thyroidectomy. So right in the first year, you will remove the thyroid to save the medullary carcinoma from happening in this regards.
Next, we have a 12-year-old girl with incidentally found to have hyperglycemia. The HbA1c was 6.5. Fasting sugars were slightly on the higher side, but 2-hour postprandial levels were normal. She had no ketosis. There was history of early onset mild diabetes in mother and grandmother, which never required major shifting to multiple anti-diabetic agents. She had a normal BMI and no signs of insulin resistance, and being of pediatric age group was started on insulin. With bolus dosing, she had frequent hypoglycemias, and therefore should we consider something other than type 1 here? And if yes, how do we go ahead?
I think this is a very interesting case. This is a very mild hyperglycemia. Your fasting is very high, but 2-hour value is not going up at all. So there is something wrong. This is not a usual type 1, type 2. This is something else. It's a lean individual, strong family history, no acanthosis. So I think MODY becomes very, very important. And this, if you ask me, we will have a talk on MODY. This is more likely to be a GCK MODY rather than a transcription factor MODY. So now what we should have done in this case is to get a genetics. And genetics will show you this is a GCK deficiency. Now, this genetics is going to help you out. You don't need to give any medicine. You don't need to give any insulin. You can just follow them up over time and get the diagnosis. So the prognosis is predicted via medullary carcinoma. The treatment is predicted. So this is precision medicine, so to speak, in that regards. The key messages are that classical Mendelian patterns are rare. Consider non-Mendelian effects as well. Genetic testing should be done only if it is essential, and method selection is vital. So I'll thank Dhwani for this wonderful discussion. And if there are any questions we like to see.
Any questions? I would just like to comment that I know it is not important to order genetics in every child, but it's still, we cannot undermine the importance of genetics, especially in research purposes and also in prevention. And importance of genetic counseling cannot be overemphasized.
Yes, genetics becomes very, very important. We are running a bit behind time, so we'll try to carry forward with this session in which we'll try to see how life can be try to see how life is so complicated with endocrine investigations. But is there a way in which we can make it easier from that perspective? So we'll be talking about some tools that we have developed over the last few years. And those tools can really help out in terms of making an easy assessment and management. So we'll talk about some of these tools and how these innovations can be of help from that perspective in that regard. So we'll try to wrap it up quickly, but it's an interesting phenomena to discuss about in terms of innovations which are there. So we know that pediatric endocrine disorders are rare and they are complicated. They require cumbersome workup and expensive treatment. I already discussed about two common things, genetics and endocrinology. So we need to have tools which decide when you need a workup and what workup should be done in that regards. Now, we all read everything. We all have a lot of courses, books, everything is available. But then when you try to translate that into a clinical practice, the two-way communication becomes difficult. So we want to have a tool which can bridge the knowledge that we have and the clinical practice that we do. And therefore, this will guide your diagnostic tests, your algorithms, your treatment, and many other phenomena. So this is what we have been trying to do using mobile applications. And now we have got the MedEClasses endocrinology application, the third generation of which is going to be released in the next couple of weeks, which will have many more new developments. It's in fact the most downloaded endocrinology app with over 5,000 installs. We have already done a lot of validation studies which have been published, and it provides ways in which we can manage pediatric endocrinology, gynecology, pediatrics, as well as adult endocrinology to a certain extent using pathways which guide you on approach, on management, so that you have a specific guidance which happens in this perspective. We also have developed analytics which will give you immediate interpretation of various functions like thyroid functions, bone age. Many of us are using the bone age tool. We are trying to incorporate AI-based bone age soon. So we are working on that regard, but it's going to take some time on that. And then we have developed interpreters like DSD interpreters, in which whatever we talk for 1 hour, if you just use that interpreter, you will get the right diagnosis in that regards. We also try to supplement with diagnostic information about the test and the therapeutic information. We're trying to put all the knowledge in that one app so that you can access and assess in that regards. So we'll try to see where it can be of various helps. The first, of course, is growth, which is the most common form of pediatric endocrine presentation that we have. And we know that there are algorithms which are available, but these algorithms are often not followed. And when we did studies, which Vibha will talk about, there are a lot of variation which happen even at a specialist level. Because number one, we don't plot on the chart. If we plot on the chart, we don't calculate the Z-score. We don't calculate the BMI Z-score. We don't calculate the height SDS for BA. And many of these parameters do not give us the right diagnosis in that regards. So we developed and validated a mobile application which provides growth interpretation based upon key inputs in that regards. And that was published a few years ago as part of this. Now, the second big problem which happens is that you have a problem of bone age assessment. And bone age clearly can be a problem. So in this growth interpreter, if you just put in the data with regards to the age, the date of birth, the parental height, you will get the interpretation there. And we have got very good validation on that regards. Now, bone age has been an Achilles heel. Most pediatricians do not do bone age. And for pediatric endocrinologists, it's a burden because if you want to do it, it takes a lot of time. So what we did was that we developed ways in which bone age assessment could be done. And we developed and validated a tool with which a simple 5-site based you can do evaluation, in which if you select 5 sites, you will get the bone age. And this was published last year, in which we found that this tool was very good for comparison to the gold standard tools. And we had got good diagnostics even for the trainees also, where we found to be very effective. Now what we're trying to do is to club all that we have developed till now, the bone age, obesity interpreter, growth interpreter, to one tool, and that will be this bone age assisted interpretation of growth big. And Vibha has been also working in that regard. So please, over to you.
Thank you, sir. So after making so many interpreters and helping so many pediatricians as well as the endocrinologists, we decided to move a step forward. And so we decided to make a personalized, integrated, a point of care tool, which allows the usage by non-experts and it provides the instantaneous guidance. So with regards, we aim to develop and validate bone age assisted interpretation of growth, that is BIG. It is a web-based tool for the guidance of assessment of growth and pivotal disorders. Basically, BIG is essentially a tool which requires the entry of key anthropometric parameters along with the pubertal status and the bone age. We can put the bone age either by selection of 5 specific sites or by manual entry options. And all these are analyzed and assessed by the logics which have already been fed in the portal system, which involves the validated and published into this algorithm for growth, for obesity, for puberty, both in girls and boys. And after this, this is analyzed by the algorithms, and this big will give the instantaneous pictorial growth chart, which shows the mid-parental heights and a detailed interpretation of the anthropometric parameters that are very useful in classifying the disorders of growth and puberty. Along with the interpretation, it also provides the initial workup that has to be done in both growth and pubertal disorders, and it also provides the bone age. As I already mentioned, it provides the bone age along with the BMI chart. This is how the big works. This is basically a web tool. This is not available in the mobile app. So what we have to do, we have to fill the patient particular details, the name, date of visit, gender, date of birth, birth weight, gestation, height, weight, sitting height, father's height, mother's height, tenor staging, and also the pubertal hair, this pubic hair. And then we provide, then we select the multiple sites of the bone for the bone age, or we have the option for the manual input of the bone age. All this is analyzed by the algorithms which are fed in the portal system, and it provides the reports in this form, which includes all the parameters like corrected height SDs for BA, corrected height SDs for BA, and the bone age. So for this, with this regards, we conducted a study for the validation, which included 250 subjects, which presented to the pediatric endocrine clinic between the December 2022 to July 2023, with the concerns of growth and pubertal disorders. These were analyzed by the BIG by giving all the anthropometric parameters, and the guidance of the BIG was compared with the guidance provided by the expert like pediatric endocrinologist, and the non-expert, the pediatric trainee and the pediatrician. Then all these guidance were compared with the gold standard, which was the final diagnosis and the management. And what we found in the result, the concordance score, the BIG has scored the highest concordance rate as compared to the pediatrician and the pediatric trainee. And with the use of BIG, importantly, the concordance, there is a reduction in 96% of discordance. And the discordance was mainly found among the pediatric trainees, and the impact of the discordance was they missed important pathologies by 20%, and they do the unwanted workup where the workup was not required in the normal cases. The errors were like the normal was diagnosed as short or precocious puberty and overdiagnosis of the endocrine etiology. But the BIG provided the reassurance and follow-up in 137 cases, and it misdiagnoses only 6 cases. So let's begin with the cases. How does the BIG work? It will be more easy to understand the functioning of the BIG with the help of couple of cases. So we have this 6 year and 6-month-old boy with a concern of growth with a birth weight of 3.5 kg. He was full term. 96.1 centimeter was his height, weight 10.6, SMR, PH1, TV2, and the maternal height was 158.8, and father's height was 177. This was the bone age because we required the X-ray for the bone age, or we can directly enter the bone age. So this is how the BIG works. We have to enter all the initials, and after putting all these initials, we'll get this report. Now, the main thing is I would like to emphasize the details it provides. It provides the height SDA, which shows the boy is has minus 3.61 standard deviation, Weight is minus 4.87 standard deviation, and the BMI shows that the weight is more affected than the height. So definitely it looks like a nutritional pattern, but as we compare it to the family, he's also shorter than the family, as corrected height SDS you can see is minus 3.24. And the height SDS for BA is minus 2.64, which is less than the minus 2. And if we see the growth interpretation, it clearly shows the patient has nutritional growth failure, and it guides the initial workup that has to be done in this patient. And the pubertal interpretation shows he has a normal puberty and nothing has to be done in this case, along with the bone age that shows he has a bone age of 5 years. This is the pictorial growth chart which shows the height and the birth weight and the weight, and clearly we can see that the weight is more affected than the height. Coming to the next case, we have the 16-year-old girl with growth concern. Birth weight was 3.5 kg, height 142.5 centimeter, weight 26 kg. Her SMR was B5, PH5, M1, and the maternal height 144.6, and father's height was 157.1. She has a bone age of 15 years. Now let's see what we'll get in the BIGS report. And what we see here, her height SDS is minus 2.37, definitely less than minus 2. His weight is minus 3.7, and BMI SDS is minus 2.9. From here, the growth parameter shows she is looking like a nutritional pattern. But when we look into the corrected height SDS, what it shows that it is greater than minus 1.5, which clearly shows she is fitting into the familial short stature, not the nutritional pattern. And what we get his growth interpretation that she is the case of familial short stature with underweight, not the nutritional pattern. The initial workup was guided, and she has a normal puberty. So no need for workup here. Moving towards another case, we have this 12-year, 11-month-old girl with a growth concern. Her height 136.4 centimeter, weight 34.8 kg. She has a breast age of 3, pubic hair of 2, and not in menarche is not attained. Mother's height 155.6 and father's height 167. No syndromic facies, no Turner stigmata. Here in this case, her bone is 10.7. So let's see what does the big will give us. Here, if we see the height SDS is minus 2.26. Clearly, height SDS is less than minus 2. And if we see the BMI SDS, it is minus 0.02. It means the patient is not the, she is not having any growth failure. And if we see the corrected height SDS, it is less than minus 0.5. Like she is shorter than her family. And the height SDS for BA is minus 0.97, which means his height is comparable to her bone age. And when we see the growth interpretation, which clearly shows that his height is more affected than her weight, and it gives the endocrine pattern of growth failure. And the workup showed that all the screening tests has to be done, and if they came normal, the growth hormone assessment should be done. And the pivotal interpretation shows normal and no need for further evaluation in case of pivotal. So moving towards the next case, we have the scenario, and height is 128 centimeter at the age of 8 years and 9 months. At the age of 8 years, she has a breast stage of 3, pubic hair of 1, and not menarche not attained. And here we do not have the X-ray, we just have the bone age. So as I already mentioned that bone, we can manually enter the bone age here. And when we see the results, what we found, she does not have any growth failure. And when we see the pivotal status, she is B3P1, and the pivotal interpretation shows that she has a slowly progressive central precocious puberty. And the pivotal workup, it gives the guidance for the LH, FSH, estradiol, ultrasound uterus, and consider even, it also provides the guidance when to consider the GnRH analog therapy. If the LH is above 0.2 and the radiological features of progressive pubertal is present, and the endometrial thickness above 3 mm or uterine length above 3.4 mm is present. So with these data, we are very much close to make that diagnosis. Even we are not very much familiar with the textbook or the algorithms. This app provides details of these parameters, and even the guidance is provided. So moving towards the next case, we have this 17-year-old boy with a small phallic size, and he has a height of 162 centimeter with a weight of 49.8 kg. He has a SPL of 3 centimeter and TV of 2. At the age of 17 years, pubic hair 3, and the maternal height 168, father's height 177. And here also we do not have the X-ray. We just have the bone age. So with this bone age, we can evaluate further. So when we run the big, and here's the results what we get. He does not have any growth failure. Now let's see what is the height, corrected height is this. He's shorter than the family. And the growth interpretation shows that there is no growth failure. He has normal growth. But in the pubertal interpretation, what we see, he has delayed puberty. And for this delayed puberty, the BIG provides the guidance for initial workup, like LH, testosterone, complete blood count, random blood sugar, sodium, potassium, ALT, creatinine, and TSH. So if I summarize what we decided to do, like we decided to develop an app which is personalized, integrated, and point of care. We have already made it, and we have successfully validated into 50 subjects. It allows the users who are the non-expert. It provides the instantaneous guidance. So I would say it is very much helpful for all the pediatrician and along with the pediatric endocrinologist as well. But it still needs validation across various settings. So thank you.
Thank you, Vibha, and 3 cheers for Vibha for developing and validating this tool. So this is something which is hopefully going to come up very soon for use. We are using it for quite some time in our own center. So we'll just showcase some other cases. One is about obesity, and obesity also causes confusion, and we discussed about monogenic obesity, when to think of. So we have an obesity interpreter. Based upon the basic findings, we are able to really know whether this is a pathological or physiological form of obesity, which is there in that setting. Then we have this boy, 12-year-old girl with height of 130, weight of 58, and we can see she is short and she is obese, but she was reassured, came back to us with growth problem and was diagnosed as Cushing syndrome. But at the end, it turned out to be a pathological obesity. So it's very important to look at a proper assessment, and these tools can really help out in that perspective and regards. We have developed many tools with regards to the glucose disorder, and the pivotal one is the DK interpreter, which allows the management of DK based upon simple findings. Dr. Neha will be here, who is talking about different aspects. She showed in her study that the diabetic ketoacidosis and cerebral edema is extremely common in Indian children, and that is because of inadequate management. So there are guidelines which are there, but they are not properly followed up in that perspective. And when we studied our own children, we found that a substantial number of errors were happening even in our ICU, despite repeated training, despite a written protocol. So what we decided is to develop a sort of a new mobile application which guides the initial treatment based upon the weight, the pH, the carbon dioxide, the dehydration status, exactly what fluid you need, how much volume you need, as well as the follow-up based upon your responses, that now the sodium is 133, what do you do? Or the potassium is this thing, what you do? So this is something which we developed, and this tool was proven to be effective, and we published in that regards. And therefore, the other important factor in terms of glucose is how do we classify diabetes? Now, we saw this case of genetic diabetes where we found that there was a lot of fluctuations, but then we can miss this case. Like this is a 16-year-old boy who presented with obesity and type 2 diabetes in family, labeled as type 2 diabetes, but was not evaluated for autoimmune antibodies and was missed out and developed DK subsequently. So what we did here is that we have developed a diabetes algorithm which has been proven, and incorporating the diabetes interpreter which guides how much is the evaluation required and whether we are going to the right track or not. And this validation was done by Alapan, in which we involved the pediatric endocrinologist, the adult endocrinologist, and pediatricians. And we found that there were significant discordances which were happening in terms of the pediatrician, even the endocrinologist, and that resulted in missing and missing. So children who were having type 2 diabetes were being missed, children who are having obesity with type 1 were misdiagnosed as type 2, and that will have implications. And therefore, if we use it properly, we will have a proper evaluation. The next major problem is the sick day management of children, and we have developed specific tools for insulin doses, correction doses, and sick day, which are used in terms of achieving the good outcome. Very soon, we are going to come up with a DiaBuddy app, which is going to guide individual recommendations based upon carbohydrate intake by children in terms of insulin dose, tracking their glucose, how much they are sleeping, how much they are eating, and other parameters will come in that perspective. And this is the way that the DiaBuddy will work on that. Now, one major challenge has been hypoglycemia, which has been commonly encountered in clinical practice. And this hypoglycemia will cause a lot of confusion in terms of evaluation and management. So now we have developed a glucose interpreter in which it will serially, you have to enter the various information and data, and then you will be able to identify the correct diagnosis and evaluation on that. So there are multiple tools that we have developed in terms of the management of wide variety of pediatric endocrine disorders. And we seriously hope that all of you would be able to access it, provide your feedback and how we can improvise on these tools and develop more tools. Because in future, there was a lot of debate today morning about AI and how AI can change things. I think AI best would be if you use AI properly and we are able to interpret things. Ultimately, we have to make the final decision, but we should at least get all the data in. So as Vibha was talking about, if you get all the data about height SDS, bone age, corrected height SDS, predicted height SDS, you will exactly know and manage it in an appropriate fashion. While if you just go by rough ideas, maybe plotting on the chart, you may not get all the information. So knowing more data will always be more beneficial in that perspective. And we have been trying to develop these tools subsequently, and hopefully over the time, we will be proceeding in that regards. So I think this has been a wonderful session. I'd like to thank the chairpersons, Dr. Somana and Dr. Arpita, for providing us with this opportunity. We are now going to start off with the inaugural function. I'll request Dhwani to start the process.
So to start the inaugural function, I would first of all like to invite Dr. R.N. Chaurasia, Patron Grow Society. Dr. Rahul Jakidhar, Sir, Professor in Pediatrics at Bharatiya Vidyapeeth, Pune. Dr. Saurabh Uppal, Sir, Endocrinologist from Jalandhar, Punjab. Dr. Atul Kapoor, Sir, Patron, Grow Society. Dr. Rishi Shukla, Sir, Senior Endocrinologist at Regency Healthcare. Anurag, Sir, Dr. Yutika Bajpai, Ma'am, and Rekha Sharma, Ma'am, for lighting of lamp and book release. Rishi Shukla, Sir, as well, to the dais, please.
पहले बैठ लेते हैं. हाँ नहीं जगह है वहाँ पे. हाँ. So thanks. So it's really been a pleasure to have this program every year, and we are joined with our people who have been involved in terms of leading this to this program and developing and encouraging us with regards to these developments. Now, this is actually the 5th advanced pediatric endocrine course that we are having here. And it's been a long work. Actually, for the last 3 days, most of the participants have been working in the Regency Healthcare at Regency CDR, and where they have seen a lot of cases, and the entire team of Regency has been involved in ensuring that everybody had a very good time, seeing good amount of patients and evaluating from that perspective. So this actually is the 5th Advanced Pediatric Endocrine Symposium. We have been working in the field of pediatric endocrinology awareness for the last over 15-16 years, and we have conducted a number of practical pediatric endocrine courses across the country, even internationally, with a lot of workshops, as well as advanced program that we have been doing. We then realized that it may not be a good idea and not possible to go to different places and do the programs every time. So we started with the e-learning, starting off with the free YouTube videos. And there are over 400 videos which are available freely in that perspective. And these videos basically are accessible to across the globe. And a lot of people have been accessing these videos over this time. And as we are looking at currently, there are a lot of people who are subscribing even to this program as well. So there are over 1.5 million views which have been given in these videos in terms of this e-learning program. We then realized that we needed to have a structured program rather than just having some videos. So we started off first with a fellowship program from 2017. And till date, in the Regency Center of Diabetes Endocrinology and Research, we have had 11 fellows who have been involved. And I remember Dr. Kapoor, when we went for the first time, and he said that, yes, we should start the program. It was one of the few centers which started the program at that point of time. So in the last 7 years, continuously, we have got very good fellows and with good support from the hospital. In 2018, we started the online learning portal MedEClasses, and then a lot of books and application came up. So we have got pediatric endocrine learning tools. We have got fellowship programs in pediatric endocrinology, a 2-year course. And many of the people who are here actually are part of that course. They are coming 4 times in a 2-year period to gain experience, clinical, as well as learning in that perspective. We have developed the MedEClasses Endocrinology app, which I was talking about. It's the most downloaded pediatric endocrinology app with over 5,000 installs, a lot of publications coming onto it. We are working in terms of developing connected clinics, which will help out people develop personalized care in terms of specific disorders. So we have developed tools to guide evaluation for growth failure, which have been validated. There are tools for management of diabetic ketoacidosis, which have been shown to reduce the complications of DKA. We have developed a bone age application, which provides within 2 minutes a reliable and valid way to assess bone age, which has already been published. A lot of other interpreters are there, which are being published, include our obesity interpreter, our puberty interpreter, as well as thyroid interpreter. So these interpreters are going to make life very easy. You have to enter the values and you will get the right outcome. And they have been validated in a large number of patients in that perspective. We also developed a DSD interpreter. And the next step, which Vibha was talking about, was the bone age assisted interpretation of growth, in which all the pediatricians have to do is to enter some basic information with regards to the child in terms of their age, in terms of their birth weight, and other parameters. And then you have to enter about their pubertal status. And then you can either have a manual entry of bone age, or you can have a data which you have to select the sites and get the right data in terms of bone age. Now, this bone age assisted interpretation of growth is a tool we have been using and validating for the last 1 year in our center. And this has been found to be perfect in terms of not only plotting the data, but also getting a lot of interpretation and whether our puberty and growth is going normal or not. So this is going to be probably a way in which we can really screen a large number of normal children, as well as patients who are coming to different pediatricians in terms of school, as well as clinic, to get the right guidance in terms of evaluation and management from that regards. So we have got different courses. We have on-site course. So we have had 7 on-site courses till now. And yesterday we had a big number of around 48 participants from across the world, actually, and over 300 patients who had come from different parts of the country to specifically come and get exposed in this perspective. We have got multiple publications, and we have now coming up today with the 2nd edition of MedEClasses Basic Pediatric Endocrinology, which is going to be released just now. And I'll now like to invite Dr. Kapoor to start off and share some words on that, sir.
इसको करेंगे आपसे जी जी आओ मैम रेटिंग करने पहले तो बोल देंगे सब लोग ना आइए आइए ये रोटी चले रहा कैसी हैं चलो बढ़िया है
as well, the second edition of Basic Pediatric Endocrinology. This is a book, the first it came in 2019, and now last 5 years there have been a lot of developments which have happened in the field. So this is an updated version of that book, and it will be available. So I'll request all of you to kindly open.
So good evening, friends. Thank you so much. Anurag, thanks a lot for inviting me to this program of yours. And I think the fifth in succession. And some of the people I always meet here only for this program whenever I'm here, round the clock, round the year. So first of all, my compliments to the Department of Endocrinology at Regency Hospital. And especially to Anurag, who has been really a forerunner in this issue, and what all he's created in 5, 6 years, 10 years, in fact, 12 years with us, 12 years, 13 years, 15 years, I keep forgetting. So 15 years of existence of Anurag with us, and the department was started by Rishi way back in 93, 94. So that's where we are, about 30 years plus in the department. And then 15 years back when Anurag joined, so 2 and 2 made 4. And then he made great strides to bring the department as such into the national map where we are. And I'm very proud of him that he's done wonderful work all these years to bring us to this forum. Well, all said and done, innovation is the way for medicine going forward. We have to be innovative and we have to be different. And what we started was this Department of Pediatric Endocrinology, this division, I think is the first time in the country that we could do it. And obviously, I have done nothing. My only patronage is there. I'm just supporting the cause, the department, creating infra, whatever he requires from time to time. Rishi is a guiding force. Plus the city of Kanpur, the doctors who are with us in the city are the people who have supported us all these years. So that has made the difference, the confidence that people have in us. Recently, we installed the Da Vinci Robo about 3 months back at one of my hospitals in Kanpur. And thus far, we've done about 250 cases on the robot, say in about 4 months span. And out of which 25 Yutika has done in gynecology. She just finished her training about 45 days back, 40 days back. So in 40 days, she's in 25 cases of robotics in gynecology. So that just shows that there is a potential to, if you have something innovative, there's always a potential to grow and potential to do different, but you need a leader. So that's where these people have been working hard to see this day. All of you have come from different parts of the state, different parts of the country also. I said last time also, and I'm saying again also, that we start our Gorakhpur hospital sometime in September this year. It's a 300-bed facility with oncology, combined with oncology. And it's on the main road, just next to the medical college, about 500 meters from the BRD Medical College. Anybody who is from that area, who is interested to be, basically attached with us, he can always approach me, Anurag, Rishi, anybody, so that we can, look forward. And fortunately, People think that Gorakhpur is Gorakhpur is not Gorakhpur, by the way. If you go to Gorakhpur, then you understand that what difference the government has made in last 8 years. And in fact, all the big 5-star hotels now are in Gorakhpur, which are not in Kanpur. So that's the surprising part. But the wonderful work they have done over there. And so that's the reason that we forayed into Gorakhpur. And I was, basically, I am surprised that the amount of doctors and colleagues, who have come forward to go to Gorakhpur on their own was surprising for me, honestly. I thought I'll have a dearth of people, where will I get them from? But it looks so easy. The reason for this are two mainly. One, saturation of metros. Number two, people who are living far away from their state or from their family or from their, parents want to come back to the state if they get a level playing field. So this is what we are doing. We are trying to create a level playing field for doctors to come back to the state. Every, let us say, every 7th person in this world is from India. You go anywhere, you go to Europe, you go to America, every 7th person is an Indian. Recently, I was abroad in Europe and I found that everybody is speaking Hindi over there. So Indians are, everywhere. So don't worry. And every 6th person from the country is from UP. See, every 7th person is from India and every 6th person in this country is from Uttar Pradesh. 24 crores of population. So we have at least every 6th doctor in the country is from UP. So that is our motto, that we want to grow big in UP. Currently, we are operating 5 hospitals in Kanpur and the 6th in Lucknow. 7th Gorakhpur is starting maybe in August, September. And Varanasi next year, 300 bed, same type of hospital, sometime next end of 25. So that is where we are. And all this has been possible with the strong team that I have of doctors. Unfortunately or fortunately, what you say, our attrition rate is only 1% to 2% maximum. People who came 30 years back are still with me. Who came 10 years back are still with me. 15 years back, they're still with me. And I don't think anybody has left the company, because Regency is a family. Ultimately, it's not a corporate hospital, it's a family. And we bring up people as a family. And everybody can, vouch for this, that people who are with me, that I never treat them as, they're all my colleagues, my friends, and my family. That's most important. That's how we will go forward. I wish you all the best. And I wish all of you, thank you so much for coming to Kanpur all the way. And to all of you, my best wishes are always there. Thank you.
So please stay on. We like you to give the awards to people and the certificates. Dr. Yutika, please come up as well. So we'll call one by one. Yeah. Quickly. Jaldi karo.
Certificates. The first one we have is Dr. Vibha Yadav, who has recently completed fellowship from Regency and has joined as an associate consultant here. Dr. Pradeep, sir.
She has joined us as a consultant at Kanpur, now associate consultant. And one of his another fellows, Neha, has joined us in Lucknow Hospital as an endocrinologist. Thank you.
Thank you. Yeah. Quickly, jaldi karo. We'll call Dr. Pradeep, who has been part of our team, and he was the examiner also for the session yesterday. So Dr. Pradeep is from AIMS Patna, and he has been part of Grow India and MedEClasses for a long time. So Dr. Vikas Mehrotra, who is again a integral part of our team. Yes, certificate baad mein de deete. And was part of the examination team also. So we had 17 people who appeared for the fellowship exam. We haven't got the results back yet. Or maybe we have probably. Dr. Vikas was one of the examiners.
30 सेकंड समय कम है, लेकिन बोलना जरूरी है. डॉक्टर अनुराग और डॉक्टर युथिका एक दूसरे कॉम्प्लीमेंट करते हैं. एक आदमी करेगा मैंने ये काम किया, दूसरे का मैं रॉबर्ट लगा लिया मैंने. She did 25 surgeries and extra excellent work. So just complimenting each other under leadership of हमारे बड़े भाई, हमारे पैटर्न सर के बारे में क्या कहूँ मैं आपको. बस आगे बढ़ते रहिए. शुभकामनाएं सब लोगों को. Thank you very much.
So we'll start off with the fellowship certificates.
Who?
we have got the results. They are being released one by one. So we don't know who all is successful. So maybe you can take it off beforehand.
Yeah. The first I'd like to invite Dr. Anusha ma'am.
So Dr. Anusha Reddy, she is from Kanpur. Just give me this thing. Dr. Anusha. Yeah. So we like to have your experience.
Good evening, everyone. Good evening, sir. Thanks for giving me this wonderful opportunity and this wonderful certificate, of course. I was just keeping my fingers crossed whether I'm going to make it or not. And I would like to thank Sir, Regency CDR, especially all the fellows also who have put in such a hard work to put up such a good show at the on-site course and as well as here. These 2 years, I would say that this is just opening of the Pandora box because in our undergraduation days, I think pediatric endocrinology is one subject which is undermined and understated. So this experience has given me a wider view at pediatric endocrinology, and I feel much more confident of dealing of the cases. Every 6 months, I would say, have been improving, and I think it's an ongoing process, and I would seek sir's blessing and guidance henceforth also. Thank you.
Dr. Sona Gupta ma'am.
Dr. Sona. Dr. Sona is from Jaipur. The mic. Dr. Deepa Gupta is from Nepal, from Janakpur. Dr. Deepak was my junior at AIMS when I was doing my senior residency.
Yeah, actually, the learning from sir is continuing from there only. I still remember one case of DK managed by him. And it was so extensive learning experience that the flow diagram continuing from the same aims that I'm so fascinating with the teaching style he has. And so I'm continuing with him for the last 5 years. And I can surely tell that there is no better place to learn pediatric endocrinology than this center. Thank you.
Dr. Lovelesh Gopalia. Dr. Lovelesh Gopalia is from Rajasthan. She is in the ESI hospital there.
Thank you so much, Dr. Anurag sir and MedEClasses to provide a great platform to learn endocrinology. Thank you so much.
Dr. Vidhu Ashok.
Dr. Vidhu is from Calicut, from Kerala. And she is moving to Oman, I think.
Thanks a lot, sir. Like every time coming here, it's a beautiful experience that all of us know by now. So thanks a lot, sir.
Dr. Bifina Begum.
Thank you so much, sir. It means a lot to me. And this 2-year journey with Anurag sir was a vast learning experience. All the on-site visits, we had a huge academic feast. We saw all the rare cases we used to read only in textbooks. And each on-site visit, we also used to look forward to coming like to a second home because we had friends from all over India and outside. So thank you so much, sir.
Dr. Santosh Kumar, sir.
Santosh is from Kasaragod in Kerala, and he's the professor there. And please go ahead.
Thank you, sir. Thank you. Good evening. It's the third time I am coming here. For me, everything was new here, very much refreshing. Everything was innovative. That I don't know anybody in the world is dealing a subject like this. He's putting new idea in medical education itself. So that's a big change. Things he is making simpler. We know this algorithm approach work everywhere in every field, but nobody is trying it. All departments, all specialty, they can try it, because we know as a teacher, we know the basic when we manage ADD, diarrhea and pneumonia, the most dreaded complication in pediatric age group. In big center, AIMS, or in PHC level, it is done by the simple our management protocol. 3-4 signs that we are looking and we are managing it. Like that, in all speciality, it can be done. And sir had rightly going through that journey. And he's at the same time, he's an IT professional, scientist, researcher, whatnot. Very excellent teacher. That's what. So if I am very much sure if he is going to develop an insulin pump, that will be more physiological, because he will incorporate everything into that, because he will incorporate our health app into that. If you walk it that way, do exercise, the insulin pump will adjust that. By chewing, it will calculate the amount of food you take, everything he will make that. Okay, I am damn sure about that. So last 2 times I to say 1 or 2 words and just went off. This is because he had awarded me. so I don't want to take much time, 1 or 2 minutes also. So these are he's opening new horizon, new era in each field. That's what. Yeah. So I thought telling so many things. One thing is that in basic pediatric endocrinology, the basic stuff is that either there is an increase or decrease, or stop or on, like a traffic light, red or green light. And associated with that, and if there is a traffic light, there will be block somewhere. And if you look like the steroidogenesis and all, there will be block, and some other ways people will run. Like that same thing only is happening. The basic idea of pediatric endocrinology is that. But now today, this pre-analytic, analytic and all things, you are telling that unnecessary investigation, this thing. So if you are in a traffic light at early morning, 2 a.m., and there is nobody in all the roads, in the junction, there is no road, the light is red. Then what do you do? What Indian people or usual people do is that they will jump it. But the ethical person, if a European sees that red light, he will stay there. And when the red light changes to green only, they will go. So I'll give you a word. I will practice that ethical way. Don't worry about me. Okay. So I am going to wind up. The first time I came, I have a lot to say, sir. Your hospitality, the team. I met Manoj that time, your fellows. Then Sayan, Viva, then Dhoni, now in Alapan, and Prashant now. Okay, they are all doing wonderful, and their personality also is changing, sir. That kind of, like, I'm 50 plus now. How can I observe that? So that's what I told the first time. He is a karma yogi. He's a karma yogi, will get connected to God through his work. That's a spiritual liberation to that. Thank you, sir. Thank you very much. Thank you, sir.
Dr.
On the lighter side, today you can't stop, you can't move on a red light. I'm telling you. There are cameras all over this country now. And I'm telling you the reason. Recently, you know, I sold one of my old cars which my driver was driving. So the car was sold, no problem. But when it went to the regional transport office for transfer to the new buyer, he said, please pay 25,000 rupees challan first on before you can transfer. So now the e-Vahan facility in the country, the e-Vahan app, everything is recorded. Trust me, you are also being recorded everywhere. So that thing I think is over now.
Dr. Nitya. Dr. Nitya is as additional professor at Thrissur Medical College. Yeah.
So very good evening, one and all. So this is probably a dream come true for me. As we all said, Anurag sir was the person who was bridging the gap between the desire to learn pediatric endocrinology, and now it's like you are a fellow of pediatric endocrinology from MedEClasses. So thank you so much, sir, for this. We have learned many things from sir. We all know, like sir is 20 years of medical and I started drawing flow chart. So till now I've not been doing that. From sir, I started drawing flow chart and more than that, apart from pediatric cardiac, sir told lot of other things we have done. The soft the way the smile, even in the mid of such a so even the way he asks questions to us, we are all like old age learning people. So when he asks questions and we make some blunders, still he smiles and then he tries to like console us. Okay, you are in a way right, but that is not the right answer. So so many things, and I would immensely thank the whole team, sir. It's like ably guided by you, all your fellows, starting from Sayan, Naveen, Manoj, now Vipa and Alapan and Dhwani and all the team, like all the sir's assistant teams, Prashant, Nikhil, so many people. So thank you so much for this. And now that sir has taught us alphabets of ped endo. Now we'll start making small letters and small words, then followed by small sentences. And I need your blessings, sir, for all this. And maybe I wish this will be very helpful for the patients throughout our country, maybe throughout the world. And please bless me for making best use of it. Thank you, sir.
Dr. Princey Joseph.
Princey. Dr. Princey is from Kollam, Kerala. Like she's in the medical college there.
Yes, yes. They all joined together, so they're
Good evening, all. I am actually very happy that I joined the course 2 years back. At that time, I am not sure whether I will be able to complete the course. I will be able to come out here all the way from Kerala to Uttar Pradesh to join, and whether I will be able to cope up with the other fellows here. But in sir's company, it was such a wonderful journey. As Nitya pointed, every time when we meet sir, we are meeting a great leader, a great human person who can accommodate the poor candidate and the brightest candidate. And also we can ask any blunders, and with a beautiful smile, he will correct us without feeling humiliated. Thank you, sir. Thank you for the wonderful opportunity. Thank you.
Dr. Mahesh Maheshwari.
Dr. Mahesh is professor at AIMS Bhopal, and Dr. Mahesh has been long-term. We was SRs together at AIMS. So.
So thank you very much. First of all, I think I failed in the exam because he's not taking my name. So it's joke apart. I think first time I met Dr. Anurag in 2001. When Dr. Anurag was a third year PG and Dr. Yuthika also a third year PG. So we attended few delivery calls also at the same time, and something like that. At that time, I thought Dr. Anurag will go in nephrology because he was doing the thesis in nephrology. And so I thought he will go in nephrology. We worked 3 years and we had a lot of pediatric endocrinology discussions also. Then somehow I was in a different academic institute. 2011, Dr. Anurag again brought me back to pediatric endocrinology. So it was, I think, the first conference that you conducted it here. At that time, it was again the burning desire of coming through the pediatric endocrinology. I think that was there. And 2017, when I joined AIMS, I think this is the people like Dr. Anurag and then the team MedEClasses. I think that is the reason why I started at pediatric subspecialty at AIMS Bhopal. And now it's almost 6 years. And now it's started giving the fruits. I am seeing that one of my senior residents is a faculty at Regency. So, and there are maybe a few more that they are here. And we started with the senior link, resident link fellowship at AIMS Bhopal. And hopefully the super specialty course of DM also going to start at AIMS Bhopal in January onwards. So I think that will be the third DM in India. And I think Anurag plays a very important role in that. Though this time I came as a student primarily, and I had a little apprehensions, tachycardia, palpitations, and Anurag took the exams in the same manner. So, and he's not taking the name also, and the other expert is saying probably you are failed. So it's a joke apart. I think it's once again the congratulations and best wishes, Dr. Anurag. You are having the long way to go. And I think with you and with all the stalwarts here, I think all of us will take this pediatric endocrinology way forward. Thank you. Thank you very much.
Dr. Sumana, ma'am.
Thank you. Thank you.
What can I say? Every time I try to speak, I become emotional. Everybody knows that. But today I won't be emotional. I'm really very happy. This is a day we all have been waiting for. Thank you, sir. Thank you, Team CDER, everybody. I mean, I can't explain. I mean, my heart fills with gratitude every time I think about this miraculous divine design that we say, by which I got connected to sir. I mean, we all have probably, we have done some good so that we got connected to him. And I mean, I am so grateful that I got to learn so much from him, from everybody, from all of you, my friends and colleagues. I got to learn something or the other from each one of you. And I'm so grateful. Thank you, ma'am. So we all consider sir our guru. And as everybody said, that he's not only the best teacher probably I have ever come across, but he's a wonderful human being and we should learn a lot from him. And this is not the end of, this is the beginning of the journey. And I'm sure I'll be able to help at least some children around my locality. And please bless me, sir. Thank you.
Dr. Arpita Brighuvanshi.
Dr. Arpita. Dr. Arpita is professor at KGMU. Yeah.
Dr. Arpita.
Thank you so much, sir. I just consider myself blessed that I could meet sir, and I think now with 2 years association and running my own pediatric endoclinic, I have that confidence that I'll be able to do justice to my patients, and sir's blessings I always seek. And even though I got this fellowship certificate, I'll continue to come each year. And I feel that one or the other area of the brain gets awakened every time I visit the center. Thank you so much, sir. Sir has changed my life in the truest sense. Thank you.
Dr. Alka Jha. Dr. Sangeeta Das.
Sangeeta Das. Sangeeta is working at AIMS Nagpur.
Dr. Sangeeta. Yes, sir. Thank you, ma'am.
what to say. Everyone has said everything. Like the more you say, the less of the words it will be for sir. Like since past 2.5 years, it was an absolute honor and privilege on my behalf to work with sir and to learn under sir. And thank you to all the MedEClasses team for assistance and support in time of need. And I hope this is not the end, because the time flew very fast, and we would like to visit every 6 months for this holistic meet and do like ourselves, better ourselves. Thank you so much. Thank you, ma'am.
Dr. Jyoti Agarwal.
Dr. Jyoti.
Thank you, Anurag sir. Thank you for all your support and guidance throughout this 2 year. And thank you to all the MedEClasses who had supported me throughout this 2.5 year. And I think this will be a continuous process from learning from you, sir. And what to say about sir? Sir, I'm thrilled to see his knowledge and the way he explains us about every cases, and he's always smiling, even listening to our blunders. Thank you, sir, for all your support and guidance. Thank you, sir.
Congratulations.
I'll now request Dr. Dhwani to give memento to Dr. Kapoor.
Thank you.
Before you go to the chair, sir, I'll request sir to give mementos to our fellows who have been working very hard in this regards. Dr. Vibha, who is no longer a fellow, she is now who is now a consultant. Dr. Dhwani. Dr. Alapan. Dr. Sandeep. Dr. Sandeep has just joined. He joined the same day as the on-site course started. Thanks a lot, sir. Please take a chair. I'll request Dr. Chaurasia, our patron, to kindly say a few words of, sir. Maybe you can say from there if you're comfortable.
धन्यवाद डॉक्टर अनुराग। मंच पर सभी सम्मानित अतिथियों का, ऑर्गेनाइजर्स का मैं नमन करता हूं। आप सभी डेलीगेट्स जो पूरे देश से और बाहर से आए हुए हैं, विदेशों से भी, मैं उन सब का हार्दिक स्वागत करता हूं ग्रो सोसाइटी की ओर से इस 5वें एडवांस पीडियाट्रिक एंडोक्राइनोलॉजी सिंपोजियम में। जहाँ तक मुझे बेहद खुशी है कि अभी मैंने आप सबके विचार सुने, ये कानपुर के लिए बहुत ही गौरव की बात है। और मैं चूंकि कानपुर का बासिंदा होने के नाते 2 बातें आज आपके सामने रखना चाहता हूं और आशा करता हूं कि आप मेरी बात से सहमत होंगे। कानपुर में जो मेडिकल सर्विसेज थी अब से कोई 50 साल पहले जब मैंने काम शुरू किया था, तो वो सर्विसेज ऐसी थी कि कुछ बीमारियां, कॉमन बीमारियों को छोड़ के हर बीमारी के लिए दिल्ली और बम्बई का रास्ता बताना पड़ता था। पास में जाना हो तो लखनऊ चले जाइए, दिल्ली चले जाइए या बम्बई चले जाइए। हम लोग परेशान इस बात से रहते थे कि ये कानपुर में ये अपने काम कब से शुरू होंगे। मैं इस बारे में ये कहना चाहता हूँ कि रीजेंसी ग्रुप के चेयरमैन डॉक्टर अतुल कपूर ने जो काम शुरू किया वो आज कानपुर में पूरी पूरी दुनिया के लिए मिसाल बन गया है। 5 अस्पताल कानपुर में और 3 अस्पताल बाहर, और न जाने कितने अस्पताल अभी और आएंगे। डॉक्टर कपूर ने पूरी तन्मयता से कानपुर के लिए वो सब किया जो आज यहाँ के हर पब्लिक को, हर पर्सन को जिसका एहसास है। दूसरी बात यह है कि इस रीजेंसी हॉस्पिटल ने जिस तरह के आयाम स्थापित किए हैं मेडिकल एजुकेशन के लिए, अपनी सर्विसेज के लिए, जैसा कि अभी हाल में बताया कि रोबोटिक सर्जरी कानपुर में शुरू हुई है। डॉक्टर अनुराग के बारे में मैं कहूँ तो शायद मैं कुछ कह भी नहीं पाऊंगा, जितना आप लोग बेहतर समझते हैं अनुराग के बारे में। अनुराग टीचर ऑफ टीचर्स हैं, अनुराग एक बेहतरीन डॉक्टर हैं, और अनुराग की जो सर्विसेज हैं वो मेडिकल प्रोफेशन के लिए टोटली डेडिकेटेड और डिवोटेड हैं। डॉक्टर अनुराग एक डॉक्टर ही नहीं, एक डॉक्टर का जो असली माने होता है वो डॉक्टर हैं। ये पढ़ाते भी हैं, इलाज भी करते हैं, चैरिटी सर्विसेज भी करते हैं, सारे पब्लिकेशंस भी करते हैं। शायद ही कोई ऐसी फील्ड बची हो, मेरे 50 साल के अनुभव में मैंने ऐसा डॉक्टर नहीं देखा जो हर फील्ड में अपना दखल रखता हो। इनका एक विशेष स्नेह मेरे लिए है, मैं इसके लिए बहुत ही इनका शुक्रगुजार रहता हूँ, और हमेशा यहाँ आकर के अपने आप को बहुत ही गौरवान्वित महसूस करता हूँ, बहुत ही खुश महसूस करता हूँ इनकी इन तमाम सर्विसेज को देखकर। इनकी चैरिटेबल सर्विसेज के बारे में भी मैं आपको बताना चाहता हूँ कि ये तो आपका कॉन्टिन्यूइंग मेडिकल एजुकेशन के तहत जो प्रोग्राम होता है, लेकिन कम्युनिटी मेडिकल सर्विसेज में भी इनका कोई जोड़ नहीं है। जिस हिसाब से ये मरीजों की जो इनकी क्लब है और जिसमें वो सर्विस देते हैं, वो भी अपने आप में एक बहुत ही काबिल तारीफ काम है, और जो एक डॉक्टर के उससे होना चाहिए। मैं इन शब्दों के साथ आप सब आए हुए डेलीगेट्स का हार्दिक स्वागत और अभिनंदन करता हूं, और आशा करता हूं कि आप यहां से बहुत ही लाभान्वित होकर के जा रहे होंगे। और एक चीज़ और देख के मुझे बहुत खुशी हुई कि डॉक्टर विभा जो जिन्होंने फेलोशिप की और अब यहाँ की फैकल्टी हैं, ये इस बात का भी द्योतक है कि डॉक्टर अनुराग और डॉक्टर अतुल कपूर की क्या सोच है हमारे इसके बारे में। मैं कानपुर की ओर से आप सभी का हार्दिक स्वागत और अभिनंदन करता हूं, और मुझे बहुत फख्र है कि कानपुर का नाम देश और दुनिया के नक्शे में पहुंचाने में डॉक्टर अतुल कपूर और डॉक्टर अनुराग का विशेष स्थान है। धन्यवाद।
बहुत बहुत धन्यवाद सर। I'll request Dr. Rishi to say some words of encouragement for the people. जी जी आइए।
Good evening, friends. Thank you, Dr. Invite and Dr. Anurag, Dr. Yutika for the invite. Before I start, I think one word about Dr. Kapoor. You made us proud to stand way back 30 years. We lived together, we fought together, we struggled together, but end of the day, we ended up loving together. So this was the beautiful journey with him. It will continue. I was remembering my undergrad days when I was first year in med school, and there was anatomy was the most difficult subject, and the professor used to say there's a Gray's anatomy book. I think all of you must have read, and there was a parallel book called Samar Mitra's book, and we used to read from that book, and professors also read, and they discouraged to read from that book. Am I correct? I mean, so from where, and then I was thinking about him. Had there been a professor like Dr. Anurag who could have clarified the things, Because Grace, he wrote everything, but in so disorganized way. Now I can say, having disorganized, that things were not, see, not me, there was 100% to, you have to remember. But now what I understand, had a anatomy teacher been like him, so something to remember and something to understand, that will make things and foundation very easy. So from where this journey started, and I'm 30 years old, he's 15 years old. I think we are blessed to be together. We did many things together. And one line I can say about Dr. Anurag is, he's the person who is enlightened with knowledge. And he has capacity to lighten many people. And that capacity is visible here. And because I also travel across the country, so I think all good stalwarts are my friend. So sometimes I talk about him and sometimes they talk about him. So, I mean, very harshly, I am saying that this specialty is divided. Some of we are still together. But because there is no difference. The basic anatomy is more or less same. Basic endocrinology is more or less same. And so there is, I'll not go into debate, but sometimes people ask about him and sometimes I say very proudly, I mention his name very proudly. So keep growing, keep lightening. And I think you are one person who made pediatric endocrinology very interesting, useful, and available to everyone. I remember a small incident, I'll tell you. I was in PGI Chandigarh, and I used to learn testicular biopsy with my urology friends because infertility was part of that. So all urology residents were my friends. So somehow a gynecologist came to learn about testicular biopsy. And then the professor came, he saw that she is doing this. Then she kept her out. No, madam, you are not allowed. You are now doing MCH urology. At that point of time, gynae was also eligibility to appear for MCH urology. So if you want to do appear in MCH urology, enter into PGI Chandigarh, I will teach you. But right now you are not allowed. So he made pediatric endocrinology available to everyone. There was a debate also that whom to serve and whom not to serve. But I think both of us went beyond that. To serve whom? To serve the population, to serve the people, to serve the country. And wishing all the best. Keep doing well. Do well. And thank you, Yutika, once again. She has finished 25 surgeries, so I will treat her. Both of us are. So I love you. Both of us are, I mean, the common fact, both of us are very, very strong.
We are sweet lovers.
Sweet lovers, sweet lovers, sweet lovers. So we'll treat both of them. So all the best and keep doing well. Thank you.
Thank you, Dr. Rishi, for all the encouragement in making this possible. I'll request Dr. Rahul Jagirdar, who is a professor of pediatrics and pediatric endocrinology at Bharati Vidyapith, Pune. And he has come all the way from there. Please. Yeah.
Thank you so much, sir, for your kind invitation. It's always a pleasure to be here. And my association with Dr. Anurag goes about 10, 12 years back when we kept on meeting in CMEs. I've seen him from those days and learned so many things, the evidence of which I could see from all the people who just spoke about him. I know you're going to do great work, sir, in Pediatric Endocrinology Society, and hope to work and learn from you as we go further. Thank you so much.
Thanks a lot, Dr. Rahul. We have got with us Dr. Saurabh Uppal, who is a young Turk from Punjab. And he's a very dynamic fellow. We saw his presentation. Your thoughts on this whole?
Sir, I must congratulate you on your continuing success because through them you will serve the population. In addition to that, we are also very thankful to Dr. Anurag for giving, first of all, recognition, for bringing about recognition to pediatric endocrinology, because when he started, it must have been very difficult. So what you are seeing now and you're getting attracted to pediatric endocrinology is all because of efforts of people like him in the country. We are all really indebted to him for that. And also we look forward and look at him as a leader for us to lead us forward. Thank you.
Thank you. Thanks a lot. And I'll request Dr. Yutika to say a few words and vote of thanks as well.
I would like to thank everyone for attending this session and also would want to say so many good words about Kanpur and about Anurag. As Dr. Kapoor was mentioning me, so many girls are now changing, coming and praising. Are you not insecure? So we were joking around, but jokes apart, it makes me immensely proud and very, very happy to have you here and for liking our course, for enjoying it and making our goals to reach each and every child. So when we came back from Australia and, we were discussing on RT that we are two people, how good change we can bring about to many lives. So it's very important. So you cannot do it alone. You should have team of like-minded people. And here we are creating like-minded people who are even better than us, I would say. And now they're going to save so many children and so many lives and families would change. So that makes us very, very proud. Thanks a lot.
Thank you. I'll request Dr. Vibha and Dr. Dhwani to kindly give mementos of appreciation to Dr. Rishi, Dr. Arench or Asia. Dr. Rishi Shukla. Dr. Rahul Zagirdar. Dr. Saurabh Uppal. And Dr. Yutika. And to Mrs. Rekha Sharma, Dr. Dr. Alapan. I'd like to thank all of you for this wonderful words of appreciation. And we'll be starting our program. We're running a bit late, so we'll start in the next 4 or 5 minutes or so. But thanks all of you for these kind words. Thank all the participants who have come from across the country and even internationally who have come here and spared their time. And thanks for the wonderful team who is here, including the team who is present here and the Regency team who has been there in CDR working for the last 4 or 5 days. Thanks all of you. And hope we'll have more such unions coming up. Thank you. Thank you, sir.
All the best.
Yes.
For a great future.
Thank you, sir.
Bye-bye, everybody.
We'll have the national anthem before we. So request all of you to kindly stand up for the national anthem. With the next session in the next 5 minutes. And I'll just request the speakers to kindly give the presentations. So Dr. Saurabh, you can.
I would kindly request everybody to come over to the table here and collect your certificates, please.
So we are restarting the session now. We are running a bit late, so we'll start it right away. We have so Dhwani, you can initiate the session now.
The next in line, we have glucose in 2024. To chair this session, I would like to invite Dr. A.C. Agrawal, Senior Physician from Kanpur, and Dr. Deepak Yagnik, Senior Diabetologist from Kanpur. Good evening, sirs, and a very warm welcome to the 5th APES program. I would like to request the chairpersons to open the session.
Good evening, friends. At the outset, I thank Dr. Anurag and Dr. Yuthika for arranging such a beautiful session and such interactive sessions for all of us. This is the session particularly dedicated to the diabetes and what's the new in 2024 so managing glucose. Shall we start or should not?
Yes, so please introduce the first speaker.
Yeah. So the first speaker is Mr. Rahul J.
I would like to invite Dr. Rahul Jagidar for the first talk.
And
Sir,
he is going to speak on the newer insulins.
yes. Sir is a consultant at Bharatiya Vidyapeeth Pune, and over to you, sir.
And I'll request all the people to kindly come up and start the session because we're already running late. And there's a match also which is happening at 8 o'clock. So a lot of people will be going for the match probably. So we want to be on time.
Thank you, Dr. Anurag, for a kind invitation. Like we know, we have a session after this. So I'm going to be very quick and fast in my talk and try to cover something about newer insulins. So like we know, insulin was discovered almost 100 years ago. And from there, we have reached a stage where it started from the animal origin, which was later modified by addition of fish protein to make it a longer acting insulin. Then came addition of zinc and the change in pH to make the NPH insulins. The addition of zinc further increased the action and we had lente insulins. This was long back. From there, this is a time chart which shows how the insulin evolved over a period of time. So in 100 years, we have come to a stage this of 2020, and most of the changes which have happened in the last decade or so. So the next 10-15 minutes or so, I would be speaking about what we have achieved in the last 10 years and what likely newer changes are going to happen in the next decade or so as far as insulin management is concerned. We know the management of type 1 diabetes essentially includes the basal bolus regimen, which includes giving the basal injections and a bolus for 24-hour action. Most of the changes have happened in the rapid-acting insulins and the long-acting basal insulin analogs. In the rapid-acting insulin analogs, we have tried to modify them so as to have a faster onset and glucose-lowering action, whereas the basal insulins give us a longer duration of action, which is flat and peakless, gives us more flexibility of the timing, and less evidence of hypoglycemia. So let us start with the basics first. Sorry. The rapid-acting insulins generally have a slowish action because after injections, they are broken down into the monomers and hexamers before they start their action. Studies have shown that the beta chain of insulin, the position B26 and B30, are not necessary to bind to the insulin receptors, but these sites are responsible for creating dimers. So most of the changes or research has been done in these two sites, this area, so as to bring about changes in the insulin molecule. Sorry. So the first rapid insulin analog was insulin Lispro, which was prepared by modifying the amino acid changes at position 28, followed by aspart and glulysin. So this is the insulin molecule, and most of the changes were brought in here so as to give us the rapid acting analogs. What they essentially did was they gave us the flexibility of timings, decrease the postprandial hypoglycemia events, and decrease the late postprandial hypoglycemic events. So what is new as far as rapid insulins are concerned? We now have an insulin fast-acting aspart called as FIAPS. It was initially launched in 2017. FIAPS basically has niacinamide and L-arginine added to it. L-arginine gives us stability, whereas niacinamide improves or shifts the hexamers towards monomer. Also, because of its vasodilator action, it gives us increased blood supply and increased better uptake of insulin from the site of injection. Studies have shown that aspart comes in the blood faster as compared to the fast-acting aspart comes in the blood as compared to the aspart. It gives us better concentration of insulin, greater insulin action in the form of reducing glucose in the first 30 minutes after injections. In addition to that, it gives us better patient satisfaction because it can be given just before meals or sometimes after meals to suit the erratic lifestyle of the children and adolescents. As far as the basal analogs are concerned, we had injection glargine, which was the first approved long-acting basal analog. Basically, glargine changes the pH from 5.4 to 6.7, and now it is injected in the form of an acidic injection, which is at pH of 4, thus getting precipitated subcutaneously and is released slowly. It gives us a peakless profile lasting for almost about 24 hours, and that is the advantage of injection glargine. It is given once a day. Because it is acidic, it should not be mixed with any other insulins and currently approved for use in children above 2 years of age. This was followed by injection detemir, available as levemir in the market. I'm not going to go into the change of position, but basically it contains the hexamers and dimers which are attached to albumin, and this gives us the prolonged action. The action starts after 2 hours of injection, and it's lasting for about 16 hours. The drawback is you may have to give detemir twice a day, which is not really accepted by most of the patients. Currently approved for children about 2 years of age. And the injection degludec. Degludec is available in the form of Tresiba in the market. It produces multiple hexamers leading to the extended action profile. The action profile lasts for about 25 hours, so it is given only once a day. The long-acting profile gives us better glycemic control, lowers the risk of nocturnal hypoglycemia, and gives more flexibility in timing of the injections. It is currently approved for children above 1 year of age. So just to highlight the insulin profile for what you just saw, we have the rapid-acting insulin analogs and then the long-acting basal analogs in the form of detemir, which needs to be given twice a day, glargine, and degludec. So this is where we were in about last 10 years. Today we have a newer basal analog in the form of glargine U300. So this is basically a glargine which is 3 times more concentrated. It gives smaller molecules which are precipitated subcutaneously, and the depot preparation is broken down slowly over a period of time, thus gives us a longer duration of action. Benefits: reduces nighttime hypoglycemia. It is again has greater flexibility and has less weight gain as compared to the normal glargine which we see. Half-life is more than 24 hours, currently approved for use in children about 18 years of age. So what new is likely to happen in the next decade or so? Starting with something called as Peglispro. It is a long-acting insulin analog. It consists of insulin Lispro attached to polyethylene glycol molecule, which is known to increase the duration of action. Benefits would be a comparative fat peakless profile lasting for about 36 hours, and it could be probably coming in the market very soon. This is insulin Icodec, which is once weekly administration injection insulin. Icodec forms strong reversible bonds with albumin. It has a decreased enzymatic breakdown and slow receptor mediated clearance, making it a long-acting insulin. When we start injecting it, it founds a depot with albumin subcutaneously. And over a period of time, in about 3 to 4 weeks, the depot reaches a phase where the injected insulin is equal to the clearance of the insulin, giving it a week-long action. Currently, it is in a trial phase of phase 3, likely to come in the market in the next 3-4 years. The other way of giving injection insulin is to the lungs, the inhaled form of insulin. Like we all know, lung, because of the large surface area and blood supply, could be an attractive medium for giving insulins. And inhaled insulin is available in 2 forms, dry powder formulations and a solution which is given through a specific inhaler system. The dry powder inhaler system was called as Exubera, which came in the market in 2006 and was taken off within a year of its launch. Reasons being it worsened the respiratory conditions in patients who had respiratory disorders. Also, malignancy was reported in patients who used Exubera. So currently, Exubera is no longer available. What we have is the liquid solution in the form of Afrezza. So Afrezza is a human recombinant insulin which uses something called as Technosphere technology and a new generation inhaler called as Dreamboat to deliver it. The Technosphere drug delivery system created by microparticles which from microspheres and then lyophilized into dry powder inhalations. Technosphere insulin, which is the regular insulin, gives action within 15 minutes of its administration, and current trials are in type 1 and type 2 patients in phase 3 going on now. It was or it is used in adults in some centers, but no longer available in pediatric practice. The literature showed me there was one more inhaled insulin in the form of DANCE 501, which the company's website says in the phase 3 trials and is likely to come in the market within the next 3 years. We will wait for this advance. The other form of delivery other than the inhaled insulin is the buccal delivery of insulin. Now, insulin in liquid form can be delivered in the buccal mucosa or just behind the tongue. This insulin formulation is stable at room temperature for 6 months, and the particle size of the aerosols here are more than 10 micrometers. Therefore, you do not go to the lungs and have a local action at the site of insertion, which is the buccal mucosa. Each puff is supposed to deliver 10 units, and the absorption of this is variable, so it is not very readily accepted or used currently in practice. One more interesting feature of giving insulin could be the oral forms. A lot of patients are waiting for this, so are the doctors. The problem with oral insulin is that we cannot predict the absorption of insulin once digested. The destruction of insulin could be variable considering the acidic pH which has to pass through it. So there have been various methods developed to overcome this, including mucosal patch adhesions or nanoparticle encapsulation. A newer device in this form is something called as LUMI device, the luminal unfolding microneedle injector, which can be swallowed. It bypasses the gastric mucosa and directly reaches the small intestine, where the microneedles of insulin are now available, and they start their action there. Despite many years of research, currently this still remains in the early study period and is no longer commercially available, but could be one of the options available soon. The concept of smart insulin analogs, this is essentially glucose responsive insulin, which work on the bioarithmetic module, which can sense the glucose over a period of time and then decide to deliver or not deliver insulin. It uses one of the 3 biometric mechanisms to do this, either glucose oxidase, glucose binding proteins, or the power derivatives. And this concept of smart insulin is coming up in a big way and could be available soon. One more interesting advance is the palmlintide with insulin. We all know that amylin is secreted with insulin from the beta cells. And in type 1 diabetes, when the beta cells are destroyed along with insulin, amylin also is destroyed. So palmlintide is a synthetic analog of human amylin, which can reduce the postprandial glucose spikes by decrease the gastric emptying. Studies have shown that palmlintide with insulin have brought down HbA1c significantly and also increased the time in range in patients whom they have tried. So this is a very interesting module which can come in the market in the recent future. A different concept is something called as cone snail insulin. Now this cone snail uses, or when Coulsnell bites spray, the venom contains insulin, which causes hypoglycemia and its spray. The insulin here is in monomeric form, which has a molecular mimicry with the human insulin, and trials are on to use this form of insulin in humans, which could be a great breakthrough if at all we are successful with that. One more advance could be hepatic directed insulin lispro, which is delivered to hepatocytes by targeting moiety. Again, phase 3 trials are currently going on, and the results are expected to be launched in next 5 to 6 years as far as the research is going on. Very soon, we would have one of these 3 insulins. One of them is LY 9014 Lispro, ultra non-active insulin, recently completed phase 3 trials. The biochaperone insulin Lispro, which is already available in some centers. It contains oligosaccharide, which has faster absorption, as well as the speed of absorption is better in this. And a newer one called a super fast insulin aspart, which along with aspart, in the experience of bound to metal ion and have a binding capacity. As of a couple of years back, this was in phase 1 trial and now advanced to phase 2, and we could see this coming up soon. Other than this, we could see modification in the delivery of insulin. We know that the skin surface, the stratum corneum, is one of the most major barriers for insulin absorption is action. So there have been techniques which have been explored to overcome this skin barrier in the form of I just go to the next slide for that. The advantages of transdermal delivery system could be better patient compliance, prolonged therapy, avoidance of the first pass effect, and decreased degradation in the gastric system. The various methods could be the ultrasound, which can be used to increase the permeability across the skin, NRI light, temperature modifications, or microneedle devices. So as to summarize, recent advances in basal bolus regimens will provide substantial improvement over the prior insulin formulation which are available. Long-acting basal insulin therapies have demonstrated lesser hypoglycemic events and giving us more flexibility in the dosings of insulin. Newer bolus therapies, which are faster acting and have faster absorption, could improve the postprandial hyperglycemias. Newer modalities like fast-acting Aspro, the Technosphere insulin, have promising results, but would require more research to come in the market. Future approaches, which we discussed, like palmlantin insulin, combination of with Coulsnell insulin, hold a significant promise. And the hepatic or the oral directed glucose still under research phases and would take some more time if at all they succeed and come in the market. So I will close by saying this, that insulin has marked the end of era in diabetes, but not the end of diabetes. Our research for new modalities and methods of delivering insulin still continues. Thank you.
Thank you, Dr. Rahul, for a mesmerizing talk about the glimpses of the types of insulin to come. And in continuity of that, we have now future of type 1 diabetes. So you have seen what are the newer insulins available, newer devices, and now it will be about what is the future of type 1 diabetic patients. And Dr. Saurabh will be telling us all about this. Dr. Saurabh, please.
Thank you, sir. And so thank you, Dr. Bajpayee, once again. And thank you for giving me this topic, because I had to do so much work reading for it, but it has enlightened me also, and I'll try to pass on some of the things that I've learned to you. I remember the first APES, and Dr. Bajpayee himself was talking about it. And I remember his words, if I had a crystal ball, I would keep it on my table and give an answer to all the parents who come. Because I remember Sita and Geeta, the two girls in that example in the talk. And he said, when we were training, we were told that the solution is 15 years away. And then later, even now, we are told the solution is 10 to 15 years away. But things are moving very fast, and there are many things to look forward to. So what the future holds is in 3 categories: better insulin delivery, precision genetics, and immunotherapy. Better insulin delivery is already here. So in fact, the future is here. So we have advanced hybrid closed loop, which is not as good as the physiological insulin delivery because it's still in the skin. Till the time we have a portal delivery, till we have insulins which are faster, this is actually the future. What further is going to happen to advanced closed loop is personalized closed loops are going to come, which will integrate machine learning algorithms within this closed loop insulin delivery system. So what will happen after that? It will predict insulin requirements based on CGM and patient-specific characteristics and external factors at the same time. And it will start learning individual glucose patterns and adapting insulin delivery strategies in real time to optimize glycemic outcomes. The current advanced hybrid closed loop learns for 3 days and then applies the knowledge. After that, it is just building upon that. But the models that are now being are in processing will just keep on building on that data. Just like the previous ChatGPT did not remember your conversations, but the ChatGPT 4.0 now you can go back to any conversation and start from where you started. So that is what is going to happen with the personalized closed loops. Now, glucose responsive patches for closed loop dual hormone delivery have been tried in mice and pigs. And as Dr. Jagirdar was telling, glucose responsive insulins. Now, how are they going to be delivered? These are the new generation devices that are going to come, transdermal needles, and depending on the glucose, insulin or glucagon is going to be released. So no battery, no electricity, nothing. It is just nanotechnology. Because as if you remember the previous talk, the third compound was phenylboronic acid. So it is being integrated, which reversibly shifts the net charge of the entire matrix. So depending on which direction the charge is going, either insulin will come out or glucagon will come out. So this allows a modulated release ratio of the negatively charged insulin or positively charged glucagon, because it's as simple as that. Insulin is negative, glucagon is positive, charge moves negative, the compound gets released. So this will be a dual hormone glucose responsive closed loop system. Now, emerging research areas, teplizumab, we all were very eagerly waiting. We were a little disappointed because the duration of postponement was not that great. We all know, for those of you who have been initiated, teplizumab is a monoclonal antibody that targets the CD3 and it interferes with the activation and function of T cells. So it prevents the autoimmune attack on the pancreatic beta cells and delayed the onset of T1D by an average of a few months to a few years. The studies that are ongoing will enlighten about the durability of the treatment effect. So everybody thinks such an expensive therapy, at least some more time should be given. Evaluate the potential for teplizumab to be integrated into standard care for type 1 prevention, and combine teplizumab with other immunomodulatory agents for therapies to enhance efficacy and primarily extend the duration of therapy. It's a very good molecule, but doesn't make a great difference. Now, CRISPR-Cas9 has come up in many things in pediatrics. You've seen patients getting cured by this technology. It's getting into diabetes also. So we can use CRISPR-Cas9. You all know, like SMA patients are being treated now even in India, and they are being cured of SMA. It's gene editing, and you can correct genetic mutations responsible for monogenic diabetes. It's not in type 1 or type 2, but monogenic. In protection and restoration of beta cell function by modulating immune responses. That is a jellish thing for the future. The challenges still remain the precision in targeting, delivery mechanisms, and ethical implications. So that is why CRISPR-Cas9, although it's a very promising therapy, not very difficult to reproduce in different diseases, but still hasn't been able to cure all of our genetic disorders. Now, what are the advances in genetics that are going to... So this is where things are going to really change in the time to come. So there have been attempts to identify genomic risk factors and core genes. So, and development of polygenic risk scores for, so you all know when a family has one child with diabetes, they have all the questions about the other children and also the marriage, the future, next generation, all these things. So polygenic risk scores are being utilized. Integration of HLA and non-HLA genetic data to assess individual susceptibility, because higher scores have correlated with increased likelihood of developing type 1. And because we have things like teplizumab coming in our armamentarium, and if the duration of prevention extends, this is going to be a direction to look forward in the future. And implementation of genetic screening in newborns and high-risk populations to identify individuals who are eligible for diabetes postponement therapies. Next, we have biomarker integration. So all these biomarkers, so biomarker integration has really brought cancer treatment way forward. Now, biomarker integration can also help us in diabetes because use of antibodies, we all do antibodies. And you use other biomarkers alongside the genetic risk to improve the prediction accuracy. We already have the biomarkers, GAD65 and insulin antibodies. The problem is how to use them to stratify the risk. So when all these genetic biomarker and clinical data are combined, you can have predictive models. And that's where diabetes is going to go. Now, personalized immunotherapy for targeting specific pathways. So target identification, like what are you going to target once you are either treating the patient or postponing or preventing diabetes in not in the true sense, but in a way. So immune pathways and molecules involved like IL-2, CTLA-4, Tregs, tailored therapies like immunotherapies targeting identified pathways like monoclonal molecules, and autoantigen specific approaches like peptide vaccines, tolerated dendritic cells to induce immune tolerance for beta cells once you get into stem cell transplants. And progress in monitoring and adaptation. Now, continuous monitoring we do for glucose. But what is the future? The future is going to be continuous monitoring of immune parameters and disease progression to adapt treatment regimens. We all know that diabetes doesn't behave all the same over the years. First year is different, second year is different, then puberty would be different. So to adapt our treatment regimens, immune parameters and the disease markers can be brought together. So, and also assess the response to therapy and just dosing or switch therapies as needed. And then combination therapies. So synergistic effects from combining immunotherapy with beta cell protective strategies to prolong the honeymoon phase, to delay the onset of clinical diabetes in the pre-diabetes stages or metabolic interventions. Now, a lot of parents come and ask us, weigh in and, Doctor, what about stem cells? What about stem cells? So I thought it's a good platform to sensitize all of you who are going to go and start practicing type 1 diabetes to have a solid answer to what is the current status of stem cell therapy for type 1 diabetes. So a lot of people have so many opinions about it. But the stem cell therapy and cell therapy, although used in the same breath, are a little different. So cell therapy involves the transplantation of functional cells. For example, deceased individuals' beta cells are harvested and given. That is cell therapy. So you would give either pancreatic islet cells or beta cells, which is the islet cell transplant or beta cell transplant. On the other hand, stem cell therapy is a little different. It uses the stem cells, which can differentiate into various other cells. We all know there are two types: pluripotent cells, which are subcategorized into embryonic and induced pluripotent stem cells, and adult stem cells, which are the mesenchymal stem cells. Now, the current, so the status of pluripotent stem cell derived pancreatic progenitors, they have limited success in clinical trials. The mesenchymal stem cells have immunomodulatory and can be differentiated. These cells have shown promise in preclinical trials, but haven't yet been tested in clinical trials. The challenges for stem cell therapy include immune rejection, tumorigenesis, and finding optimal transplant sites. So whatever success we have had till now is for cell therapy rather than the stem cell therapy. But a very exciting future direction is encapsulation. So encapsulation devices, as the Vertex trial is going on, you all must have said it was presented in Florida a few days back. They've got the permission to increase the number of patients because 11 of their patients are insulin free for 1 year. Now, encapsulation devices and immunosuppression still have their drawbacks and limitations. And we are really going forward by genetic engineering. But the future direction may be mesenchymal stem cell derived exosomes. So because it is a cell-free therapy alternative. So what is the biggest problem? It's immune rejection. So you create an exosome. So you create a packet which is not attacked by the immune system, which is an exosome. We all have read about exosomes in our basic sciences. So they are extracellular vesicles naturally released by cells. And they're small membrane vesicles. They have a lipid bilayer, do not contain a nucleus, and they're derived from endosomes. So exosology is a new branch of genetic engineering that is coming up because they can function as one-way conveyors of genetic cellular material from secreting cells to the cells of their function. And they have functions similar to mesenchymal stem cells. as promoting cell repair and modulating immune responses, and they can be used as cell-free therapy. So you give a cell, it is rejected. So you give a cell-free therapy, it may not be rejected. So that is a future direction. And these exosomes are a new focus in diabetics therapy because there's no risk of teratogenesis. There's no nucleus. There's no DNA material. So there's no teratogenesis. They can be stored and used as off-the-shelf therapeutic tool. You don't need to go and harvest. There are packets of exosomes. You can just give an infusion and they start working just like mesenchymal stem cells. And they can be administered intravenously and repeatedly without invasive procedures. All the present therapies, you have to give an infusion directly into the portal vein, which is a very invasive procedure and you need a lot of paraphernalia for it. Exosomes can just be given by IV infusions and they have autonomous targeting ability. They're just carriers. They just go there, deliver, and they finish off. It's not like a cell which is circulating and you need a constant immunosuppression for it. So it's a very exciting new direction. And it's called educated exosomes. They know where to go, what to deliver. But the challenges will still remain in standardizing the preparation characterization before they can be widely used. Now, what is the status of cell therapy? So stem cell therapy is still has a distance to cover, but cell therapy is reaching somewhere. So this is the first approval, FDA approval last year. So donislicel, that is Lantidra. So islet cells harvested from deceased donors is FDA approved. The aim is to replace the insulin producing beta cells by an infusion into the portal vein. It was tested in 2 open label studies, total 30 patients with type 1. 21 of the trial patients did not need to take insulin injection for a year or more. 11 of these have 5 years have passed, they have not required insulin. 10 more than 5 years, and 5 of the subjects but unable to achieve any days of insulin independence. So it didn't work in all of them, but worked in quite a few of them. But there are safety issues with the procedures because it has a need to take immunosuppressing medication to stop the damaged cells. So as I said, the biggest problem is the body itself. Although they are off insulin, but they're on immunosuppression. So you have to tell the parents, what will you choose? Something that like insulin, which is given properly, does not damage, versus something which is a battery of tablets for immunosuppressions, which may have a problem, because a majority of patients treated with Lantidra experience at least one serious adverse effect rising out of either the procedure or immunosuppression. And in some cases, the immunosuppressants had to be discontinued. So once you discontinue, the treatment goes. It costs 2.5 crore rupees for one patient to get Lantidra. So if their immunosuppression has to be discontinued, it's all gone. So the approval is nevertheless a regulatory landmark for cell therapy in type 1 because in 2023, it is the first FDA-approved therapy which can be given to a patient. Now, things are moving fast because all of you have heard about 3D printing. Now, 3D beta cells are going to be printed. So Novo Nordisk has had a $1 billion deal with Aspect Biosystems. So they are developing non-donated off-the-shelf beta cells that would be 3D printed into an encapsulated implant and then given to the patient. They're designed to protect them from immune surveillance, but still allow them to release insulin in response to blood glucose levels, very early stages. But this could be the bioink that is being generated has an immune evasive mechanism. So it's an exciting space. Anyone recognizes this person? He's been all over YouTube these days. Once Vertex presented their data in Florida ADA, he's a YouTube sensation. He's the first person who's been cured of type 1 diabetes. Hunter Schultz is his name. So that's the therapy that he has taken is Vertex VX880. He's giving interviews all over. So I have no problem in displaying his picture. He's himself all over the web. So Vertex VX880 is the therapy. And the new data has suggested that the therapy can restore the physiological activity of the insulin-producing islet cells. Now, this study enrolled 17 people. And the data came from 12 treated with the full dose given only as a single infusion. 3 patients met the study's primary endpoint of elimination of serious hypoglycemic events and a reduction of A1C to 7% or less, along with becoming insulin independent. So you don't get hypoglycemia, but you still get HbA1c less than 7% and you don't need to give insulin. All 12 showed that islet cells had grafted and were producing insulin in response to glucose level within the 3 months. 11 of them have been able to reduce or eliminate insulin use. Of the 10 participants who completed the follow-up visit on day 187 are no longer using insulin, and 2 have cut down their insulin use by around 70%. So now the company has been given a regulatory approval to expand enrollment to around 37 patients. So this is an exciting space to watch, but all of them are still on immunosuppression. Now, Vertex is also developing a version called VX264. So cells are put in a protective pouch to protect them from rejection, and the pouch is just kept under the skin. So there is no need for an infusion inside the portal vein. So the phase 1 or 2 trial of VX264 began last year. So this is an exciting space to watch because you are bypassing in a way by putting it subcutaneous or intradermal, this cell pouch. So in conclusion, things are moving. So things are moving a little faster than they were moving at least 10 years back. So that's what the hope we can take. But the future is going to be integration of technology, immunology, and artificial intelligence. It's not going to be one therapy that is going to cure diabetes. So it's going to be an integration. And the hope should be shared with families, but with a very conservative manner. So it brings to the common counseling that we have when parents come and ask, Dr. Saab, ye insulin kab tak lagani padegi? I would like to end up with the very practical point. This is all science fiction, but practically so I used to have different answers in the initial few years. Last 1 year, there has been an answer which I think clicks better with the family. So I'll share it with you. You can all use it. So when they're very disappointed and they tell me, Dr. Saab, iska ilaaj kab tak aayega? So I just tell them कि आज से 10 साल पहले अगर किसी की किडनी खराब हो जाती थी तो कहते थे कि अब इसको सारी जिंदगी डायलिसिस लेना पड़ेगा, पर अब किडनी ट्रांसप्लांट हो जाती है, आप जानते हो किसी को जिसका ट्रांसप्लांट हुआ है? एंड दे वुड से यस, हम जानते हैं। एंड सर उनका डायलिसिस बंद हो गया ना? तो क्या बंद हो गया? तो ऐसे ही जब तक कुछ आएगा जिसको ट्रांसप्लांट हम नहीं कर सकते, आएगा जरूर, क्योंकि किडनी ट्रांसप्लांट भी आ गया, कल को पैंक्रियास का या कोई सेल है जो इंसुलिन बनाने वाले सेल का भी ट्रांसप्लांट आ जाएगा, तब तक इंसुलिन लगानी पड़ेगी। And suddenly, from despair of giving insulin all their lives, they can correlate to a transplant survivor, and then things move forward. So till the time something from this comes out and we share how to use it, we can just use this. Thank you very much.
तब तक हमें ऑर्गन्स को बचा के रखना है, तब से ऑर्गन को बचाना है, क्योंकि हम आगे और चले गए।
Thank you, Dr. Saurabh, for really a fiction movie that we were seeing apparently. And this is very encouraging for the type 1 diabetic patients for future, though it may take time. Thank you very much. But you said, what is that? Disease donors. Who were the disease donors for, pancreatic beta cells, islet cells?
So there is a program that is run by the NIH in the US where they take consent and they harvest for somebody who's got pancreatectomy for some reason. So they harvest the cells from that. So it's a government-run, NIH-run program in the US. Because now almost everyone who's getting a hepatorenal transplant with serious hypoglycemic unawareness, so they offer this trial to almost all of them.
I think that was a wonderful talk. And specifically, I think one issue is about when you're comparing bionic treatment, which is the technology-based treatment versus the biological treatment. Biological treatment will always be better in terms of control and complications. So people have tried all the artificial pumps and all the things. If you're able to get a biological cure, that is the ultimate holy grail as far as type 1 diabetes is concerned, I think. Yeah, thank you.
So our next speaker is Dr. Anurag. Dr. Anurag, what to say? Everybody has appreciated so much about you. So you will be giving a mesmerizing talk again. So Dr. Anurag, about the classification of diabetes. Dr. Anurag.
So yeah, so this talk is going to be more practical compared to the previous one, which was showing more what is going to happen in the future. But we'll talk about classification of adolescent diabetes. So why do we need to classify, whom to classify, how to classify? So we have a 16-year-old boy with polyuria who has a blood sugar of 440 and a HbA1c of 10%. He had some ketones which were there, had decay, managed with insulin, and then somebody thought that now this person is actually obese, has got some acanthosis, there is type 2 diabetes in the family. Let's think this is type 2 diabetes, this is not type 1, and started on metformin, insulin was stopped. Now what happened? 1 year later, the child came back to us with diabetic ketoacidosis. So this is a scenario in which somebody who was actually a obese type 1 was labeled as type 2 diabetes Unfortunately, insulin stopped and decay happened. So this is something which we don't want to happen. And that's why classification becomes important. Now, when we talk about diabetes in children and adolescents, we used to always say type 1 versus type 2. So type 1 being ketotic, insulin requiring severe, and type 2 being non-ketotic with oral medication. Now the spectrum is changing. We know that there is an overlap of insulin deficiency and resistance in both of them. And in between, we have got various forms of diabetes, neonatal, MODY, LADA, and ketotic prone. So the spectrum is really changing. And we want to know when do we classify, how do we classify, and how to go forward. So we know diabetes could be because of insulin deficiency or resistance. Deficiency could be genetic, neonatal, or monogenic forms. Acquired in the form of type 1 with specific insulin secreting cell defect. Latent autoimmunity of diabetes, pancreatitis. Resistance can also be genetic or acquired. So do every children require evaluation? Because the evaluation is expensive. You want to do a GAD antibody, that will cost you 6,000 rupees. You do a genetic testing, it may cost you 15,000 rupees. So does every child require a GAD antibody, a C-peptide, or a genetic testing is the question. The answer is a big no. And we will try to see how we have developed a tool which will guide which child requires evaluation and which does not. So type 1, essentially, if you have an onset before 1 year of age, of course, you're thinking of neonatal diabetes, particularly if it is before 6 months of age. If your insulin requirement is low, and by low, we mean less than 0.5 unit per kg per day for more than 1 year. Beyond the honeymoon phase, you have to think that, okay, this is a low requirement. Of course, if antibody is negative, it may or may not be type 1 diabetes, but other features may point towards MODY. And if you have a 3-generation family involved, think of monogenic diabetes. On the other hand, if you have a type 2 diabetes without, so don't, of course, you have no obesity and acanthosis, this is of course not type 2 diabetes. But in our experience, we have seen that the children may be overweight and not obese. The reason is that they have lost weight during diabetes. So just being overweight does not exclude type 2, but you can't have a lean type 2, at least in our experience. Then if you have very early failure of drugs, think of LADA, and ketosis against more or less type 2 diabetes in most cases. And if you have an abnormal fat distribution, think of lipodystrophy. So now once we know that we want to classify diabetes, first of all, we like to go in terms of clinical parameters as to how we can help. So studies have shown that there are two major things. One is age at diagnosis, and second is the need for insulin, which will guide us. BMI is not going to help you a lot. So when we talk about evaluation, I think the most important parameter from our side is persistent insulin requirement. If you have a persistent insulin requirement, don't bother. You're mostly dealing with type 1 diabetes or insulin requiring diabetes. However, if your insulin requirement is less than 0.5 unit per kg per day after 1 year of onset, you have to keep your minds open now that something else has gone up. BMI, as I said, is not a good criteria, but if you are lean, then having type 2 diabetes is extremely difficult. However, if you are obese, you can be type 1, type 2, MODY, anything can happen. DK, again, is not going to help you out much in this perspective. Now, what about assessment? So assessment things we discussed, we can do it at the level of pancreatic function. So imaging is not a good modality to look at the exocrine pancreas. Best is fecal elastase. So if you're thinking of pancreatitis, get a fecal elastase, because only a few with calcification will be picked up. Otherwise, you will not pick up these individuals. Beta cell function, you can use insulin and C-peptide, and we'll discuss about what is better. And for autoimmunity, the best, of course, are antibodies which are there. Now, insulin sensitivity is a difficult thing to assess. The ideal way to assess insulin sensitivity is a hyperinsulinemic euglycemic clamp, which we don't do in routine clinical practice, but you can have other surrogate markers which can be done. HOMA-IR or insulin levels are not a good marker of insulin resistance, so don't rely on those levels. Look at other parameters. So when you want to classify diabetes, you've got two things, autoimmunity and beta cell reserve. Autoimmunity is there to rule out type 1 diabetes. Or you can say rule in the sense, if you are positive for an antibody, you're most likely type 1 diabetes, or rule out type 2 diabetes in this setting. While beta cell reserve, if it is persistent beyond 1 year, it rules out type 1 diabetes. So you need to know what has got what specific role. early in disease, autoimmunity is going to be helpful. Later in disease, you will go more towards the beta cell function, which will give you how you are progressing from that perspective. Genetics, we were discussing a lot, but at the moment, I would not really tell towards routine assessment of genetics unless you're thinking of monogenic diabetes in that regards. Now, how do you assess the insulin status? We, of course, have got two options. You can look at insulin or C-peptide. Insulin has got short half-life. It's very unstable compound. It's not a good marker. So insulin levels are not a good marker of your beta cell status. C-peptide is co-secreted. It is a good marker of insulin secretion, and it is equally secreted in the same molar quantity. So you can go for C-peptide in that regards, and that becomes important. For insulin resistance, we go more with higher insulin requirement and acanthosis than actually other parameters in that regards. So beta cell function, I would say if you want to do one thing, you should do a random C-peptide. A random C-peptide when your blood sugar is above 140 is what will you tell you exactly in terms of whether you're dealing with type 1 diabetes or not. So if your random C-peptide is more than 3 nanogram per ml, that really excludes type 1 from that perspective. It goes more in favor of type 2. If it is really low, less than 0.6, this is suggestive of type 1, but because of glucotoxicity, C-peptide may also be low. So this is not a very good test if it is low. If it is high, it's a good marker. And if it is persistently high after 1 year of diabetes, you are pretty much out of type 1 diabetes. That's what we are saying. So GAD antibody is ruling in type 1, C-peptide is ruling out type 1. This is what you can understand from that regards. So we can classify based upon the presence of autoimmunity and beta cell function. If you are autoimmune positive and you have no beta cells, lifelong insulin. Forget about everything. You don't need to do anything else. If you are autoimmunity negative, beta cell negative, you also will require usually lifelong insulin, not much difference. However, if you are autoimmune positive and beta cell positive, you may be honeymoon phase or a milder form of diabetes. You have to watch and wait and watch. And if you are beta cell positive and autoimmune negative, type 1 becomes unlikely and type 2 becomes more likely. However, the bottom line is before you diagnose type 2 diabetes in an adolescent, you should get an autoimmune evaluation, without which the ISPAT guidelines say you cannot label somebody as type 2. So GAD is essential in an obese adolescent. Otherwise, you will make the mistake of the case I started off with in the initial phase. So how do you classify? If the onset is before 6 months, this is most likely neonatal diabetes. Go for genetic testing. After 6 months, and 6 to 12 months, you can say GAD antibody negative, go for genetics. Beyond that period, you look at insulin requirement. If you have persistent insulin requirement, don't do a GAD antibody. It's just a waste of money. You can use it later on. This is usually type 1 diabetes. If the insulin requirement is not there, then you can get a GAD antibody, which will classify into positive and negative. A pubertal individual who is obese, who doesn't have a decay at onset, you can get GAD antibody right at diagnosis to identify type 1 versus type 2 diabetes in that regards. So our classification is largely based upon how much insulin you are requiring, how long has the diabetes been there, when was the diabetes diagnosed, and whether the child is pubertal or not. And mostly you will get a classification without doing much workup in that regards. So now we have a 16-year-old girl with increased urine output. RBS is 258. There is mild ketosis, lean individual without acanthosis, labeled as type 1 diabetes, on insulin having recurrent hypoglycemia. So do you think this is type 1 diabetes? So there's a very, very mild diabetes, non-ketotic, lean, so type 2 becomes unlikely. So this is classically going more in favor of a monogenic diabetes, and this turned out to be an HNF1 alpha defect. And here, if you use insulin, you will develop hypoglycemia. Now, why do I want to diagnose them? You just give them a very, very small dose of a sulfonylurea or glinide, or even a GLP-1 analog. They will respond wonderfully well for life. They will not need much medication. So identifying them will be very, very important. This was the case I talked about, type 2 being mislabeled, type 1 mislabeled as type 2. So you should always get an antibody before you label somebody as type 2 diabetes in that regards. And this is the ISPAT guidelines. always you have to prove that the antibodies are negative before you label somebody as type 2. That is something which is important. Now we'll run through a few cases quickly. 2-month-old boy, failure to thrive, not gaining weight, hepatomegaly, myopathy, and weakness. Sugars are very high. HbA1c is high. Triglyceride is very high. So do you think this is type 1? Very early onset. So this has to be a neonatal type of diabetes. And I've given clue of hepatomegaly, myopathy, and weakness. So this is the potassium ATP channel defect, which happened to be a KCNJ11 defect. This will respond to glibenclamide. So this is a good diagnosis to make. It will help you out reach the appropriate diagnosis in the right time. 15-day-old girl, birth weight of 1800 grams, failure to thrive. So this girl is presenting a bit earlier compared to the previous child. Sick looking, very high sugars, non-ketotic but dehydrated, managed with fluid and insulin. You would need to go ahead and do a genetic study here. And the child did not afford genetic study. So do you think this will be a permanent diabetes or a transient diabetes? We cannot predict entirely, but this is more going in favor of a transient form of diabetes in which improve. But remember, if you have a transient neonatal diabetes, it may recur later on in life, maybe early for severe defects and later for milder defects. So after 12 years, developed polyuria, hyperglycemia, HbA1c became high, and on insulin, we start thinking that there's something wrong there. So this is actually a monogenic diabetes, which presented at initial phase and now recur again. And there would be a ABCC8 defect, which we found, and the child is responding wonderfully to sulfonylurea. So classification is important because you can actually do not need to give insulin for a long time. You may have very good control in this perspective. 12-month-old girl with failure to thrive, birth weight is 2500 grams, blood sugar is 360, family history of consanguinity. Now, when you have a consanguineous individual with an early onset, you start thinking of some genetic diabetes. So what will you look at on examination in this child? The most common cause of neonatal diabetes in a consanguineous individual is Walcott-Rallescence. You will look at the fingers, you will look at the other things. So you found these funny things which are there in the X-ray. And on investigation, it was found to be Walcott-Rallescence syndrome, which basically is a syndrome associated with hepatic dysfunction. International reports suggest that this is a very severe form and all of them die by 1 year. But we have many children, including our center, and Dr. Vaman has reported many centers in which they actually have a good survivor. So it's not that it's a very bad diagnosis. They may have hepatic dysfunction on and off in this regards. 2-month-old boy with failure to thrive, hyperglycemia, recurrent skin infections. So always think of something else. So it's definitely, it's soon, it's severe. You have other features, diarrhea, skin infection, GAD positive. So do you think this is type 1 diabetes? So this is something else. Type 1 diabetes doesn't happen before 6 months. This is another form of immune diabetes, which is the IPEC syndrome, in which there is an immune dysregulation. We talked about APS1 in the morning. This is another form of thing in which FOXP3 is defective. So your immune tolerance is not happening, and this becomes a very, very difficult condition to treat. 11-year-old girl on routine investigations found to have mild fasting hyperglycemia, and prandial value is going slightly up. She is lean, no acanthosis, non-ketotic. You think this is type 1? LADA? What do you think? What's unique in this girl? The rise between the fasting to PP is only 13 points. If the rise is less than 4 millimoles per liter or 72 milligrams per DL, the recommendations are you start thinking of a glucokinase deficiency, which is basically a sensing problem. The body doesn't sense glucose till a level, no insulin, and suddenly starts sensing your fasting is high, but PP doesn't go up. So this is a classical example of a GCK defect. And in this scenario, you don't need any medication. They will remain stable in terms of hyperglycemia. We got the history that the mother, the grandmother, everybody had mild diabetes controlled on just the lifestyle intervention. So this again becomes important. 15-year-old girl with osmotic symptoms, high sugars, HbA1c of 10.4 with DKA. However, she is lean, no acanthosis, and family history in mother. So she looks like type 1 diabetes, but she has a very fluctuating course. With 2 units, she will develop hypoglycemia. Otherwise, the sugar will go to 300, 400. So if you have these sort of unusual situations, always think that this could be something abnormal going on. So in this scenario, we got a targeted panel which showed a HNF1 beta. But when we got the ultrasound kidneys later on, we found there were multiple cystic lesions which were there. So the message is, maybe if you have a doubtful case, get a renal ultrasound. You may get something. You may get hepatic adenoma, which is there in which form of diabetes? Hepatic adenomas, HNF. So one of the HNF1 alpha may have hepatic adenomas. You may have renal abnormalities, and HNF1 beta is actually usually presenting with renal anomalies. Mother had the same, and they may not even have diabetes. So something you need to be aware of. 17-year-old boy with weight loss, mild diabetes, HbA1c 8.5, non-ketotic, BMI is in the obese range, no acanthosis, and metformin was there, blood sugar was normal, and it was stopped. Now, there was a history of neonatal hypoglycemia. So I gave you a history of neonatal diabetes, and now you have a history of neonatal hypoglycemia. So which disease? Anybody? So some form of HNF mutations, we know they will present with neonatal hypoglycemia and hyperglycemia. So we are trying to say clinical clues will give you a picture. 11-year-old girl with type 1 diabetes, diagnosed at 8 years of age, insulin 1 unit per kg per day, and she has visual complaints. She goes to an ophthalmologist who says that you have developed retinopathy. Now, all of us who are sitting here know that nobody will develop retinopathy in 3 years of diabetes, that to type 1 diabetes. So do you think there's something else going on? Yeah. So you have to think of other forms. There is optic atrophy, which is there, GAD negative. So immune negative diabetes with visual complaints equals dead mode syndrome. So this is something you need to be very, very, very much clearly aware about that in that regards. 14-year-old girl completely emaciated, severe hyperglycemia, HbA1c very high, still non-ketotic, very lean, fat percentage 3%, insulin requirement is 3.2 unit per kg per day. I think this is a classical picture I've given. This is a classical picture of lipodystrophy, in which you have got no fat where you can store it. It all goes into your liver, causing insulin resistance. Very difficult condition to treat. Leptin is a therapy of choice, but not available. It's very, very difficult condition, of course, there. 19-year-old girl with developmental delay, visual defect and deafness. Random sugar is 240. HbA1c is 8.4. GAD negative. So again, GAD negative is important parameter coming out here. With metformin, she had a worsening. So a girl who has developmental delay with diabetes, with deafness, and metformin, she goes into the ICU. So this is clearly a mitochondrial form of diabetes which can be there. And this is the mitochondrial diabetes with deafness in that regards. 14-year-old boy with obesity, polydactyly, nyctalopia. We are trying to go through easy cases now. Blood sugar is 144. HbA1c is high. What do you think it is there? Bardet-Biedl syndrome. And I have seen Bardet-Biedl having insulin resistance at 5 years, 6 years. So this is a very, very difficult condition. And somebody was discussing about Bardet-Biedl treatment. I think you were talking about specific therapy which is there. At setmelanotide also as a treatment there. It's a very difficult condition to treat otherwise. 16-year-old girl with hyperglycemia, mild, lean, GAD negative. She has anemia, neuropathy, and pigmentation. Again, we are going towards a diagnosis. Anybody? So B12 deficiency was found, and this was found to be a megaloblastic anemia transporter defect. So there are ways in which you can diagnose these rarer forms of diabetes. They will constitute around 5% to 10% of all of your diabetes. We have seen many patients who were labeled as type 1 and type 2 turn out to be MODY. And we have seen that in our onset course as well. So keep your eyes and ears open for these other features which are there. 12-year-old boy with polyuria, developmental delay, hyperphagia, infantile hypotonia. I think this case everybody will know. Once you diagnose diabetes here, it's very, very difficult. This is Prader-Willi syndrome. Extremely difficult to treat. We tried GLP receptor analog and all those things, but it was not really working in that regards. So now we have talked too much about diabetes classification, and we have tried to develop our algorithm which is cost effective, which does not require too much interventions based upon the age, duration of diabetes, insulin requirement. And based upon that, we have developed a diabetes interpreter. You just put those data, you get the likely diagnosis, whether you need evaluation or not. And what we did, we validated this in 302 subjects. And we validated with pediatric, adult endocrinologist, pediatric trainee, and our own scenario. And what we found that there was significant discordance between different parameters. So very interesting thing which happened was the pediatric endocrinologists were missing type 2 diabetes. The adult endocrinologists were doing more GAD in type 1 diabetes. The pediatric endocrinologists were not doing GAD in type 2 diabetes. So everybody had their own sort of a thing. So once we looked into that, the workup recommended by the pediatric trainer, you can see 299 out of 302 patients, the pediatric trainee said, yes, I would like to do either a GAD antibody or a genetics. So you see how much more unnecessary workup would be done when it is not required, while the algorithm, which is largely ISPAT based, says only 51 children required. So 16-17% will require evaluation. But if you go by the general guidelines, you will need much more evaluation. So this is something which we want in terms of a tool which can help out in that regards. So diabetes classification is crucial. It's expensive, but do it only if it is indicated. Go for clinical clues and use autoimmunity and genetics only when needed. Don't do it in everybody just because it's available. Thank you. I think we'll close on that.
Thank you, Dr. Rag. As usual, a mesmerizing talk, and people are not able to even gaze their eyes away from the screen and ears away from you. Our next talk will be given by Dr. Rishi, as Dr. Neha is a little bit late, but no problem. Neha has come. Okay. Yeah.
Neha is there.
So the next talk is by Dr. Neha about the Modi.
So Dr. Neha has been our first fellows, one of the first fellows with Dr. Chetan in 2017. And she is again now part of our team. She has joined the Regency Hospital at Lucknow. And over to you, Neha.
Good evening, everyone. So first of all, thank you, Anurag sir, for setting the stage for me to continue now on another category of diabetes, which is not very common. It constitutes nearly 0.5 to 2% of all the pediatric diabetes cases that we come across. And this is maturity onset diabetes of the young, or MODY. So my talk will be basically when to suspect and how to manage this genetic condition known as MODY. So as sir has described, that diabetes is not all about type 1, that is insulin deficiency on one hand, and type 2, that is insulin resistance on the other hand, but is a spectrum of condition in which you may have intermediate forms as well. So till now, we have been classifying or categorizing patients with diabetes based on the age, based on the presence of autoimmunity, and based on the insulin dependency. But as sir has already pointed out, that all the cases do not fit into the tailor-made criteria, since all diabetes is not the same. So just for an instance, if we look at this picture, it clearly shows that the peak age for different types of diabetes do have some overlapping ages. So if we go by categorizing diabetes just on the basis of age, it is not that easy, because we may have MODY type 1, type 2 in the intermediate age group as well. So why is this current diabetes classification failing? Because it is often imprecise. We do not have a clear-cut criteria. The Flatbush diabetes, which is ketosis-prone diabetes, it may be present in type 2 as well. So a ketosis-prone diabetes is not always type 1, but few type 2 cases are also ketosis-prone. You may have antibody positive, as sir said, you may have type 1 patients who are obese. So clinically, they may look as type 2, but they are type 1, that is obese type 1. Then you may have type 1 diabetes looking patients with insulin resistance who may end up being diagnosed as type 2, that is overweight type 2 diabetes cases. And then there are certain cases which are complicated by extensive overlap between the phenotype and etiology. Then
So if we are going about the management, we have to give insulin for the management of acute hyperglycemia. And then based on the requirement, whether the patient needs insulin or not, we need to shift it to the OADs. Then what is the need to classify diabetes? Because it is not only management oriented, but it also plans care. It is cause specific studies and therapies are planned on the basis of the category of the patient. We need to predict who else might get the disease in the family, as MODY is a genetic condition and there is a risk of other family members getting the condition too. Then prevention plan can be put in the picture. It helps in proliferating the scientific knowledge about diabetes. So moving on to my talk of today, that is MODY. It is typically characterized by disease which is passed on from one affected parent to another generation, typically presenting in individual less than 25 years of age and with at least one family member diagnosed with non-insulin dependent diabetes. So understanding MODY in a glimpse, it is caused by one of the 6 genes, mutation in one of the 6 genes, which is responsible for insulin production and secretion. And because same genes are expressed in liver and kidneys, you may have coexistent hepatic and renal abnormalities, as we have seen with few cases in the earlier presentation. So this is a picture of pancreatic beta cell with certain genes, that is the glucokinase gene, which is responsible for detection of or glucose sensing. And then we have other transcription factor genes, which are responsible for insulin secretion. So this is a quick differentiation between transcription factor MODY and glucokinase MODY. So glucokinase MODY, as sir has already described, is a self-limiting condition and it is characterized by a minimal postprandial peak with a high fasting glucose. And generally, it is managed by lifestyle intervention without requiring any pharmacotherapy. So I have few cases that I have come across during my practice over last 4 years. So this was a 11-year female, non-obese, asymptomatic, and was detected on routine screening. So actually the parents have applied or got their own workup done from this Lal Pathology Health Checkup, that is package is there. And in that the female was, or the girl was detected to have elevated HbA1c, which was 8.4. So this was a routine health package checkup that they went through. Then they presented to our clinic. We repeated an HbA1c, which came out to be 10.2. Random blood glucose was 89. Fasting was 111. OGTT was 111 and then 313. So clearly there was hyperglycemia in picture. Glucosuria was present. And as we have to get an autoimmunity test done, GAD antibody was done, which was negative. So we have an adolescent female, non-obese, hyperglycemia with autoimmunity negative. So what are we thinking of? Adolescent female, non-obese, type 2 is out. There are no signs of insulin resistance. Type 1 is out, GAD antibody is negative, but hyperglycemia is there. Then we digged into some family history and there was history of 3 generations being positive for diabetes. Then the child was subjected to MODY genetic testing and it turned out to be HNF4 alpha gene mutation, managed on sulfonylurea and lifestyle modification and is currently under control. So we are not routinely, or there are no recommendations for routine HbA1c screening for adolescent patients. But in our routine practice, what we can do at the least is to have a low threshold for those adolescent patients who have a positive family history or a 3-generation history for diabetes. So this was the second case of 14-year male, non-obese, was diagnosed as type 1 at 11 years and was having recurrent hypoglycemia. So this is a very common mistake that we go through. Non-obese patient presenting with hyperglycemia is frequently diagnosed as type 1. The next step will be to start him on insulin. So this patient presented with osmotic symptom at the baseline. HbA1c at diagnosis was 10.6. Ketones were negative. So it was thought that because the patient has presented earlier with osmotic symptom, so may not have landed in ketosis yet. He was started on basal bolus insulin regimen. So till here, everything is going as per our protocol. But what happened 3 months later, he started having recurrent hypoglycemia. So the treating clinician thought the child has entered into honeymoon phase. Quite right, nothing wrong there. And the insulin doses were gradually decreased and ultimately child was put on basal insulin minimal dose, that is 2-unit glargine or 4-unit glargine. But he continued to have fluctuating sugar levels. And at this time point presented to me, he had HbA1c of 7.8. And when we did autoimmunity test, GAD antibody was negative. Again, a family history was inquired into and 2 generations were positive. His own father had diabetes at the age of 24 years and grandfather had diabetes at the age of 32 years. Both managed on oral hypoglycemic agents or oral antidiabetic agents. So in January, this 6 months back, Modi genetic panel was sent, but the diagnosis didn't come out in one of the Modi categories. It was an insulin resistance gene located on exon 6, which was mutated. It was a novel mutation and the report was given as variant of unknown significance. But I started him on metformin and lifestyle modification. For last 5 months, he's on metformin and lifestyle modification. Insulin was completely withheld. And this is his current HbA1c report. So he is on metformin 500 mg bedtime after dinner. So this is the HbA1c report of 5.9. He is well under control. So if we go by the diagnostic algorithm for Modi, I'll just quickly go through this algorithm. Any patient presenting before 25 years of age, neonatal, we all know, patients presenting before 6 months of age, possibility of neonatal is there and they should be managed as per the guideline for neonatal diabetes. If it is an abrupt onset diabetes with ketosis, non-obese, and no signs of insulin deficiency, then you need to subject the child to GAD antibody testing. If it is positive, then type 1. This is a clear-cut picture of type 1 diabetes. But what if the antibody is negative? So non-obese, without ketosis, antibody negative, chances of Modi is there, and the child should be offered genetic testing. Type 2 diabetes, again, obese individual with signs of insulin resistance, negative antibody, classical type 2, not fitting into the classical picture of type 2, think of Modi and proceed accordingly. So these are the common variations or categories of Modis. We have HNF1 alpha, 4 alpha, 1 beta. These are the common subtypes. Glucokinase, high fasting with minimal peak. In the postprandial, think of glucokinase managed by lifestyle modification alone, no pharmacotherapy needed. So just to take from my talk, it can be similar to type 2 diabetes presenting with mild or no symptoms, as in the second case, just with mild osmotic symptoms. Can have normal C-peptide, which is not there in type 1 diabetes, negative autoantibodies, managed with diet, sulfonylurea, plus minus insulin in the initial phase of hyperglycemia. Against type 2 diabetes, it may be early in onset, absence of obesity and overweight, and no signs of insulin resistance. Similarity to type 1 is early onset, non-obese, no signs of insulin resistance. And against type 1 usually present with severe symptoms, but it may have mild or no symptoms. And evidence of endogenous insulin production is there in Modi with normal random C-peptide level. Thank you. Any questions?
Please, over to the chairpersons. Yeah.
Excellent, Dr. Neha. Very simplified way you have explained when to suspect, when not to suspect. That's excellent. But
thank you, sir.
How often we come to see these type of patients in normal population where we have to suspect Modi, and how to get all these genetic testing done in routine?
So these symptoms will be presenting with mild symptoms of diabetes. So they can have mild osmotic symptoms. They can present with mild failure to thrive. They can present with infections not getting treated with normal antibiotics, non-treatable UTI or any skin infection. So these patients should be checked for hyperglycemia. And if they are not fitting phenotypically into either type 2 or type 1 with a positive family history, then a suspicion for Modi should be kept and genetic testing should be offered.
So epidemiological data from the West will suggest somewhere around 2 to 5% of quote unquote type 2. Even in adults also are Modi. In type 1, it will be like 5 to 7%. So if you really do a good genetic analysis, so many patients even thinking they are type 2, they turn out to be Modi. Now, genetic testing is very easily available these days. So you can get the targeted panel which is there, and that is something which really has helped us a lot in terms of making the diagnosis, because then treatment changes, complication changes, everything changes from there.
Yes.
Yeah.
Is there any specific advantage of getting the panel over just getting a clinical exome? Is the cost the same?
Theoretically, if you're looking at lesser number of genes, you're looking at greater depth. So if you look at the whole genome sequencing, whole exome sequencing, and then targeted panel, the depth that you get, so likelihood of missing, so your sensitivity will go up in that regards. While if you're looking at a bigger panel, they will not go to all the areas. There will be some areas in which the depth will be less than few X's. If you read, the results are given that way. So targeted, so as we discussed in the genetics session, if you think of one gene disorder, do that gene. If you know that this mutation is common, do that mutation. If you have 10 to 20 genes, go for a panel. If you don't know, you can go for exome. If nothing comes out, then go for genome. So the broader you're going away from, your searchlight is going away, you might miss on a few things there. So better is to do the precise thing, will be better in that. So thank you, Neha, for wonderful talk.
Our next speaker, none other than Dr. Rishi.
I'll request Dr. Dhwani to hand over the memento to Dr. Neha.
जो लखनऊ वाला वो तो रीजनल this आगे उससे once again, good evening, friends, and thank you, chairpersons, for good word. My elder brother and my younger brother, two are sitting together, so I'm truly blessed. And again, thanks to Dr. Anurag for inviting me. And the second help, he provided me the material also to speak. So I took some material. So I'll be talking about type 2 diabetes. And if you look here, the type 1 diabetes is also increasing over the decades, and same is type 2. So there are many reasons for type 2. I think we know the reasons. But if you look at, yes. If you look at these orange bars, the type 2, this is the Asian patient. The type 2 is also increasing in Asian patients. And type 1, and there was I think we had, Saurabh has talked very nicely about type 1. And there was a very interesting report on type 1 that the prevalence of type 1 has increased over the, if you've read that paper. And that was interesting for the reason that the survival has increased of type 1. So this was a very positive report in terms of type 1. So more and more people are being diagnosed. So we are doing probably a better job. And when I started in endocrinology 30 years back, there used to be only 3 types of diabetes: type 1, type 2, MODY, and other was gestational diabetes. So 4 you can call. Now a lot has happened in terms of advancement. And what are the management studies? The lifestyle manifestations. The lifestyle is actually very, very important, because weight loss is a truly challenge for everyone. And especially if the type 2 child comes, and if you look at the entire family and they try to put restriction on the child itself. If the child is being put restriction, you can imagine what is going to happen. Nothing is going to happen. And then many people, they are parents and grandparents. And I think the number of restaurants over the years, I mean, all of you are aware how much advancement has taken in number of restaurants. Earlier, now you're sitting here and eating a food. You go there and out and eating a food. Now we are keeping restaurant into our pocket. So everybody is having restaurants in the pocket. So you can imagine. So diet management is very, very important. But I think one thing is there. Where are we missing in diet? We know eat this. But where are we missing? I just want to ask a question from all of you. Where are we missing in that management, because it is the cornerstone of management of any type of diabetes. And it is much more important, especially for type 2 diabetes. What I understand where we are missing in managing diabetes is that management is we are very judgmental about our patients' population, and what we simply tell them do's and don'ts, eat this and don't eat that. But did we ever interrogate to our patients that earlier you've been eating this, now you should eat this, and do you feel that you were at the fault? And when patient realizes that I am at the fault, probably that would be the time patient would be ready to adhere. Otherwise, the attraction and addiction of food is perhaps the worst addiction. You can talk of number of addiction from so many things, inclusive of abuses and all, but the worst addiction is of food. The physical exercise, there are lot many exercises, but I would suggest two things. One is go for any physical exercise, number one, and then you sit with them, and in the limited amount of time, what best can be done to burn maximum amount of calories. And second thing is, since they handle with the younger age of people, so the exercise should have some entertainment also. Simply running and jogging will not help. If you encourage a child to play some game, probably this is going to be a bigger way. Because again, the modifications and understanding, see, we don't create a space. Whatever we do in terms of lifestyle, what happens? We simply tell. And because all of you are sitting here, why have you come here for last 5 days? Can you tell me the reason? Because you created a space in your mind that having spent 2 days or 5 days here would give you something good. Am I right? So the lifestyle is easier said than done. And why? Because we don't create a space into our patients. It doesn't enter into the patient's mind that this is important. My grandfather has been eating the same, my father has been eating the same, and food is such an addictive thing. I mean, all of you would agree, while eating a good food, you feel happy or happier. Everybody feels good. Everybody feels good. Ah, I was listening to interview of David Dhawan. का मेरे को जब चाउमीन खाना तो मैं खा ही लेता हूँ, मेरे घर वाले चाहे डेविड धवन इफ यू ही का मैं खा लेता हूँ, फिर मैं खा ही लेता हूँ. So, but this is one example, celebrity, but all of us are like that. But why we are not able to create the discipline many people are able to do? And the simple reason is we are not able to create the space. Coming to the therapeutic options, starting from insulin. If the patient is symptomatic, we have to give insulin, or if A1C is more than 5. The second option is metformin, which is a very vital and useful molecule. The GLP-1 receptor agonists are, again, we will be discussing one by one. SGLT2 inhibitors. I think I'm a great fan of SGLT2 inhibitor because we have been talking from whenever they come, a lot of questions have been into my mind. And because I always ask everybody a question, up to what renal impairment SGLT2 inhibitors can be given. We don't talk about type 2 diabetes, but time ho to nahi raha hai. So SGLT2 inhibitors, whenever we talk of the question that came in my mind, why can't we give SGLT2 inhibitors in a failed kidney, not in failing kidney? And nobody answered. So everybody said that there is a spike that worsens, and somebody said that it is not recommended, not at all in recommendations. But I think 2 months back, probably you were there or not, Dr. R.K. Sharma is a professor, head of the department of nephrology. He said you can give it at any level. So SGLT2 are a very, very useful salt and much useful in the adolescent. Glucosidase emitters, I'll be discussing. A word about metformin. It is MAP kinase. Basically, it reduces the resistance, reduces hepatic glucose production, and increase insulin sensitivity. We start with the smaller doses, and it is better to use a sustained release because these GI side effects are less, and then gradually increase to tolerate. Some people are intolerant, but majority of people are able to tolerate if you start, because not only with 500, I started even with 250, and 250 tablet is also available. And the data says around 25% of patients B12 deficiency is also seen. So it would be advisable to add vitamins, especially B12. Avoid using this in very low EGFR. If there is any hepatic problem, mitochondrial cirrhosis, Dr. Anurag already mentioned, and in sick day, and especially if there is a very strong anorexia. I still remember a patient, BMI 16, adult patient, and tuberculosis, and advised metformin 1 gram twice a day. So you can imagine about the patient. Patient will not die of tuberculosis or diabetes, will die of metformin. This was a long, I think 2012, a trial where metformin was tried in a young people, and it was found to be effective. Monotherapy with metformin was associated with durable glycemic control in approximately half of children and adolescents with type 2 diabetes. The addition of rosiglitazone, because that was the time rosiglitazone was available in the market, now it is no longer being used. So it is a useful sort, but again, the interesting data at that point of time, half of the patient, it was not effective or fully effective in all the patients. Insulin again is a, we can use variably. We have glargine insulin, we have U300, 20 insulin, we have degludec insulin, and some of the institutes I was talking to Dr. Mahesh, they are using NPH insulin also. So we can use any of long or intermediate acting insulin. Incretins are actually useful. And a very interesting historical fact about incretin was what they do, they're secreted from the L cells of intestine, and then they suppress the hypothalamus and reduce the satiety, and then also stimulate the pancreas to increase insulin and reduce the glucagon. So it has multifold effect, and endogenous GLP versus exogenous. So endogenous GLP does not have as much effect at the level of satiety, but exogenous has a very significant effect at the level of satiety. And you have to be very clear that those who are not able to tolerate, I remember I've been trying a patient to write GLP-1, BMI 45, and whenever I write GLP, he said, I have something, but a subset. So you have to be very clear that a subset of patient will be very, very symptomatic about GLP. That is very important. Then another thing is the DPP-4. If you go historically, exenatide was the first GLP molecule that came into the practice long back. And the beautiful part at that time was that we understood what is the GLP molecule and what happens to this. And then we very nicely understood how DPP-4 inhibitors work. And what these GLP molecules do, they take care of satiety, reduce gastric emptying, incretin effect, glucagon inhibition. And liraglutide is the approved GLP-1 up to beyond 12 years and above. And what is important is that start with 0.6 milligram daily, build up to 1.8, and a clinical tip I would like to give. Suppose you started with 0.6 milligram of liraglutide in a patient, and patient is not tolerating even 0.6. Make it 0.3. Make it even, because there are clicks in the pen. So 10 click is equivalent to 0.6. So you can make 5 clicks, or you can make even lesser, and moment patient starts tolerating, then you gradually increase. Weight loss, GI side effects. A subset of patients have no side effects. We have actually two molecules that are approved, dulaglutide and exenatide. And third molecule, oral GLP-1 semaglutide, is available, but it is not as yet recommended below 18 years. But look at the contradiction. The semaglutide injectable is recommended to use 12 years and above as a weight reducing agent, but not as a oral is recommended as a anti-diabetic. So avoid this pancreatitis and medullary carcinoma thyroid. Please ask if there is any history, because I still remember I wrote semaglutide to one adult patient, and the patient called back, "Sir, my grandmother had cancer thyroid, so I will not take." So this was a trial on liraglutide in children, and it was effective in reducing a significant HbA1c and a weight reduction. And dose was up to the 1.8. It is up to you how much dose titration can you do. Dulaglutide is also interesting molecule, once a week, and it is up to 0.8, 0.9 HbA1c. And but you have to titrate, start with 0.75 and then gradually build up. Semaglutide is a, I think, off-label we can use. I don't know, I'll not say, but off-label you can use, because I always ask a question, same question that I've been asking about SGL2. If I give SGLT2 to failing kidney, what will happen? And 2-3 people said nothing will happen, it will be beneficial. So something similar is, I'm asking, if we give GLP-1 to a 14 years, 15 years, 16-year-old adolescent, what will happen? Probably nothing, probably off-label I'm talking, but because many patients are not acceptable to injectable therapy at this age group. And if you give semaglutide, then they will be happier. And the best part with semaglutide is this is very intense molecule, and of the three, liraglutide, dulaglutide, this is the most effective molecule. But the GI side effects are also much more. That is another thing to be kept in mind. And one thing I've also understood over the decades, that if you start as GLP-1 earlier in type 2 diabetes, the beta cell preservation stays very long, because the basic dictum of, we have been learning about diabetology. The basic understanding is younger is the molecule, they lose their beta cell reserve faster. This is the basic understanding of any type of diabetes, bearing some syndromes or moody. Coming to SGLT2 inhibitor, all of know this simply gives glycosuria, and glycosuria per se gives a lot many things. It gives a weight reduction, fat reduction, cardiac benefits, liver benefits. NASH also, it has been useful. The renal protective power. And if you use them earlier, probably we have done so 3 molecules are there, EMPA, CANA, and dapagliflozin. EMPA is perhaps the best molecule, and it is to be avoided in UTI, insulinopenia. If there is any chances of type 1, please don't give, because then diabetic ketoacidosis gets precipitated. And that's why SGLT2 inhibitor was earlier recommended by European Society for type 1 diabetes, and later on this ban was taken up because they've seen more frequent episodes of diabetic ketoacidosis. Still, I feel if you write to type 1 diabetic, those who are controlled doing well, they will have long-term protection, provided they are aware enough to take care of their ketotic status. So dapagliflozin was relatively lesser effective. The empagliflozin was a significant. This is a trial where EMPA versus placebo, and this is Lina versus placebo. So linagliptin was as such not effective. So FDA approved empagliflozin and DPP-4 inhibitor. What I can say, there are one trial this have shown, there are trial with sitagliptin also. For adults, they are a very good molecule, used earlier, and they have worked wonderfully. If you use in late 30s or 40s, they do extremely well. And I think sometimes I say that you should always use with metformin. People say that metformin is the first line, then I say you can use DPP-4 with metformin. They are so nice, but in younger population, they are ineffective. So we should avoid using DPP-4. Then 3 molecules I will also name. This sulfonylurea. Some societies have also recommended the name of sulfonylurea. They work to begin with, but what has been observed that if you use sulfonylurea, the type 2 adolescent lose beta cell faster. Alpha glucosidase inhibitors, they work locally. So in a milder reduction of HbA1c, probably they are of a use. Third molecule is of my brainchild, amiglin. Amiglin are probably theoretically a very nice thing, but as such, we don't have a trial. Because they not only work like metformin, but they have a little bit action like a secretagogue. They also increase a bit of insulin secretion. And so I don't know. So finally, the approach. And if you look at that, my friend is also there. Preeti is part of this recommendation. This is SPAT. So if the A1C is less than 8.5, more than 8.5, or if the patient is symptomatic. If the patient is symptomatic, ketosis is there, you need to use insulin to settle down the patient. A1C less than 8.5, healthy lifestyle, then metformin and gradually titrated doses. And more than 8.5, metformin and basal insulin. Wait for a month, you'll have time to work up and then see what happens. First month, if there are islet anti-positive, positive or negative. If the islet anti-positive are negative, yes, then continue metformin. And if not responding, add GLP-1 and it is confirmed type 2. If there is a islet cell antibody is positive, take it as a type 1 diabetes. Subsequent therapies, of late, if the patient are not responding very well to metformin or lifestyle, those who respond, at least I think Dr. Anrak's paper was there, if I remember. If you take type 2 diabetes, those who lost weight in first year, the beta cell function remains very nice in first year. So we should encourage very intensively about lifestyle. But those who are not doing well, we should think in terms of adding GLP-1. We should think in terms of adding insulin. So this is a very simplified approach. As the presentation, if the patient is symptomatic, treat like this. A1C 8.5 or less than 8.5. Less than 8.5, start with insulin. If insulin is not working, add GLP-1. If the symptomatic, add insulin. And if more than 8.5, probably you need more than one molecule. This is sure, and then it is up to you. But again, in any type 2 diabetes, if you use GLP receptor agonist earlier, you can retain beta cell for a much longer period. This was an interesting paper by Dr. Anrak's group. Fortunately, I was also part of this. And we looked at the determinants of course of type 2 diabetes in adolescent, and what was observed that a subgroup responded nicely to metformin 1. And second thing, those who did not respond very nicely, they needed multiple oral hypoglycemic agents or blood sugar lowering agents. They did not do that well. And subset also had a remission, those who stick to lifestyle. And the findings suggest that majority of people have delayed because average A1C in our study was around 10. And so we assume that they present very late because there is hardly any screening. And if you look at the total patient, and 50% presented because of symptoms and 50% just the incidental detection, they came for workup for obesity and it was detected. What should be the glycemic goal? Less than 6.5 for majority, less than 7 optimum. And I think if the patients are motivated nicely, they should be kept less than 6.5 because and one thing I would like to share, we have been talking about type 1. Type 2 is worse than type 1 because it opens the door to all macrovascular accidents much earlier compared to type 1. Then psychological factors are also very important. And I think I'll not be going to detail, but if you look at center part, we look at the depressive symptom, diabetes, distress, behavior. We should talk what you feel about diabetes. I think that will go a big way. And to conclude, diagnosis of type 2 DM in adolescent is delayed overall in the country compared to West part. Needs very aggressive management from day one, beginning with lifestyle and effective molecules. You should write GLP-1 and metformin as early as possible. Metabolic syndrome in children is a serious routine because it starts from there. So all of us are responsible. We need sensitization of pediatricians, pediatric endocrinologists, physicians, and family physicians, I think, an entire society. I think, thank you so much. And everybody should do some exercises. Thank you so much.
Thank you, Dr. Rishi, for your excellent talk. But most probably one thing we are missing in your talk. At what age we start the screening for normal population to diagnose type 2 diabetes or diabetes in young population? Because now we are getting type 2 even in a very young population, 11 years, 10 years, 20, 12 years. Why don't we have some guidelines about the screening of the people or young population and what it should be?
I think a very nice question. I did not address because my topic was management, not the preventive part. So any patient getting overweight, we should do blood sugar at the earliest. And especially if you talk of in terms of diabetes, pubertal or peripubertal age group, that age group makes them more prone because there are hormonal imbalances and all these hormones give insulin resistance, all these steroid hormones give insulin resistance. So as early as possible, moment patient starts getting.
So 10 year and above is the
10 years.
recommendation, basically based on puberty, as Dr. Rishi said.
Yeah.
So 10 year and above, definitely. And you need to do both fasting and 2-hour value.
2-hour value.
And HbA1c is not at all good in this age group as a screening strategy.
And one more thing, if you talk about the management part, yeah, probably you don't have covered the glitazones because we are talking more and more about the obesity in a young diabetic people. So it might be the reason that you haven't touched the glitazone part. But still, if you have a normal weight type 2 diabetic young, then what your views about the glitazones?
Actually, glitazones are not as yet recommended below 18 years. I mean, we have 4 molecules, the metformin, GLP-1 receptor, SGLT2, and insulin.
Actually, yeah.
Not with sulfonylurea I mentioned because in some global societies they have been recommended. AGI is plus minus concept based and imiglamin was my thought process. That's why I did not mention because there was trial on rosiglitazone that also did not do so well. So we don't advise below 18 years.
And even the DPP4 is not also recommended below 18 years.
No.
But that question is there. Why the GLP-1 is recommended and DPP4 is not recommended?
No reason. I think answer is very clear. Because GLP-1, what it does, it simply increases a bit of GLP-1 level. But if you give exogenous GLP, such a huge difference. Yes, and that has a that has effect at the level of hypothalamus. That has effect and it reduces satiety. That has effect at the level of GI system. So entire GI system starts speaking, which is not seen with DPP-4. Probably that is the reason.
And DPP-4, as Dr. Rishi said, has not been proven to be any effective. 0.2, 0.3%.
Sitagliptin, not at all effective. And
Linagliptin, both have been trials have shown they're not at all effective.
Not.
Thank you, Dr. Rishi. Thank you. बजा दो भाई कसके benefit.
Yet another very interesting and very untouched topic about the diabetes is a hyperinsulinism, and the speaker is Dr. Hemchand.
So Dr. Hemchand is a well-known pediatric endocrinologist from Chennai, and he has been coming to our programs now for over a decade. He is one of the most constant person here. So welcome, Hemchand.
Thank you.
Thank you.
I'm starting off with a timer on my side as well. So I think if you see hyperinsulinism, I personally think it's the toughest case for a pediatric endocrinologist. And if you see recent literature, the amount of data that has emerged on care, the diagnostics of hyperinsulinism, I really think it's a volcano in itself. There is an explosion of available literature in this regard. So I think when I saw the profile of all the attendees, all of you are working in such prestigious institutions. I think your knowledge about hyperinsulinism will be a big power to the care of difficult cases that are going to be referred to you and give them optimal care. The purpose of the next 20 minutes is not to talk about what is hyperinsulinism, how to evaluate. I think you all know that and you have read it and you can find it in any standard textbook. What is relevant and new in the past 3 or 4 years pertaining to diagnosis, management, evaluation, and monitoring will be the focus of the next 20 minutes. So these are 4 cases I thought who require a genetic test or do not require a genetic test. So how do we tackle this? We'll go through them one by one. See, basics of genetic testing. I think genetic testing has revolutionized the identification of underlying cause of hyperinsulinism. And there is a recent consensus which has been published in 2024, which has given a very beautiful overview of how genetic testing has to be performed. And it has given very, very clear answers. The only indication to do genetic testing, number 1, is diazoxide unresponsiveness, which is the commonest problem which we encounter. Number 2, diazoxide requirement beyond 3 months of life. Whenever you see a baby with transient hyperinsulinism, genetic testing may be deferred unless there is a history of MODY in the family. And what is the yield of genetic testing? Overall, it is said to be around 50 to 75%. And in diazoxide unresponsive states, it's about 90%. I think that's a very important thing. Genetic testing will give you an answer in most of the cases. And a new technology that is emerging, optimal gene mapping, may be the thing of the future. General dictum, whenever you have a recessive and an inactivative mutation, it's going to be a severe disease and a diazoxide unresponsive disease. Whenever you see a diffuse and a dominant disease with activative mutation, it's going to be diazoxide responsive and a mild disease. So this is what the test says. You have a cafeteria of tests that are available. Number 1, a rapid diagnostic test to pick up mutations in the pathogenic factors, biallelic mutations, which are paternally inherited and likely to be focal. You have tests which identify mutations which are biallelic, which are going to be diffuse. You have tests which are going to identify syndromic causes like Beckwith-Wiedemann syndrome, and you have tests which help you identify deletions and duplications. So I think a cafeteria of tests are available, and a proper choice of test is very important to make a diagnosis in the right clinical situation. So this is what the consensus statement says. Whenever you have a diazoxide unresponsive child who requires a lot of glucose, lot of glucagon, go in for a rapid diagnostic test. I think that is the point number 1. Do a rapid diagnostic test, identify a focal disease early, and refer it to the surgeon at once. I think that would be the approach in a very, very tough, difficult case. If you have a difficult case, which is being managed medically, I think the NGS-based technology to look at the targeted genes with Sanger confirmation, with or without copy number variant, would be the approach. Whenever you have a child with phenotypic features of Beckwith-Wiedemann syndrome or syndromic features, you go in for a methylation study. And whenever you have a child with persistent hyperinsulinemia and the testing is not yielding a result, you go in for a deletion duplication analysis by either an MLPA or a chromosomal microarray. So why do we do a genetic test in a diazoxide responsive form of the disease? Anyway, it's not going to change your management. It's very important because it helps you to avoid triggers. With the list of disease genes that are implicated in hyperinsulinism, you can avoid protein-rich diet, exercise, etc. And it helps you identify comorbid diseases in certain conditions, like in CDG disorders, you can identify protein-losing enteropathy and to predict the risk in the future. I think this is a very, very important thing on the choice of genetic test. Whenever you have a hyperinsulinism, which is early onset with syndromic features, you go in for methylation study. If it is diazoxide responsive, no genetic test unless if it is persistent beyond 3 months or there is a family history of MODY. So if this diazoxide unresponsive and a very aggressive disease, go in for rapid diagnostic test. When it is a difficult case, go in for an NGS with copy number variant testing. If it is negative, go in for a MLPA and a chromosomal microarray. When you have a late onset disease, there is a diagnostic possibility of an insulinoma. A MEN gene test has to be thought of. And if there is no insulinoma, again, it may be a late presentation of a genetic cause and you need to go in for an NGS-based targeted gene panel or a whole exome sequencing. Now, using this, let us just apply. You have a 2-month-old child with high requirement of diazoxide, high requirement of octreotide, high requirement of GIR, and intermittent glucagon. You are looking at a losing battle. What test will you order? Rapid diagnostic test. You have a 3.5-month on diazoxide, octreotide, on NG tube feeds, has glycemia, low glucose episodes on and off. Growth and development are acceptable. What test will you order? NGS. Very good. You'll go in for a targeted gene testing. A 4-month-old child, persistent requirement of diazoxide since day well, responding well. Should a genetic test be performed? 4 months. So it's persisting beyond 3 months. Would you do? Yes, probably it has to be planned. And you look at the 2-month-old child with a very low requirement of diazoxide, 3 mg per kg. Would you do a genetic test? Very good. And you look at that baby with hyperinsulinism and strong phenotypic features of Beckwith-Wiedemann syndrome. An ultrasound showing renomegaly. You're looking at a child with some asymmetry. What test would you do? Excellent. I think that is very important. The cafeteria and the right item has to be checked. So this is a 3.5-month-old child on diazoxide and octreotide, has hypoglycemia on and off, and the genetic test is pointing towards a focal lesion. What would you do at this point of time? I think this is where the concept of scintigraphy emerges. Scintigraphy, when would you do a scintigraphy and when would you not do a scintigraphy? I think that is very important. Whenever you look at a monoallelic variant in the potassium ATP gene, more so if it is recessive and paternally inherited, you have a high likelihood, high pretest probability of finding a focal lesion. This would be one step, immediately consult the nuclear physician. Or an inconclusive genetic test. You don't know whether it is focal, you don't know whether it is diffuse. Look for an alternative source in terms of scintigraphy. But when you have an autosomal dominant pattern, when you have a genetic disease pointing towards a diffuse disease, a diazoxide responsive state, diffuse, I think you will have to individualize and kind of defer this process. The guidelines are going more towards genetic testing and more against scintigraphy in the 2024 guidelines. So these are the various dyes that are available: L18F DOPA PET, gallium scan, DOTATAC, DOTANOC, and DOTATATE scans, and exentin scans. So these are the new available molecules which look at specific targets in the pancreas and are focally taken up by the pancreas and taken up and help you distinguish whether this is a focal lesion or this is a diffuse lesion. The sensitivity and specificity, all of them are depicted in this slide. And what you really see is the DOPA PET remains the gold standard, but the other two are emerging closer and are more easily available. So I think when nothing is the gold standard is not there, these may be emerging options. But remember, all the sensitivity and specificity has arrived on very small sample sizes, 20, 30, not more than 50. So I think when something is better than nothing, you definitely will have to do. And always remember fallacies in testing. every dye is concentrated not only in the pancreas, but other sites as well. So if you see FDOPA PET, you have false positive accumulation in different parts of the kidney. Gallium scans, you have accumulation, I think, in the spleen, and the exendin has uptake in the pelvic parts of the kidney. So the other false positive causes should also be borne in mind. And remember, it is operator dependent. Some practical aspects: it helps you distinguish between a focal and a diffuse disease. And whenever you're doing a scan, it is recommended that you keep the child off medications, that is glucagon, octreotide, so that you really help the scintigraphy give you an answer. If you're giving a drug that is suppressing the pancreas and you do the scan, you might not get the answer whether it is focal or diffuse. So you keep the child off medication, fast the child, keep the child on just IV dextrose, and it is an operator-dependent procedure. Most of the recommendations are in favor of going in for a general anesthesia. So you really are able to identify a focal lesion that can pick up dye uptake, and the rest of the pancreas which does not pick up a dye uptake. So this is a summary of when you would really go in for a scintigraphy. Whenever it's diazoxide responsive, there is no role. Unresponsive, and the genetics giving a strong possibility of focal, or the mutation is negative, go in for scintigraphy. I would really like you to focus on this slide and look at this slide on genetic testing. You would find a cafeteria, the push towards genetic seen on all the red boxes. And you see the very gentle approach of just one box pushing you towards scintigraphy. Why? Because focal, what recent understanding of the disease tells us is focal can remit. Focal disease can be medically responsive, and interpretation is extremely challenging. So the world is moving towards genetic testing and moving away from scintigraphy. I think that is an important development in 2024. A 2.5-year-old child presents with hyperinsulinism. Is it different from a younger child? Yes, it is different. What are the important things you would rule out is, of course, a delayed diagnosis of hyperinsulinemia, monogenic disorders, and insulinoma has to be thought of in these group of children, especially who present with hyperinsulinemia after the age of 2 years. This is one of our own patients who had insulinoma presenting as recurrent hypoglycemia. There is a lot of data from the Western world looking at pediatric insulinoma. And what is really interesting is many of them are diazoxide responsive. Many of them behaved like just a late presentation of hyperinsulinism. The only test which gives you a clue is imaging, either an endoscopic ultrasound, or you're looking at a child with an MRI. That only helps you. And what is really important, it's a big group of them are men positive as well. So you not only identify an insulinoma, you identify the other diseases associated with men in this child. And these reports are described asymptomatic siblings and family members of children who also have features of men. So one hypoglycemia picks up men in the whole system. So I think whenever you see an older child with hypoglycemia, always remember a possibility of insulinoma. This is another important development in 2024. An SGA baby with hypoglycemia, you are looking at a possibility of hyperinsulinemia. What would be the management strategies different from a child with a term baby with hyperinsulinemia? I think, remember, there is a consensus statement on usage of diazoxide published in JCM, which has given very clear guidelines for practitioners on use of hyperinsulinemia, use of diazoxide for hyperinsulinemia. You start off with the standard dose of 5 mg per kg. A lower dose is recommended in babies who are born SGA because they are going to be highly sensitive. You can go up to 15 mg per kg, and if there is no response for 5 days, you label it as diazoxide unresponsive. Response is gauged by getting off IV fluids and tolerance of fast. You can take up to 3 to 5 days for onset of action. Always a baseline echo, uric acid, and CBC should be done at 0, 7, and 3 months. Lower doses for SGA perinatal stress and those with cardiomyopathy. And you know that hydrochlorothiazide has to be added. And side effects, all of us are very well aware of. And efficacy and safety. Whenever you see that when you prolonged fasting of the infant is done, within the stipulated time. You have appearance of ketones before the occurrence of hypoglycemia. You know that this child is coming out of the problem. And transient causes, withdraw the drug once the sugars start increasing above the target. So this is a 4-month-old child diagnosed as hyperinsulinemia, developed pulmonary hypertension with diazoxide on octreotide in 3 divided doses, unable to wean off. Parents are not able to administer injections. What would be the next step? You're looking at a difficult disease which is not responding to diazoxide, responding to octreotide, but practical challenges in giving octreotide injections. What would be the option for you in 2024? The important option is given here, the option C, long-acting octreotide. Long-acting octreotide is a very wonderful drug that is available, which is available in various strengths. Very simple guidelines are endorsed in the 2024 guidelines. Calculate the total dose of octreotide for 1 month and give it as a single shot of a monthly dose of octreotide. Suppose this baby is on 100 microgram daily of octreotide. Calculate 100 into 30. Convert it into an equivalent of milligram and give it as a shot, and slowly withdraw the daily dose of octreotide after a period of 2 to 3 months. Remember, this can be started only after the neonatal period. There are references for starting it after 3 to 6 months and after 2 years because of the risk of NNEC. Always, octreotide not only suppresses your pancreas, it can suppress the thyroid and the growth as well. Monitor the thyroid functions and growth, and watch for other side effects as well. There is 2 important Indian studies who have looked into the utility of long-acting octreotide, and very wonderful results. The study from All India Institute has described that the youngest age where they used long-acting octreotide was 3 months. The median age was 6 months. And by 3 months, they were able to stop the daily octreotide injections and no major side effects. And the study from Mumbai described 8 children who were given on long-acting octreotide, and even the diazoxide responsive ones preferred long-acting octreotide because of the high cost of diazoxide. Good clinical efficiency and good cost effectivity. And the studies have described effectiveness. There should be no severe hypoglycemia, and more than 90% of the sugars must be in target. I think 2 important criteria. Presence of 1 episode of severe hypoglycemia also puts the efficacy of the medication as a question mark. This is a 2-month-old infant currently on diazoxide octreotide. You are unable to wean off IV fluids, needing intermittent glucagon rescue. The genetic test is identifying a missense mutation of ABCC8. So you're moving towards a condition which has a diffuse disease. So you're looking at a diffuse disease, a genetic disease incriminated as a cause for hyperinsulinemia. Definitely, this child may be a candidate for a near total pancreatectomy, but always remember the physician's option of giving sirolimus. Sirolimus can be given in a difficult hyperinsulinemia case, and it acts as an mTOR inhibitor. It reduces the beta cell proliferation. It is available as 1 mg tablets, and the cafeteria of side effects are there for you to watch and monitor this child for hepatitis, infections, pneumonia, dyslipidemia, diarrhea, immunosuppression, fluid overload, angioedema, etc. I think there is a cafeteria of side effects that are there, and these are some of the practical aspects useful in diffuse disease. The starting dose is 0.5 to 1 mg per meter squared. How high you can go? There is no clear answer. People from our country have used up to a dose of 4.8 milligram per meter squared in CMC Vellore. So 4.8 milligram per meter squared would be a stiff dose for an infant. And it can be attempted even after pancreatectomy. And long-term safety has been reported up to the age of 5 years. But you have to use it very carefully. Always require a PICU and a hematology backup. The current guidelines say it's an experimental drug. You would have to have an IEC approval before going in for this. And this is a very beautiful slide which looks at the Indian experience with sirolimus. And if you see, whatever I could lay my hands on, almost 16 infants have been treated with sirolimus, and it's very varied. The study from Hyderabad has described that 5 of them outgrew the problem. whereas the study from North India described that out of the 7 cases, 6 of cases who received it, 5 cases, the medication was stopped because of side effects. So I think we cannot draw a conclusion about its efficacy based on 16 cases. But yes, this is an important therapeutic option that is available. You have to monitor the sirolimus levels. Monitoring can be done. The lab testing is available. And very interestingly, it has been attempted even in focal diseases with a good response. So I think you have to keep this in mind as a therapeutic option. This is a 3-month-old infant, mutation negative, contemplating surgery. You're thinking, but you don't know what to do. Any rescue medicine that can be offered? Yes, glucagon is offered as a rescue medicine in the awaiting surgery period, perioperative period. And you start off with at 5 microgram per kg per hour, and you titrate it up or down up to 30 microgram per kg per hour. It's just a strategy to buy time. This is available and published and approved for this indication. The average dose is reported to be 12 microgram per kg per hour. And very importantly, the side effects, thrombocytopenia, diarrhea, and the very famous side effect of necrolytic migratory erythema. This is a child with difficult hyperinsulinemia considering surgical options. As a physician, what is it that we are going to contribute? I think pre-operatively, we always have to remember to stop the diazoxide a week prior. IV fluids, glucagon rescue, octreotide rescue. Cardiac clearance is mandatory. And the importance of the planned operative procedure, whether based on the focal or diffuse nature, biopsy the margins, biopsy the entire pancreas, even in a focal disease. And in the post-operative period, the onset of hyperglycemia with ketosis would warrant IV insulin. Hyperglycemia with oral feeds would warrant subcutaneous insulin. And if the child develops hypoglycemia, continue the medications. The second last case, this is a child with hyperinsulinemia. Parents are bored of testing sugars. What is there an alternative strategy? CGM. I think CGM is emerging as a game changer as far as monitoring of sugars and hyperinsulinemia is concerned. This is an array of studies who have looked into the utility of continuous glucose monitoring as a monitoring tool in hyperinsulinemia. What is really interesting to see is there is a very good relative difference versus a glucometer reading. So you really have the accuracy is quite questionable in the use of CGM in hyperinsulinemia. And what most of the studies are telling is the sensitivity is poor, the specificity is very good. You cannot really make a big conclusion about hypoglycemia based on a CGM reading, but normoglycemia is reassuring. So when you see a low sugar on a CGM in a PHHI child, probably you have to cross-check it with the glucometer and then take an action, but it helps you reduce the number of pricks. The problem with CGM is most of them have been done on Dexcom as a tool. Dexcom is currently not available for use in such young infants in our country, but probably in the days to come, it's going to be available. So it may result in undue anxiety, compression artifacts. Manual insertion is recommended over automated insertion. And all of us are aware of the lag between the interstitial glucose and the plasma glucose. And there is no link between an adverse glycemic profile on a CGM and a long-term neurodevelopmental outcome. So really, you have to take it with a pinch of salt. But probably if there is another session on glucose metabolism in 2029, this may be the game changer at that point of time. And this is the last case. What is it that we have to expect in the future? Optimal genomic mapping. It's a more advanced technology which is available in certain labs as a research module, and it will help you improve the yield in children with hyperinsulinism. That is the anticipation. And an array of newer drugs, GLP antagonists, glucagon pumps, antibodies to insulin receptor. You have selective SST5 receptor agonist, which has an impact on insulin secretion. Pasriotide, ketogenic diet to improve the epilepsy profile in hyper. So these are the case reports that have been described, not routinely recommended by the experts, but these are the tools that probably which will emerge as the new breakthroughs in the days to come. So to sum up, what is new and what to anticipate in the near future in terms of evaluation, I think individualize and rationalize the need for genetic testing. The choice and timing of the test is dependent on the clinical situation. There's no blanket choice of genetic testing. An individualized clinician discretion-based genetic testing is warranted with input from the geneticist. The timing, choice, and the test is decided by the course of the disease. I repeat, the timing, choice of the test is decided by the course of the disease and the clinical situation. Judicious use of scintigraphy. It's operator dependent, mainly helps you to rule out focal lesions. Newer agents are available with different targets with less radiation exposure and improved sensitivity. As far as management is concerned, long-acting octreotide is a wonder drug in our hand. Use it extensively. Sirolimus is a nuclear bomb in your hand. Use it judiciously. Medical management is overshadowing surgery, even in diazoxide unresponsive cases. CGM will help us rule out rather than rule in hypoglycemia in persistent hyperinsulinemic hypoglycemia. See, optimal genomic mapping, newer therapeutic agents, and newer CGM tools, which are FDA approved for use in infants, may be the breakthroughs to anticipate in the upcoming years. Thank you very much.
So I think it was a wonderful talk, and you really covered a lot of topics and so many new things happening in hyperinsulinism. I think this is what we expect from Hemchand to really summarize the entire literature in a nutshell within 20 minutes. Thanks a lot, Hemchand. With that, we come to the end of this session, and I'll request Dr. Dhwani to kindly give a memento to Dr. Hemchand. I'd like to thank Dr. Deepak Yagnik and Dr. Agarwal for coming here. I'll request Dr. Dhwani to give mementos of appreciation to Dr. Deepak Yagnik and Dr. A.C. Agarwal. Thank you, Dr. Deepak. Thanks a lot, all of you. So now we'll start off with the last session of the day, which is on the pituitary disorders. I know it's been a long day, but this is going to be a case-based session, a very interesting session. And this will basically focus on the key aspect of pituitary disorders. Dr. Dhwani, you can invite the panelists, please.
Yes, so for the last session of the day, I would like to invite Dr. Rahul Jagedar sir, Dr. Vibha Yadav, Dr. Neha Agarwal, and Dr. Anshul to the dais, please.
So we have really honored to have all the faculty here. Dr. Saurabh somehow could not join for the session, so we've got Vibha who can join in, who's coming in instead of there. Dr. Rahul, we already have been introduced about Dr. Rahul, who is an eminent pediatric endocrinologist from Pune, Maharashtra, Bharati Vidyapeeth. Dr. Vibha is now Dr. Vibha and Dr. Neha both are part of Regency Health Endocrinology, Pediatric Endocrinology. Dr. Anshul Jain, Dr. Anshul Agarwal is a leading pediatric endocrinologist from Jhansi. He had done his training from AIMS Kochi, and he has been doing a lot in terms of diabetes in that region. And we are great to have him for the first time in this program. Welcome, Dr. Anshul. And Dr. Neha, we all are aware, she just delivered a talk, and she has been part of our Regency Center for Diabetes Endocrinology and Research. So this talk, I'm going to focus about 3 groups of disorders: multiple pituitary hormone deficiency, hyperprolactinemia, and AVP disorders. And we will mainly be focusing about the various case-based scenarios which are there in this perspective, which is there in that regards. So we will be focusing on these. Just share this. So when we talk about the hypothalamic pituitary thyroid and the end organ axis, we know that we have got a lot of hypothalamic hormones which are regulating the pituitary hormones, which are then regulating the end organ hormones. Now, generally, most of the hypothalamic hormones have a positive tone in terms of secretion, with the exception of dopamine, which is inhibiting the prolactin secretion. So in conditions where you have a transaction of the hypothalamic pituitary axis or a lesion which is suppressing that particular stalk, you would expect all the hormones to go down with the exception of prolactin. So prolactin is a wonderful marker of site of lesion in a hypothalamic pituitary defect that is there. There are also a lot of crosstalks which are happening. It's not just a simple talk. There is the crosstalk of cortisol, which is suppressing AVP. So if you have cortisol deficiency, you would have something like a SIADH-like picture, which may mask DI. Once you start steroids, you will again have a scenario of recurrence of DI in that perspective. And AVP, as we've discussed already, has a crosstalk with the secretion of cortisol. Now, as discussed, the prolactin level is something which will go up if you have a transaction. Now, the most common causes of pituitary abnormalities can either be congenital disorders. And when we talk about congenital disorders, the problem can start off right with proximal defects, where you have a craniofacial visual defects like HESX1, like LHX3, LHX4, where you will have eye problem, ear problem, face problems. Then you will have why only the pituitary is affected, like PROP1, POW1F1, and then individual disorders like TSH receptor, like LH beta, and all the problems which are there. Acquired causes include radiotherapy, and radiotherapy, the most sensitive is growth hormone, followed by TSH. LSFSH are less sensitive, and then finally you have the sensitivity of AVP, which is the least sensitive as far as radiotherapy is concerned. For immune damage, on the other hand, you have got a greater predilection of having a ACTH involvement in that regard. So now, if you have two or more involvement of the axis, you consider this to be a multiple pituitary hormone deficiency. The abnormalities, of course, you include assessment for growth hormone using a growth hormone stimulation test, a free T4 with a TSH, free T4 which is low, and the TSH which is less than 20, we consider it to be central hypothyroidism, prolactin deficiency, a low cortisol in the presence of hypoglycemia, hyponatremia, or ACTH stimulation, low estrogen, testosterone, and water deprivation will give you a clue. The management, of course, is to supplement different hormones, and there is a lot of interplay which we need to be aware of. So when we are giving growth hormone, we expect the cortisol metabolism to increase, and therefore you may precipitate a cortisol deficiency. So before you really start growth hormone, you exclude cortisol deficiency. You may also have an effect in terms of hypothyroidism. So you may unmask hypothyroidism. So get a FT4 done in a regular follow-up, and screening becomes important. Similarly, when you are treating somebody who has a multiple pituitary hormone deficiency with thyroxine, you expect an increased metabolism of cortisol resulting in precipitation of insufficiency, and that could be a problem. And that's why in central hypothyroidism, always check for cortisol level. When you give estrogen, you will increase the growth hormone requirement because of growth hormone resistance. You will increase TBG, increasing thyroid requirement. You will increase CBG, increasing the requirement. So now we'll go from the theory to the cases. A 12-year-old boy with lethargy, FT4 is low, and we are finding that the TSH is normal. So this clearly means it's a central hypothyroidism. Cortisol is low. LHFSH, everything is low. So you have a multiple pituitary hormone deficiency. The question is whether it is at the level of pituitary or hypothalamus. Dr. Rahul, what is your opinion and how we can localize that?
So you already explained in the beginning how you differentiate hypothalamus from pituitary lesions. Prolactin could be a drug of investigation which you could do because prolactin is under control of dopamine. And when you have a hypothalamic mass pressing upon it, you will have hyprolactin values. So prolactin could be used as a differentiating feature between hypothalamic and pituitary lesions. Low prolactin goes in favor of pituitary. High would be in favor of hypothalamic lesion.
So here the prolactin is 1.2. Yes. So this goes in favor of a pituitary lesion. So what messages will recommend, Dr. Rahul?
In a child with central hypothyroidism, you should look for MPHD. Prolactin would be able to differentiate between hypothalamic and pituitary lesions. So we would recommend to do a prolactin level to differentiate the two.
So I think that's a very, very important point. Check prolactin. The second case is a 1-week-old boy with seizures who has hypoglycemia, which is ketotic. So ketotic hypoglycemia, causing seizures, has low level of cortisol during hypoglycemia, low levels of growth hormone during hypoglycemia, has micropenis. So now we are giving a lot of clues that this is going towards a central sort of etiology. What eye sign can give you the diagnosis, Dr. Vibha?
So as we can see, there is a deficiency of cortisol growth hormone, so looking like a MPHD case, but the presentation is very early and associated with seizure. So this might be the genes which are responsible for the early development of the pituitary. And the eye sign, I would say we should look for the nystagmus and the blindness. There will be a roving nystagmus, and the most common possibility it could be a HESX1. So where there is a optic nerve dysplasia. So definitely when there is a case of multiple pituitary and presenting very early, so I think we should think of HESX1, SOX2, SOX3, LHX.
Yes, and in this case, if you find this eye sign, that will really go to a diagnosis. The point is to look at the specific eye sign. So there was a nystagmus and blindness. So this goes in favor of a HESX1 defect, and that becomes important. So your messages, Dr. Vibha?
So definitely when there is a multiple pituitary hormone deficiency, and if it is presenting with hypoglycemia, it will present with hypoglycemia along with the micropenis, or some will have like salt wasting type, low blood sugar. And if it is blindness is associated with multiple pituitary hormone deficiency, then we should think of the septic optic dysplasia where there is optic nerve hyperplasia.
Very important point raised by Dr. Vibha. 17-year-old girl who is a follow-up case of multiple pituitary hormone deficiency. She has been on growth hormone and thyroxine for a long time. And now she had delayed puberty and started on estradiol. She now complains to you of headache and lethargy, and a cortisol level which was done at 8 a.m. was found to be low. So there seems to be an evolving picture, Dr. Anshul, that we are seeing here. An MRI shows an enlarged pituitary. The radiologist had labeled as query, brain CNS lesion, hypothalamic lesion. Now, do you agree with this diagnosis that this long-standing MPHD is because of this brain tumor?
Of course. Of course not, sir. We have a case with multipituitary hormone deficiency. This patient is already on growth hormone and thyroxine. Now, on puberty, we are finding that he has been gotten delayed puberty. Now he is progressing to low cortisol levels. So he is evolving multipituitary hormone deficiency. Enlarged pituitary, we can see from this slide also that prop1 is being found with enlarged pituitary, and with time this enlargement might reduce also. It can wax and wane also. So but now at present finding, we can say it might be a prop1 mutation, and it is a evolving with multipituitary hormone deficiency. We need to do a cortisol replacement also.
I think that's a very, very important point Dr. Anshul raised, that all enlargement of pituitary doesn't mean that there is a tumor and you need to start surgery. This is such a long history. It cannot be a tumor for the last 15, 16 years in that regards. So this is clearly, as discussed, prop1 defect. So your message is, Dr. Anshul?
So enlarged pituitary has been seen with prop1. And now you have to see evolving hormone deficiency with every multipituitary hormone deficiency, and we should be very cautious. And any signs that we are getting, we should do a cortisol level. And this was one case of evolving hormone deficiency.
Thank you, Dr. Anshul. Very important. Now, Neha, we have a 17-year-old girl with lethargy, weakness, and amenorrhea. There is visual complaints which are there. She has got absolutely undetectable gonadotropin levels. Prolactin is slightly high at 60, and cortisol level is low. FT4 is low. So what are you thinking here?
And low pituitary hormones with borderline increased cortisol.
On.
Am I audible?
Yeah.
So given the clinical picture of a 17-year-old girl presenting with lethargy, weakness, amenorrhea, and visual complaints with biochemical picture suggestive of hypopituitarism, but borderline high prolactin, looking at the pituitary stalk becomes important. So a neuroimaging of the hypothalamic pituitary region should be asked for. So
if suppose we find a lesion, Neha, do you think it's a functional lesion or a non-functional lesion?
So it's a non-functional lesion since other hormones are suppressed.
Yeah. So this is the MRI finding, and you find this. How do you read this finding on MRI?
So this you can see there is a thick pituitary stalk given the age, adolescent female with pan-hypo picture with borderline high prolactin with thickened pituitary stalk, a possibility of autoimmune condition becomes more likely. And if the child has been in the early childhood age, LCH becomes a possibility. Looking at the skin and bone lesion is important. But since she's an adolescent female, an autoimmune condition should be looked into. If adult, a sarcoidosis or other possibilities into picture. Germinoma may present like this with DI also as a clinical picture.
So as Neha said, the classical presentation of autoimmune infundibulohypophysitis is headache, irritability. You will have weakness because of cortisol deficiency. As we said, autoimmunity, cortisol happens a bit early.
Yes.
Hypogonadotropic hypogonadism, mildly elevated prolactin. And these will be the features to go forward in that regard. Can you have DI in this situation? Can hypophysitis cause DI?
Yes, sir, it can cause.
So it is one of the important features to remember. So in pregnancy, we say that when you develop multiple pituitary hormone deficiency after pregnancy, this is Sheehan syndrome usually. But some of these patients have got a slightly different presentation of DI also. So they are actually autoimmune hypophysitis, whom we are labeling as Sheehan. So this can also have both anterior and posterior pituitary because this is infundibulohypophysitis, not just the pituitary involvement, but the infundibulum involvement also there. So what's the key messages, Neha?
Key messages in a case of multiple pituitary hormone deficiency, MRI becomes essential as it can help you look into the pituitary stalk on radiology. And this is the only condition which will be like autoimmune condition in adolescent female. MRI pituitary stalk thickening will be a clinical pointer.
Next case is a 15-year-old girl with headache. She was having a low-grade headache and suddenly there is a very severe headache that she had. When she came to the emergency, she is in a shock-like situation. There is hyponatremia, which is there. Cortisol is low, thyroid is low. So what do you think, Dr. Rahul, we should think and what should we do urgently in this scenario?
This child has a history of headache, which sudden worsening of the condition and comes in. So conditions like pituitary apoplexy could be considered here. This generally happens in patients who have infarct or hemorrhage in the brain or a non-symptomatic adenoma which worsens. That bleeding may cause pressure on the optic nerve, giving eye signs, and the sudden withdrawal of the hormonal secretions lead to shock-like features. So if something like this is seen in the history and we suspect this, then treatment with steroids becomes a emergency. So steroid treatment would be life-saving here, along with fluid balance to maintain the hemodynamic circulation, and electrolyte balance would be recommended strongly.
So very nicely put. So if you look at the pituitary anatomy, you know that the small point of lowest resistance is upwards. So if you have a slowly growing tumor, it will go up and then it will bulge like figure of 8 as what Neha was showing. But if you have a sudden increase in pituitary size, it will burst through the bones. It will go into the cavernous sinus. It will get 3rd, 4th and 6th nerve involvement. So ophthalmoplegia with shock. First thing is pituitary apoplexy. You may or may not have a history of earlier headache because that may be missed out. So again, very importantly, this is a scenario. So the messages that are there, Dr. Rahul.
Yeah, talk with ophthalmoplegia, think of apoplexy. It's a medical emergency, so use of steroids becomes most important. Yeah. And then fluid balance is
very, very important. 16-year-old girl with delayed puberty, height is 144, weight is 41, short stature. Low LH, low FSH, low estrogen, so hypogonadotropic hypogonadism, prolactin of 32, cortisol very, very low. So, Dr. Vibha, what do you think is happening here?
So here we can see that 16-year-old girl presented with delayed puberty, and she has a shorter height. She is not tall, and along with it, she has a hypogonadotropic hypogonadism, and with the low cortisol. And what we can see in the MRI, there is a lesion which is enhanced on the contrast. So definitely this lesion is possible for this multiple.
So this MPHD looks like a congenital or acquired MPHD to you?
So this is like presentation. No, sir. The height is 144, so it's not congenital. It is looking like a acquired.
Or a milder form of congenital, not a genetic form.
Yes, sir.
So you are seeing enhancement of a cystic lesion.
Yes.
Now it's a very, very characteristic radiological sign
of Rickets cyst.
Of Rickets cyst. So if you have an enhancing cyst in the pituitary, think of Rickets cyst presenting with multiple pituitary hormone deficiency. And now we have a 16-year-old girl with MPHD who has received growth hormone on thyroxine and estrogen, complains of lethargy and weakness, Cortisol was found to be normal. Somebody thought that we should do a cortisol. It was normal. They gave us inaxin. It was again normal. But after a few days, when she developed fever, she went into shock with hyponatremia. So, Dr. Anshul, what do you think was wrong? Either the girl developed adrenal insufficiency immediately, or the testing was wrong, the report was wrong. What do you think there?
So, right, sir, this is quite an interesting case also. And as sir was also saying about the interplay of the hormone, this is what playing in this case. As we can see, that patient is already a known case of multipituitary hormone deficiency. Now she has typical history of shock, which is suggesting of hypocortisolism. But we can see the lab values, they are not suggesting so. It might be the case because patient is on estrogen, and estrogen increases the cortisol binding globulin, and hence you might find falsely elevated cortisol levels because of the high CBG. So this is what we have to look for, and look for the clinical signs. And this is what we are taught also, that clinical signs should be treated and not the lab values. So this is this which we have seen. And now next thing is also that growth hormone treatment per se can also precipitate adrenal insufficiency. So once the patient is started on growth hormone, adrenal insufficiency get masked because of the increased cortisol metabolism, and hence you might find adrenal insufficiency feature also.
Thanks a lot, Dr. Anshul. Very important messages out there. 4-year-old boy with MPHD on thyroxine 50 started on growth hormone, and now you find he was doing very fine. Now suddenly the FT4 has fallen down. So what has gone wrong, Neha?
So this is another case of crosstalk in between the pituitary hormones. So once the child is started on growth hormone, it increases the metabolism of other hormone. As in the last case we saw, the cortisol was not features of adrenal insufficiency was there. And in this case, there is increased metabolism of thyroxine. So there is a decrease in the free T4 level. So whenever a child is put on growth hormone, we need to revisit the thyroxine doses so that there is no feature of hypothyroidism. So GH therapy unmarks hypothyroidism, which should be looked into during follow-up.
So the big message of this part of the talk is that it's not only about diagnosing, treatment has got a lot of implications and interplay. Moving on to hyperprolactinemia, which is an interesting, important finding. Now, hyperprolactinemia, we are most worried about a tumor which is producing prolactin. Here, the levels are extremely high, more than 200. If you have a stalk lesion typically, or a non-functional adenoma, the levels hardly go above 100. They are 50, 60, that sort of a level. If you have a hypothalamic lesion or other lesions, you will have less than 100 definitely will be the cutoff. Pregnancy is something which is often missed, and I still see patients with pregnancy who come to us with hyperprolactinemia. This is something which is interesting. Pregnancy levels will be more than 400. So the most common cause of secondary amenorrhea is pregnancy. The most common cause of hyperprolactinemia probably will be pregnancy, but people still miss out and they do prolactin before doing a UPT. That becomes important. Drugs, of course, are very important. Some drugs like levosulpride, risperidone can cause prolactin to go above 200. Hypothyroidism can cause 50 to 100 sort of a level. Liver disease, kidney disease by around 20 to 50. So depending upon the level of elevation, you may know what is the possible cause of hyperprolactinemia. We discussed in the hormone diagnostic that there could be issues where you have high prolactin without symptoms, which is macroprolactin. And you will have situations where you have normal prolactin with symptoms, which is a hook effect, in which you will do a dilutional study. Now, very important issue is whether it's a prolactinoma versus a non-functional lesion. Prolactin will be much higher in a prolactinoma. Size may be variable, while macroadenoma will be much bigger. Prolactin will be less than 100. And as I said, if the size is less than 10, you expect levels to be less than 200, 10 to 20 around 1000. But if the lesion is above 20, your levels will be more than 1000. So if you have a big lesion with a prolactin of 80, do not think that this is a functional lesion unless you have a hook effect, which is less common with newer assays in that perspective. Some situations you may have large lesion with lower levels if it's a predominantly cystic lesion. If it's undifferentiated, hook effect, or a non-functional lesion. So we'll start off with the first case, Dr. Rahul, 14-year-old boy with gynecomastia. He has some breast development. He's pubertal. His LHFSH tests are in the pubertal range. Prolactin is 120. So do you think this prolactin is causing this problem? MRI was done, which was normal.
No, it doesn't seem to be that way because the prolactin levels could be falsely high.
Yeah.
We already seen this case in one of your talks before this. And like we already said, prolactin levels prolactin basically is a 20 kilodalton molecule which is attached to IgG and can cause 60 kilodalton called as big prolactin or 150 called as macroprolactin. Now, many labs cannot differentiate the three and report prolactin levels as high, which many times lead to unreasonable investigations and management. So the ideal way would be to do a chromatography, which is not available at many places. You would not have the finances to do that. So the new method of pegylation can be done, where there is a dilution method. I'm not going to get details about that. A cutoff of 40 is considered, and it is helped to differentiate macroprolactinemia from hyperprolactin.
So this is again a discordance between bioactivity and immunoactivity. So this is something you need to be very much aware of. And in this scenario, if the child is asymptomatic, don't worry about this prolactin levels. Get a pegylated sample done in that regards. 13-year-old girl with headache and visual complaints, prolactin is 60. So Vibha, this is the sort of a brain that you're seeing.
So in this, we have a 13-year-old girl with headache and visual complaints. And if we see the prolactin levels, that is 60. And if we look into the MRI picture, which is showing that the whole pituitary is involved. So
do you think this is a tumor?
So this is not a tumor. This is just a hyperplasia of the pituitary. So definitely jumping into a diagnosis of prolactinoma, we should first do the anthropometry and head-to-toe examination, whether we find some clues regarding the.
So this is the case which typically goes to a neurosurgeon or a neurologist. And some of them who may actually look at the child and say that, okay, child is short, child has coarse faces, has severely coarse skin, they may pick up, but otherwise sometimes they will post also. So this is a diffuse pituitary hyperplasia. This is not really a tumor in that regards. So as I said, hypothyroidism, and you have very nicely said that. Now this girl had a severe hypothyroidism. How will you start treatment in this case?
So here the TSH level is very high and FT4 is very low. So we have to start the thyroxine level with the low dose, and we gradually increase after 2 weeks and then 2 weeks.
If you start at a high dose, what will happen?
It will lead to the pituitary apoplexy.
Yes, this is a big thing. So sudden changes, if you give cabergoline at a high dose for hyperprolactinemia, if you give GnRH analog. So these are all known factors for the apoplexy. So as very nicely said, we started a very, very low dose in this scenario, and this will improve with treatment in that regard. So FT4 TSH is essential in anybody with hyperprolactinemia. Don't confuse pituitary hyperplasia to a mass. 16-year-old girl with galactorrhea, prolactin is only 34, but she has other symptoms. So somebody got an MRI and saw this figure of 8 snowman appearance, a large macroadenoma. So Dr. Anshul, do you think this is a non-functional lesion or a functional lesion with, I don't know why this is, how will you explain this?
So again, a case where we are finding clinical finding that patient is of course having galactorrhea. We are finding a huge mass in pituitary. So of course the lab value of 34 of prolactin is not going with the clinical finding. Now we see the one effect of prolactin. One thing is we have to do a sampling within 15 minutes or 30 minutes for prolactin, just to, because there is pulses of prolactin which are going on. And next is the hook effect, which is quite commonly seen, which can be prevented by just doing a dilution by 1:100 dilution. This hook effect is what? Once the analyte concentration increase to such an extent that the assays which we are using, that is like a sandwich assays, these two antibodies, capture and detection antibody, these analyte get attached, multiple analytes get attached to it, and you get falsely low level. So just dilution, this method, diluting this analyte concentration will give you a proper effect. This is what hook effect is, very common in endocrinology. This need to be ruled out.
So very clearly, if you are having too much of bioactivity and very little of immunoreactivity, think of hook effect, opposite of the macroprolactin we talked about. 17-year-old girl with amenorrhea for 3 months, stage 4 breast, stage 4 pubic hair, no LH, no FSH, prolactin is 500. Neha, you want more?
This is classical case of secondary amenorrhea with a very high prolactin. So we all know the answer. Think of pregnancy and get a UPT
Yeah, the
test.
answer comes from the estrogen level. But still, maybe every month or 2 months, I get patients who are not 17, maybe 18, 20, 25, who are done all the workup and they come to us with low LH, low FSH, and estrogen is such high. So this, of course, is a pregnancy in this regard. So always, most common cause as we discussed, you have to think of pregnancy before you do anything. Now, in this girl, 17-year-old girl, will you say you do a UPT?
Beta HCG levels.
So never say that you get a urine pregnancy test done, because that will have huge implications in an unmarried situation. Better you just write HCG, because that will be a safe way, because otherwise there will be a lot of social issues which will come up in that picture. So key message, of course, HCG before MRI with high prolactin. Now, 14-year-old boy with headache and prolactin is 80, and we are actually seeing a lesion which is coming. Now, the issue is the lesion coming from the pituitary going up, or is it from above going down? So it's like a supracellular lesion or a cellular lesion which is going up. Dr. Rahul, what's your views on that?
The size of the lesion would matter. So
yeah, it's a big lesion. If you see it's coming from up there,
yeah,
till that point.
The prolactin levels also could tell us if it is a macro or microadenoma. So basically, based on the size, the prolactin level, so more than 100 would go in favor of prolactinemia.
Yeah.
Besides, there could be a variable size. Non-functional adenoma would have prolactin levels less than 100 generally, and a huge size. It's more symptomatic in the macroadenoma, and less symptoms would be seen in a child with prolactinoma.
So this is classically a case of non-functional lesion, most likely in that regard. So again, if you have a large mass, but prolactin is less than 100, no galacturia. Now, if you had galacturia, we'll think of hook effect and everything else. So this is mostly a supracellular lesion. So we have talked about two important topics. We have a final topic of AVP disorders, and diabetes insipidus, we all know, could be a central problem in which you have a problem in the hypothalamus. Remember, this is a hypothalamic, not a pituitary problem. So if you have a lesion above the median eminence, then only you will have DI. Pure pituitary lesion will not have DI because 5% neurons terminate in the median eminence. So your pituitary may go off, still you will not develop DI. So it's a hypothalamic infundibular issue rather than a pituitary issue. So congenital malformation, cysts, other malformations, and acquired, very importantly, the term idiopathic central DI is something which you should take with loads of salt, not a pinch of salt, loads of salt, because that could be the only sign of a germinoma. You should not want to miss that. You can also have histiocytosis, sarcoidosis, and other parameters there. Nephrogenic DI, most commonly that we encounter, is typically a child who comes to you at 6 months to 12 months of age. We had a very good presentation today on that. Dr. Vidhu talked about 6 to 12 months of age with dehydration, fever. Typically, you find hypernatremia. And in that case, if you do a water deprivation test, you're going to have a definite medical legal suit coming on in that perspective. So if you have hypernatremia, there is no need of doing any water deprivation test. That's something which I actually reviewed a paper in which they said that we did a water deprivation test. So they had the audacity to send a paper also. So hypernatremia they did. Other forms are rarer in that perspective. So if you have polyuria, of course, if sodium is not high, you do a water deprivation test. If you have a dilute urine, basically, if you have a concentrated serum and you have a dilute urine, that is diabetes insipidus, basically. So if your urinary osmolarity is more than 800, this is not DI. 300 to 800 may be partial DI, and do a water deprivation test. As I said, central DI diagnosis is not the end of the story. Do an MRA and keep on repeating 6 monthly for 2 years and then yearly for 5 years, because you may miss germinomas in this case. So we'll start off with the first case, 10-year-old girl with craniopharyngioma, post-neurosurgery, has polyuria and was advised vasopressin infusion. Now you expect this within a few hours, develop seizures and hyponatremia. So Dr. Vibha, what are you thinking of?
So it is well known that after neurosurgery, if you look into the patient has developed polyuria right after the neurosurgery. So it is well known that after neurosurgery, there is a triple phase response, which is like in the early few hours, the patient will present with the DI, which is due to the neuronal shock that is due to the surgery. And after that, the neurons will release AVP, which will cause SIADH phase. And then when the neurons degenerate, it will cause the permanent DI. So in this case, when the vasopressin is done, I think it is given during the SIDH phase that has worsened this situation. And the treatment options that we have for the acute central DI, one is either we treat it with the fluid alone, or which required the maintenance fluid of 40 ml per meter square, which is N/4 solution. And here we have to replace the urine output with 5% dextrose, and it is done when this urine output is more than 40 ml per unit per meter square per hour. And there is a ceiling, like we should not never increase, we should not cross the limit of 120 ml per meter square of the fluid. But the main drawback, or we'll say that the main risk here is the development of
So do you
dehydration.
worry more about dehydration or cerebral edema because of hyponatremia? What is more dangerous?
So cerebral edema is more dangerous.
So as you discussed, it's the fluid management which is always better. If you want to give vasopressin infusion, give it a very, very low dose at around 30% of the basic dose. Don't give it more than that. Never give Minerin. If you give the desmopressin, it's going to act for 12 hours. They will go into crash. And then I have given sodium chloride infusion for many times to get it back. 3% NaCl infusion to get it back. So never ever give desmopressin. If at all you want, give a very small dose of AVP infusion, or better to manage the fluid alone, because you will not miss that SIADH phase. And remember, all polyurias are not DI. It may be part of cerebral salt wasting. It may be because too much fluid being given. So that also becomes important. So in this case, you should avoid AVP as you have mentioned. Now, 1 year later, he is on DDAVP. Now the urine output suddenly decreases. He's become better. Parents are happy. And now he develops hyponatremia. What do you think is happening here?
If the patient develops like lethargy, weakness like symptoms in the along with the DI, so it could be, and serum sodium is low, so it could be due to the cortisol deficiency that has caused the lethargy and weakness. And when there is a cortisol deficiency, it will unmask the DI, and that's why the patient has presented with the
cortisol deficiency. We said it causes SIADH. So DI minus SIADH is zero. So you will basically have a phenomena basically in which you will have a masking of DI. Once you treat, they will again develop DI. So that is the way forward. 3-month-old girl with dehydration and dovey skin, sodium is 162, a bit like the case which we're discussing in the morning, was advised water deprivation test and developed seizures and intraventricular hemorrhage. So Dr. Anshul, I think we've discussed that. Maybe you can reiterate the point on that.
Right, sir. So water deprivation test, as it was not needed in this case. In endocrinology, what we do is, if the hormone is less, we do stimulation test. If hormones are more, we do suppression of test. Now, water deprivation is just like a stimulative test. Sodium is high. It will ultimately stimulate the ADH more. And so no need to doing a further stimulation test with water deprivation, which has further might have increased the sodium level and led to seizures. So there was no need for water deprivation.
So if your sodium is above 146, osmolality above 300, you don't need to do a water deprivation. I think that's a very big message. And like you were saying that we could not do it, it's better that you did not do it. I think that was the right strategy on that. So this was water deprivation test should definitely be avoided in this scenario. Now, 12-year-old boy, central DI for 2 years, normal MRI on vasopressin, now complains of seizures and headaches. So I thought hyponatremia could be developed. Sodium is normal. Dr. Neha, what will you do now?
So, as you have already pointed out in the previous slide, so if there is a central DI with normal neuroradiology, then a possibility of germinoma should always be kept in mind. And in a child like this who is developing seizures or headache or neurological manifestations in follow-up, a repeat MRI as per the algorithm is mandated in 6-monthly or 2-yearly follow-up. So if we go and look at the algorithm for a central DI neuroimaging, if it is normal initially, then a repeat MRI is required 6-monthly for the initial 2 years. But if at presentation there is stalk thickening, then think of LCH and autoimmunity. For LCH, skeletal survey is required, where if it is abnormal, then a biopsy is done to confirm Langerhans cell histiocytosis. If normal, then again germinoma becomes a possibility and a repeat or sequential MRI is needed.
I think that's a big message out there. So if you have stalk thickening, you can have either hypophysitis or a germinoma. If on follow-up your anterior pituitary is shrinking, that is hypophysitis. If it is enlarging, that is germinoma. So that is something to look at. Now, 3-year-old boy with polyuria, sodium is 154. There is low urinary osmolality. So we already know this is diabetes insipidus. He has a rash. What will be the simple test which will give you the diagnosis, Dr. Rahul, in this case?
A central DI with rash could be something like histiocytosis. Rarely it can be sarcoidosis, but mostly histiocytosis. A simple X-ray of the skull could give us punched out lesions. If you have the facilities, MRI could be done to look at the pituitary stalk, but a simple X-ray would do the needful.
And you see the rash, the seborrhea, the hepatomegaly, And if you press the particular area, you will see bony defect like ping pong compression, and you will get that. That is histiocytosis. Now he's planned for chemotherapy, advised hydration for which a lot of fluid is to be given.
Yes.
But then he develops respiratory distress and pulmonary edema. So what could have been done in this case to avoid this?
We could have given the fluids very slowly, like we said in the last case.
Yeah.
This is to basically tight, and obviously would require ABP infusion, because desmopressin, like we said, would not be useful here and should not be given. So titration of the fluid along with ABP in a low dose, so as to maintain the urinary output of about 2 to 4 ml per kg per hour is what we look at, so as to reduce the complication and give the better outcome.
So you will avoid the DDAVP 1 day before, and then you will let him diurese, and then if required, give a low dose of vasopressin infusion. That is how you should manage in that perspective. Now, the opposite of DI is, of course, SIADH, which basically mean that you have got a dilute blood and a concentrated urine. So we expect that if your sodium is low, your urinary sodium should also be low. So if your sodium is below 130, your urinary osmolality should be less than 100. If it's more than 100, it is SIADH. And this is something you need to really worry about from that perspective. So dilute serum with concentrated urine is SIADH. But remember, you have to exclude hypothyroidism, cortisol deficiency, diuretic use, and all the other factors which are very, very important. And hypovolemia will shift the curve toward the left side. So that should also not be there in this perspective. So that is important in that regard. So now we have a 14-year-old boy with drowsiness, euvolemic, and has hyponatremia. So euvolemic hyponatremia and urinary sodium is 100. So urinary osmolality is 300. So it's very, very high. Yes. What do you think,
So
Vibha?
the status of the this boy is euvolemic, and we can see that the urine sodium is more than 25, which is like more sodium is being excreted through the urine, and the urine osmolality is on the higher side. So definitely before going to another diagnosis, we should rule out whether there is a hypothyroidism or cortisol deficiency. Before ruling out this condition, we should evaluate further.
So he was diagnosed as SIADH with fluid restriction and suddenly went into a lot of problems. And in this regard, as you said nicely, we should have excluded cortisol deficiency, which was found to be there, and hypothyroidism, MPHD should be ruled out in this scenario. So we should rule out that. 11-year-old boy with traumatic brain injury. Now, this is a common scenario, admitted in the ICU, had improvement, and now seizures on day 2, has hyponatremia, and the treating physician are asking whether this is SIADH or salt wasting. This is an important question which often comes to our mind. So Dr. Anshul, what is your thoughts about that? How do you differentiate?
Right. So after an ICU admission, after a traumatic brain injury, these are the two major diagnoses for hyponatremia. After we have ruled out, of course, cortisol deficiency and hypothyroidism, that is SIADH and salt wasting. SIADH we all know very well, but salt wasting is generally an underlooked problem. It's just in what happen is there is more of salt wasting. You will get more sodium out from the urine. It will cause hypotonic hyponatremia. The patient will be dehydrated and you need to replace fluids and you need to replace with the saline also. So treatment with both these scenarios are totally different. In SIADH, you need fluid restriction, but salt wasting, you need the fluid replacement. So it's very important to distinguish between these two. So these are the criteria. Specific good indicator would be low uric acid would be found in SIADH, and patient will be euvolemic, but hypovolemic in salt wasting.
So I think that's a very important message. And SIADH is usually more common in this scenario as compared to the salt wasting. The uric acid was low, labeled as SIADH. So that is an important thing. 13-year-old girl with tubercular meningitis, Sneha, drowsiness and hyponatremia. Urinary osmolality is 130. So dilute blood, but concentrated urine for the level of sodium. Normal thyroid and cortisol, so that's out. Was advised tolvaptan. Do you agree?
So based on the clinical and biochemical parameters, a possibility of SIADH was definitely there. Tolvaptan, which is an antagonist of the V2 receptor, should be used cautiously, especially in the acute cases. And this was not a correct picture to be used tolvaptan here. So tolvaptan should have been avoided here.
In children, generally we avoid because there will be a rapid rise in sodium, and that can cause a lot of problems because of the chronic nature of hyponatremia. If it's acute, then you can have a different scenario. So key message is that we should have a gradual correction of hyponatremia, avoid vaptins in this scenario. So I think with that, we have come to the end of this marathon day, which started probably somewhere around 11 o'clock or even before that. So thanks all of you for this patient hearing. I think all the audience is still there. Thank Dr. Rahul, Dr. Vibha, Dr. Anshul, and Dr. Neha. I'll request Dhwani to give a memento to Dr. Anshul. Yeah. Okay, thank you. So I think we will close the session now, and we'll close the online link also. It's been going on for a long time. And we'll join again very early tomorrow at 8 o'clock India's time. And there are a lot of interesting sessions tomorrow as well.